A very good morning to one and all who have reached here on time. And we're ready to we're very excited to kickstart this ASCENT program. Firstly, welcome to Soin Hospital. This has been a wonderful place for a lot of us to learn and work. And I'm sure many of you are visiting here for the first time. I am certain you're going to enjoy the experience here. Dr. Renuka Pradu, our head of department, along with the entire department, has arranged an entire feast of academic program when it comes to rhinology, endoscopic sinus, as well as skull-base surgery over the next 2 days. And I'm sure you're going to enjoy that. We're expecting our international guest faculty to also join us very soon. We're going to kickstart this program with live surgery. And the first case that is lined up is angiofibroma surgery, which is also having an intracranial extension. And that will be followed by Dr. Janki demonstrating an inverting papilloma from Trichy. So I would also request all the delegates who are outside the hall to come inside. You know, an event of this magnitude, getting almost 200 plus people into the city of Mumbai and across into this auditorium is impossible without an active support of a leading pharma like Alkem. And we're very grateful that they have an unrestricted educational grant when it comes to supporting an activity like this. And the hospitality that you enjoy today is largely due to their endeavor with us. And on that note, I would like to invite Mr. Rana Bose, he is the Associate Vice President of Alkem Nexa Division, to also please welcome the delegates.
First of all, very good morning to all delegates, and thank you, Dr. Kshitij. It's a great privilege on behalf of Alkem to be partnering the entire team in actually giving you something which is one of the most aspirational thing as far as Alkem is concerned, and one of the most academically oriented program, because we've got hundreds of programs in today's scenario. But this is absolutely an academic program which has interested most of you. That's why most of the people are on time here. So very good morning, first of all, to all respected doctors, esteemed dignitaries, Dr. Renuka Pradu, our Chief Course Director, world-renowned speakers, Dr. Paulo Castelnova and Apostolos Kaligiotis, Dr. Mario Turi Zenoni, and all dear delegates who have actually graced the occasion. Myself, Rana Bose, on behalf of the entire Alkem family, welcome you all on one of the most prestigious scientific feast, ASCENT, Advanced Surgery Conclave of ENT, spanned across 2 days at Mumbai. We at Alkem are extremely honored and feel privileged to have you as our guest at Soin Hospital. At the outset, let me thank each one of you for taking time from your busy schedule to attend this scientific feast. ASCENT is a scientific program enriched by a wealth of scientific knowledge from a galaxy of luminaries who will share with us the latest advances in the field of otorhinolaryngology. With every year, the content has become more richer and with all relevance to your clinical practice. This year, the event becomes much sought after due to the richer scientific content laid down across 2 days, covering live surgeries by Dr. Renuka from Soin Hospital and another surgery by renowned Dr. Jankiram from Trichy, followed by a session from world-renowned ENT surgeon Dr. Paulo Castelnova. His team, Dr. Apostolos Kaligiotis, Dr. Mario Turi Zenoni, will perform cadaveric dissection right in front of you. Alkem, since its inception way back in 1973, has grown leaps and bounds with the vision to achieve value-driven leadership through consistent hard work in developing enduring quality products marked by exceptional service. With an illustrious journey of nearing 5 decades, Alchem Laboratories, currently the fourth largest pharmaceutical company in India, is having presence in over 50 countries with globally approved state-of-the-art manufacturing facilities backed by cutting-edge R&D. Our portfolio includes iconic brands like Switch CV, Prolastin M, A to Z, which features among top brands of the Indian pharma market. For over a decade, our dominance in anti-infective segment has remained unchallenged. My sincere thanks to all panelists and our esteemed delegates for taking time out from their busy schedule and making our ASCENT extremely successful. At the last, but definitely not the least, I extend my warmest gratitude to each one of you for being a part of ASCENT and look forward for a mutually beneficial relationship in the times to come. Thank you very much. Thank you. Thanks a lot. Thank you very much. May I request Dr. Kshitij once again? Right. Fine. To come and grace and start the occasion. Thank you very much.
Thank you, Mr. Rana, for those lovely introductory words. I think as he's already introduced you the program. He's already introduced to you the program that's about to unfold today. The next 2 days actually has been the culmination of the last almost 2 months of hard work, including giving a very fine attention to detail. And that is one of the features of what our team specializes in doing, as you'd realize over the next 2 days. I think we're ready for transmission 2. The first case has been taken up. It's angiofibroma. And are we connected to the OT? We shall have someone take you through the history and the CT scan findings. The case has already been started in the interest of time because we're transmitting 9 to 12. So first few basic steps of endoscopy have been done. And I think we will catch up from maybe ethmoidectomy or just after that. The operating surgeons are going to be Dr. Renuka Bradu madam, Dr. Anaga Joshi madam, and I think the assistants are going to be Dr. Shivali Patekar, Dr. Pushkar Kulkarni, and Dr. Shrekha. Ma'am, you're online. We're with you and the CT scans.
Hey everyone, Kshitij, can you hear me?
Loud and clear.
Okay. So good morning to all the delegates. I will be expecting Dr. Mario Turi Zanoni and Dr. Apostolos Karlikiotis to join us shortly. I am very happy that we have a very large response to our ASCENT and I look forward to 2 days of intensive scientific program so that you go home happier and hopefully a little wiser. I would like to thank Mr. Rana Bose and his entire team, Mr. Vivek and his entire team from Alchem for their absolutely unrestricted educational grant in order to make this a success. I'd also like to thank Carl Stores India Limited and Medtronic for their technical support. So let's begin straight away. We'll go over the scans of the patient and just so that we have an idea of what kind of tumor we are dealing with. So these are post-contrast CT scans. These are the coronal cuts.
Yeah, we're with you.
Zoom in, please. Zoom in to here.
Yeah, now it's good.
Yeah. So the initial cuts are unremarkable. We're looking at the soft tissue cuts first. So that's the sequence in which we see first the soft tissue contrast and cuts of the CT scan, then the bony cuts of the CT scan, and then the MRI. So nothing of note here. As you go further behind, you start seeing the haziness in the nasal cavity, which is probably a little bit of secretions. And then as you go posteriorly further, you'll start seeing the enhancement of the tumor. And still further, and you can see it's a large tumor in the nasal cavity, completely filling the nasal cavity, strongly enhancing. And at this point, you can see that besides being in the nasal cavity, it is already in the maxillary sinus. So part of this tumor has actually gone into the maxillary sinus. Erosion of the posterior wall of the maxillary sinus and involvement of the maxillary sinus itself is not very common. Usually there's just anterior bowing and the maxillary sinus is contracted, but not actually the tumor sitting inside the maxillary sinus. This is, you can see the dumbbell shape appearing. And then you can see that the sphenopalatine foramen, this is the sphenopalatine foramen on the normal side. Kshitij, can you hear me and see it properly, whatever I'm talking?
Yes, we're with you.
Okay, so this is the sphenopalatine foramen on the normal side. And you can see it is widened. And you can see the tumor go from the nasopharynx, from the nose into the pterygopalatine fossa through the sphenopalatine foramen. And you can now see it appearing more in the infratemporal fossa.
Yes.
As you go further behind, you can see that there is tumor in the sphenoid sinus. It has gone through the base of the sphenoid, which is usually what happens. The angiofibra erodes the base of the sphenoid and not through the anterior wall. And you can see it occupying the left sphenoid sinus. And as we go further, the sphenoid component increases. And as you can see, the infratemporal fossa component also increases. And there on the lateral aspect of it, you can see the maxillary artery. This is the inferior orbital fissure, which this scan is a little earlier than the MRI. I'll show you the MRI. But you can see that there is some haziness. And then if you see, this is the normal cavernous sinus and this is widened. So you can make out that there is something happening in the cavernous sinus. As we go further behind, we look at the pterygoid base. The pterygoid base has come into view, and you can see in the pterygoid base some enhancement compared to this pterygoid base. And as we go further, you will see this better on bony, but you can see that the pterygoid base is eroded. There is contrast enhancing tumor within it as compared to this, but the greater wing of the sphenoid is not involved so much. So sometimes these two areas, we'll see that on bony, they can be splayed apart and you can have extensive tumor going into the greater wing of the sphenoid. As we go posteriorly, we see the sphenoid sinus, you can see the carotid here on either side. It starts here. You can see this is the cellar part of the carotid. And as you go, this is the cellar part. This is the paraclinoidal part. And as you can further behind, you can see the carotid turn and become subarachnoid and then divide into its two branches. So that is what you can see on the CT scan. Let's look at the axials first. We start here. Kshitij, have we gone over the history of the patient? Not yet, no?
No, not yet. We can see it's a 12-year-old male child on the CT. We don't have the rest of the history.
Why don't you just put on the PPT and show them before I go into the axials?
Sure. So as you can read with me, a 12-year-old male child, chief complaints with left-sided nasal blockage and bleeding for the last 4 months. In the nose, you can see secretions and a fleshy pink mass in the left-sided cavity. The cold spatula test, air blast was reduced on the left side. He did come in with a CTPNS, which we have repeated, and we have done a contrast enhanced MRI for the reason that you saw the extension on the CT. We embolized this patient this Wednesday morning using PVA particles, and there was significant, that's 85% reduction in the tumor blush, which is a good thing. And a BOT has been performed. The reason being, it is, as Madam showed, it's close to the carotid, though it's not showing involvement. But yet it's a good idea to have a BOT so you have an idea of what is the cross flow. This is the JNA grid, and this has been devised by Renuka Madam. If you haven't yet seen it, it's also available on YouTube. We use this grid extensively in every patient, and the reason is to look to communicate with corresponding surgeons as well as for a later prognostication. The color coding is what she's come up with respect to what is safer a little. So light green, dark green, orange, so be guarded, and red, which is significantly may have a chance of recurrence or residual tumor. This patient falls in the red zone. Reason being, so again, the residents have marked the grid, and as you see, it's something which is very easy to use for anybody who has a basic reading of a CT scan. It's involving the nasal cavity, maxillosinus, sphenoid, nasopharynx. So all four in the nose are involved. Lateral spread to the PPF, ITF plus, because it's extending a little inferiorly, not yet to the parapharyngeal or temporal fossa. Inferior orbital fissure is involved, so the dark green is already there, but it also extends through the inferior orbital fissure up to the superior orbital fissure. The pterygoid fossa is not involved, so it's not marked over here. The marrow of the Vidian canal is involved. Greater wing of sphenoid is not, so that makes it an orange zone. What makes it a red zone is because it's intracranial, spreading through the orbit, not through the other areas, but through the orbit, and it is abutting the paracellular, not encasing, but so A is for carotid abutment, E is encasement, which becomes a gray zone because there are certain tumor types, how they behave, but this is abutting the carotid, so it's a red zone tumor. We are back with the CT scans, ma'am. You can take us through the axials.
Yeah, so these are the axials. You can see the circle of Willis. I don't know whether it was mentioned, but we did a balloon occlusion test on this patient, and he doesn't have collateral supply, which means that we can't afford to coil or close off this carotid. And therefore, we'll have to be very careful while dealing with the cavernous sinus component and a little conservative because we know that there's no contralateral supply. So what we do in consent is, because this is the case, if there's contralateral supply, then we are not too worried. But because if the contralateral supply is not there, then we take consent that at any given point, if we feel that the carotid is at risk, we will cut the tumor there and then send that part of the tumor, intracranial part of the tumor, for gamma knife. Or we will just watch and wait. So this is one thing which has been explained to the patient's father before we start this surgery, primarily because the balloon occlusion test, the patient has failed the balloon occlusion test.
Right.
So let's go to the axial. That's the circle of Willis. And as we go further behind, we can see the orbit first on either side. The ethmoids are clear. And then we start seeing the component in the sphenoid sinus. And as we go further, can you see this is the inferior orbital fissure?
Yes, on the normal side.
That's the normal side. And look at what has happened to the inferior orbital fissure on the disease side.
Yeah.
Okay, so it is widened and it has enhancement within it. So we now know, though the coronals are not showing it that well, probably the phase difference, and therefore you can see. So therefore you can see that the inferior orbital fissure is involved.
Yes.
Now, as you go further behind, you can see that, we're coming, as we come further inferiorly, we can see here, this is the normal sphenopalatine foramen, the normal pterygopalatine fossa, and the normal infratemporal fossa. You can see here that the sphenopalatine foramen is widened. That's the infratemporal fossa component. And as we go further, you can see the Holman-Miller sign bowing of the maxillosinus wall anteriorly. In the bony windows, we'll see whether the posterior maxillosinus wall is intact or not. This is the infratemporal portion. And as we go further, we see that it is going fairly low. It's not the Holman-Miller sign is seen, but the Hunduza sign, where there's widening of the maxillomandibular distance, is not there.
Correct.
That's about it. This is the part in the nasopharynx. And in the nasopharynx, there seems to be some amount of space between the posterior wall of the nasopharynx and the tumor.
Yeah, okay, sure. You're just blocking the scan, ma'am, a little. Yeah,
Oh,
we can
okay.
now see it.
Okay.
Yeah.
So that is, did you get it from here?
Yes, we were with you
Okay.
apart from the last nasopharynx bit. We've got the
Okay.
rest. Yeah.
So this is the part in the nasopharynx. It seems at least the inferior part. Superiorly, near the base sphenoid, near the roof of the posterior choana, it is always attached to the nasopharynx with quite dense adhesions.
Yes.
Okay, we can take the MRIs now. On the sagittal section, you can see basically the Holman-Miller sign and the sphenoid extension from the inferior thing. This is the part, there's a large amount in the nasopharynx.
Yes.
And like I said, it will be adherent here. It may not be adherent inferiorly, as we've seen.
Yeah.
Okay, take them off. Take it off. Put up the bony windows. Okay. In the bony windows, we are actually looking only for the bone and for landmarks. We're not looking at the tumor itself or the extent or spread that we've already discussed. So this is the part in the nasal cavity. You can see that the medial wall of the maxilla-sinus is intact anteriorly, but as you go posterior, you see the sphenopalatine foramen is widened, and you can see that the tooth root is coming quite high up because he's a 12-year-old boy. So that is one thing we have to remember, that the tooth root will be higher up, and we need to take care of that. As we go further behind, you can see that this spike of bone here is, although the sphenopalatine foramen is widened, the spike of bone is here. We may need to take it out, depending on how we find the situation. So a lot of decisions about what to remove, what not to remove to access the tumor depends on what we find intraoperatively. But this is possibly one thing that we will remove. This is going further back. I want you to see, I didn't. So I'll show you that. So what we need to do is, you see, this is the pterygoid base. There's the normal pterygoid base, the Vidian canal, and the foramen rotundum. And as we go behind, we will see that the pterygoid base is eroded. It's eroded here, but the greater wing of the sphenoid is not splayed apart.
Yes.
Okay, the greater wing of the sphenoid is not splayed apart, but it is eroded near the Vidian canal. The foramen rotundum is not involved, as you can see. So the Vidian canal is involved. Part of the pterygoid base is involved. And so that's what we are seeing on bony coronals. On bony axials, the other thing we look for is on coronals also is that the two pterygoid plates, the medial and lateral pterygoid plate, we look whether they're splayed apart. And on soft tissue, which I forgot to mention, is that we look for any enhancement in the pterygoid fossa, which lies behind the pterygoid plates. In this particular patient, it's not there. And so we will not be having to go into the pterygoid fossa at all. Keep those, give me the CT contrast again, coronal. Put that up here again. And you can see here, this is the pterygoid fossa on the normal side, and this is on this side. And you can see that there's no contrast enhancement there. And also, so there is no erosion of the pterygoid fossa. Whatever has happened in the pterygoid base and has not extended into the pterygoid fossa. There are two ways by which it can go into the pterygoid fossa: through the nasopharynx and through the pterygoid base. So they are not involved. Okay. Think that off. So in the axials, here you can see the sphenoid involvement, the widened pterygopalatine fossa, the Holman-Miller sign, and then you can see here that the pterygoid plates are not splayed apart. Okay.
Yes.
So now we'll take the MRI.
Sure.
In the MRI, you look at the T1 contrast plates, post-contrast plates with fat suppression. So that is what we look at to get the best tumor delineation. So this is T1 weighted, fat suppressed, coronal post-contrast. So this is what we look at first. And
Yep.
as we go along, let's look at the coronals. We first start seeing the tumor enhancing here.
Yeah, he needs to. Yeah, with you.
Yeah, so that's the inferior turbinate. This is the tumor enhancing here. As we go further, you can see it is intensely enhancing.
Yeah.
Going through the sphenopalatine foramen into the infratemporal fossa.
Yep.
And as we go further, you can see it's fairly broad in the infratemporal fossa. It's a large component in the infratemporal fossa. That's the maxillary artery.
Right. Seen very
This
well.
is the component in the sphenoid sinus, nasal cavity, infratemporal fossa, going all the way down up to the, well, not parapharyngeal, but low down into the infratemporal fossa. That's why we say infratemporal fossa plus. And as we go behind, we can start seeing the involvement of the cavernous sinus. So before that cut, can you see this?
Yeah.
This is the involvement of the inferior orbital fissure and the orbital apex. And as you go further behind, you can see that it is involving the cavernous sinus. This
Yes.
is a cut at the level of the paraclival carotid. You can't see the carotid here. And as you go further behind, you see it's still in the cavernous sinus and it has compressed the temporal lobe for a certain degree. And you can see the carotid appearing here. And in the next cut, you can see the carotid, the upper loop of the paracellular carotid.
Right.
I'll show you on axials how it abuts the carotid. And further going on, then there's the tumor is absent. Now let's look at the axial T1 fat suppressed post-contrast films.
Right. Ma'am, we've just had Professor Alkis and Professor Mario joining us now. After your scans, we'll welcome them formally.
Yes, welcome Professor Apostolos and Professor Mario Turizanoni. Let me tell the audience that Professor Apostolos also goes by the name of Alkis. And for me, he has always been Alkis. So Alkis, good morning. Mario, good morning. I'm so glad you've joined us in spite of having a late night flight. Thank you so much.
Thank you, Renuka. Nice to see you.
Yeah.
Thank you, Renuka. It's great to be here with you. Many thanks. It's a pleasure.
Thank you. So we were speaking about the inferior orbital fissure involvement and then going on into the cavernous sinus. And then we spoke about the fact that the carotid is close by. And let's see on the axials. On the axials, you can see that this is the nasopharyngeal component. It's the hard palate. So you can see it's going back down into the oropharynx. This is the nasopharyngeal component.
Yeah.
Okay. And then you can see it in the nose, extending into the nose. And that's the middle turbinate. So there's always the inferior turbinate. And there is always a pattern of adherence. So the tumor adheres to the middle turbinate, but it usually, I'm talking about primary tumors, they adhere to the middle turbinate, but not necessarily to the inferior turbinate. So inferior turbinate is usually free. You can see this is the infratemporal bit. You can see the infratemporal part of the tumor there. And you can then see the connection between the two. You can see it's an intensely enhancing tumor. As we go further behind, this is the bowing of the anterior wall of the maxilla. And these are the different parts. This is the sphenoid component. And as we come here, this is the inferior orbital fissure on the normal side. And you can see that there is some enhancement there in the inferior orbital fissure, and then coming into the cavernous sinus. And this is the carotid. So you can see it's abutting the tumor, but not encasing. The tumor is not encasing it, but it is abutting the carotid.
Yeah, well said.
Yeah. Okay. So we are ready to start. We've done some basic work. So let me tell you two things. One is we started doing this surgery well before skull-based surgery came to be a gold standard. So it's almost, we did our first angiofibroma endoscopically in 1997. And that was the year that the first endoscopic pituitary was done. Almost the very first case, I think it was done by Joe and, I know it was done by Joe and Kara. So by the time skull-based surgery became common ground, it was the early 2002, 3. So we had almost a 5-year part of our experience with angiopharma, which was before standard skull-based surgery. And at that time, the understanding or the thing that the scope could be held by someone else was not clear. That we realized can be done after we started doing skull-based surgery. So in those years, we trained ourselves to work as a team, 2 people together. And it held us in good stead. So by the time skull-based surgery came and you could have another person holding the scope, we were already trained significantly as a team to operate. And since our results have been, they're there for people to see. There may be many people in the audience who have referred cases to me. But because our results have been very good, we have not seen any reason to change. So you will see that there's a large difference in the way we deal with angiofibromas as compared to other surgeons. So, and the reason there's this large difference is because it has worked for us. And this is the way we have been doing these angiofibromas now for quite some time. Of course, we made a lot of changes. We did a push-pull approach. We do a 4-port technique. I'm going to show you the 4-port technique today. So let's get started.
Yes, thank you, ma'am. Also at this point, as we move to live surgery, I'm going to take the opportunity to welcome our international faculty. So Dr. Apostolos Karlikiotis, he is a eminent otolaryngologist, head neck surgeon with particular experience in endoscopic sinus and skull-based surgery, working in the Department of Otolaryngology at the University Hospital of Varese in Italy. He's authored more than 160 scientific publications at national and international level, and more than 70 have been peer-reviewed with 15 book chapters, participated in numerous conferences, lectured over 160 times. He's been invited tutor in more than 100 courses of endoscopic sinonasal and skull-based surgery. Well, his CV keeps going on. He's been kind enough to give us a brief version of the same. And he's the associate editor for the rhinology section currently of the Acta Otolaryngologica Italian series, and which is the official journal of the Italian Society of ENT. We look forward to interacting with you and learning from you over the next 2 days. And as Madam already said, you're known as Alkis, and that is the way probably we'd get along with you. It's also my pleasant duty to welcome Dr. Mario Turi Zanoni. He's currently the assistant professor and consultant in the skull-based surgery at the University Hospital in Serbia, Varese, Italy. I read here he's had a wonderful time at the MD Anderson Cancer Center under Professor Ihab Yana, and that must be, I'm sure, a wonderful experience. He's authored more than 150 scientific publications, many of them being peer-reviewed, and has lectured more than 120 times. He's also served as a junior member in the advisory board of the European Rhinology Society, and currently serves as a training coordinator within the advisory board of the Italian Skull-based Society. Welcome, Professor Mario. I'm sure we'll have a wonderful 2 days together. And we look forward to Professor Paolo in the afternoon, and that's when we'll introduce him. Welcome.
Thank you, Kshitij. Let me introduce Dr. Anaga Joshi. Dr. Anaga Joshi is the professor in the Department of ENT at Soin Hospital. And both of us have worked together since probably the earliest inception of angiofibroma surgery in Soin Hospital. And like I said, we have now an almost telepathic communication between us when we operate. And the other person who assists me when Dr. Anaga is not assisting me is Dr. Kshitij, who is there with you as the moderator. Dr. Kshitij Shah, who is the associate professor in this department. And you have already met him. And so we will begin. I'd like to acknowledge that the anesthesia team is headed by Dr. Kanchan Rupavate. And
Hi,
good morning. And I'm sure they'll give us an excellent field, as they always do. Thank you so much. So let's get started.
we'd also welcome centers that are with us at Guwahati, Imphal, and Bhubaneswar. And I think numerous people who are attending this wonderful event online too. What I request the delegates who are online and over here with us in the auditorium is, as you have questions or when you have questions, please jot them down and pass it across so that we can, have a effective scientific session here. Madam, over to you. We're still with the external picture. You want to show us the instruments?
Yeah, just a little basic thing about the instruments. I just want to know, have we not got that online link for the questions?
There is an online link. We are checking that too.
Yeah, so they can then put the questions on the online link.
Sure.
So that might be more comfortable than actually handing over pieces of paper.
Sure.
So when it's ready, you can let the people know, the audience know. So
The
we
online
have
link is
all
ready,
these.
and we'll circulate it once again. So you can log into that and post your questions online.
Okay. So we have a whole lot of insulated instruments that we use during the surgery. One of the most important, so we use the coblator, but like I said, we use the cautery much more than we use the coblator. This is, all these instruments are monopolar. Our forceps is not there, no, the crocodile. Okay, that will come. This is a bipolar crocodile action, and this is a bipolar regular one, bayonet shaped. Besides these instruments, we also create what we call laddus. Okay, these laddus are actually betadine coated gauze, roller gauze rolled into balls, which we use if there's extensive bleeding. So that's the laddus. We have Surgicel with gel foam. That's laddus, and these are Frankies. So, yeah, okay. And then, of course, there are Vaseline and roller packs. We use patties, preferably in the micro areas, in the nooks and corners. We prefer to use patties, which may be larger patties or 2x6. These are 6x6, and these are 2x6. We also have long patties, which are not put here. But we'll get started now.
Right.
Give me the endoscopy picture now.
We're with you with the endoscopy picture.
Yeah. So let's have a look. Packing forceps.
So as you take off the patties, ma'am, and I mean, you can already see quite a lot of the job done. Could you walk us through the steps of what was done so far?
Yes, I will. I'm just removing the patties before we talk.
Sure.
Okay, so what we have done. Smaller section. So what we've done is, this is the middle turbinate on the left side. We've done
Yes.
a posterior septectomy.
Yes.
Okay, so we've done a posterior septectomy so that you can see the middle turbinate on the left side. You can see the middle turbinate on the right side. This is the inferior turbinate on the left side. This is the inferior turbinate on the right side.
Right.
This is the tumor.
Yes.
Okay, and you can see the tumor pouting onto the opposite side through the nasopharynx. Give me a suction elevator. So this is the septal mucosa. We'll trim it a little more. And
Superior turbinate.
yes.
Yeah.
No, not the superior. Yeah, that's the superior turbinate over there.
Yes.
This is the middle turbinate. And when we
Yes.
go in, we've done an anterior posterior ethmoidectomy. We've
Yes.
delineated the skull base. Give me a straight suction. And we've opened the maxi-sinus ostium widely. So we've opened the skull base. You can see the skull base there. It's skeletonized. And
Yes.
this is the posteriormost ethmoid cell. We haven't
Right.
opened the sphenoid sinus as yet.
Right.
And you can see here, this is the maxi-sinus opening. It's open widely. If we feel the
Yes.
need, we will take off the inferior turbinate. At
Yes.
present, we don't feel the need.
Yes, if I may add, we usually start off with trimming the middle turbinate, but possibly this has been done for the sake of demonstration to show
Yes,
what
so
the first
we,
step would
yeah.
be.
So we want to show what we do, the first
Yeah.
thing around. So the first thing we do is a posterior septectomy and create space for surgeons to operate from both nostrils. So there's a bi-nostril approach.
Right.
Give me a suction elevator now. Is it focused well? Is the picture fine?
It's focused well anteriorly. In the depth,
Yeah.
we're losing focus, but we can see the middle turbinate clearly.
Yeah. So as we go behind, you can see this. There is always an attachment of the tumor to the middle turbinate. Can you see that?
Very well seen.
Okay, so it's very important that when we trim the middle turbinate, that attachment is detached from the middle turbinate when we do that.
Right.
Is that clear? So what we do is whenever we use the cautery, we don't use it at the junction of the tumor and the middle turbinate. We will err on the side of the middle turbinate. So we'll take a little bit of the middle turbinate along with the tumor.
Right.
So that's the principle we follow always. Okay. So give me.
Yeah. We have a certain feedback in the OT if someone's been talking around.
Yeah, please can everyone please maintain a little silence. We are a talkative lot in the OT.
That's good. Any specific cautery settings that you prefer right now?
It's a 35, I think. 25. It's a 25.
All right.
Okay. Give me a turbinectomy scissors. So that's the way we detach the tumor from the middle turbinate.
Yes.
And as you can see, a little bit of the middle turbinate is left on the tumor.
Yeah.
So that, at the junctions, we are not very sure infiltration. We are not very sure how much the tumor has infiltrated submucosally into the 1 and 2 line.
Yes, ma'am.
Into the submucosal plane of the middle turbinate, which is why we what number needle is this? Just take that off.
वॉल्यूम बढ़ा दोगे वॉल्यूम बढ़ा दोगे
Okay. We always leave the axilla of the middle turbinate intact
Yeah, that's a good
because
landmark.
that's a landmark for any future surgeries.
Right.
और ये किस लिंक में देख सकते हैं नहीं जूम लिंक नहीं वो पब्लिक देख सकते हैं क्या यस सर क्या यूट्यूब लिंक या जो भी
And as we take it down, we push it down. As we cut,
Right.
we push it down. And then push it up.
ये वेबकास्ट क्या आलकम का वेबकास्ट
You've got excellent AV here. Apparently, when you're column mic, when you don't talk, it catches surrounding sounds. So you need.
No one talking now. I think someone is talking somewhere else. कुठेतरी दुसरीकडे बोलतायत लोक जरा बघा कुठून तरी दुसरीकडनं ऑडिओ येतोय. So there's someone talking somewhere else where the audio is connected.
Yeah, so we'll just figure that out.
Blakesley. So that's the middle turbinate.
Right.
This is, of course, to give maximum exposure to the sphenopalatine foramen. Debrider, please.
Correct.
So this is a little bit of middle turbinate on the tumor.
Yeah. We're talking of the inferior turbinate being free. So is that clearly seen over there?
Yeah, I'll just show you.
Yeah, sure.
Blakesley. Just be careful when you take out these sharp flush.
Yeah, the spicules of bone.
Yeah. Yes. Okay. Now we can see that the tumor, you see, it doesn't attach to the superior turbinate except for a little bit posteriorly.
Right.
And if you see here,
Yeah.
give me a suction elevator. Yeah, you can see here. Give me a suction
you can see
elevator.
the lateral nasal wall too over the inferior turbinate.
Can you see the inferior turbinate is free?
Right, right.
Yeah, is that seen?
Very well seen.
Okay. So these patterns of adherence are very typical in a primary tumor. We now just
Right.
detach the superior turbinate. Turbinectomy scissors. Leave the upper half of the superior turbinate intact. You don't want to affect olfaction.
Right.
Blakesley.
So you're not yet entering the sphenoid, right, ma'am?
No, not yet,
Oh.
not yet.
Okay.
Now you'll also see that the posterior part of the septum usually adheres to the tumor.
Right.
Suction elevator.
Yeah, we can see it's in the upper part of the tumor, upper part of the septum.
So can you
adhesions.
see that adherence?
Yes, we see that.
And it's usually in the upper part of the septum, not the lower part.
Right.
Okay, so we are going to remove this part of the septum and make sure that we cauterize and cut that adhesion.
Right.
Touch. Touch.
Right. Just to re-announce, you could again access the link if you wish and put your questions online. But for the benefit of people who are with us physically, if you just wish to write it down and pass on questions, that is fine too.
Touch.
So that's taking off the adhesions on the upper end of the septum and the tumor.
Okay, give me an elevator.
Yeah.
So I reached the bone there.
Right. That's the rostrum, is it?
Yeah. We've
Yeah.
removed part of the rostrum. This is near the basisphenoid.
Basisphenoid.
So you
Okay.
can see that we reached the bone. So the
Yes.
key is to reach the bone every
Yes.
time and stay a few millimeters away from the tumor.
Yes.
So this is the rostrum of the sphenoid. Give me a Blakeslee.
Right. Yeah.
When you're taking out these sharp pieces of bone, be very careful. You don't want them to. So as we remove that,
Yes.
you need to be certain that you're not abrading the mucosa as you go along.
Right. We see that.
So you can see it's been detached to a significant
Yes.
extent, okay,
Yes.
from the posterior end of the septum.
Right. I think in the process, the right sphenoid has been opened too. We could see an
Yeah.
opening
I'm reserving my judgment on that
there. Okay.
for the time being.
Okay.
So what we are doing is, with this removal of the bone, we are making wide access to the tumor.
Yeah.
So you see, we don't touch the tumor at all. We are touching only the surroundings. Great suction. Yes, that is the sphenoid. And
Yes,
that's not
the
the
left
contralateral sphenoid, that's the ipsilateral sphenoid.
Yes, that's the left.
Okay, and you can see the tumor within the sphenoid.
Right.
Okay. Give me a
Yeah,
Blakeslee.
seen well.
So now what we will do is, we will remove the base sphenoid so that
Yes.
dumbling of the tumor in the sphenoid is gone. Okay, so that's the base sphenoid. Before we do anything, we'll cauterize that edge, because there are two things there. One is the septal branch of the sphenopalatine, and you
Right.
also have perforators coming through from the internal carotid into that area.
Right. I was just going to ask you about that, because that is why, if you remember the embolization report, it said 85% embolized. Because once the tumor is beyond the
Yeah.
base sphenoid, you will have ICA feeders. Ma'am,
Yes.
we're going to take a question at this stage.
Yes.
So there's a question that what is the instrument you're using to cauterize the turbinate and septum, and is there any risk in using monopolar? How do you feel the nasal mucosa behaves to cauterization?
Okay, so our patients of follow-up are for a minimum of, well, minimum is they definitely follow up with us regularly, first 3 monthly, then 6 monthly, and then yearly for 4 years. And what we found is that extensive use of the monopolar cautery does not hamper regrowth of the mucosa normally and the ciliary beat. I have post-operative, videos as well as slides to show that, but that's not the lecture for today. So,
Right. And if you were to use, or if someone were to use a coagulator, what wand would you suggest?
Prosax Max.
Right. Any specific benefits in what you are currently doing with the cautery that you find?
One is, it just works for us.
Right, thanks. That's a good answer.
Yeah, and the other thing is, you have a very narrow footprint.
Yeah.
Unlike the coagulator. So you can do a very precise management. Okay, so now you can see, flush please. You can see this bone is coming off. Can you see that? Yeah, just a minute. Can you see this bone?
Yes, we do.
Can you see? So when I remove this bone, the thing which is holding up that sphenoid component will be removed, and we'll be able to
Right.
deliver that sphenoid component. And if we
Right.
try to deliver it without removing this bone, the tumor will tear.
It'll tear. Correct. So that's the
Okay, so
dumbelling in
no,
the base sphenoid.
and please remember, embolization is of the tumor, not the maxillary artery. So,
Correct.
So if it tears, it will bleed.
Correct.
Blixley.
So the pressure head of the tumor may decrease with embolization, but yes, as you said, it will still bleed.
So you see, I cauterize the surface and the under surface of that bone so that, you know, we don't have bleeders.
Yes.
Section. Maybe a little more. That. Okay. Still a little more. Okay. Section. Blixley. Cautery. Okay, stop. Flush. So this is now coming to the roof of the posterior choana.
Yes.
Okay, so this, there is always adhesions here. Can you see these firm adhesions?
Yeah, along the basis sphenoid.
Yeah,
Yes.
so that those need to come off.
Right.
Straighten it a little. Take a curved suction, or you're fine with this. So you see, this is a cautery ballpoint. It has a very narrow footprint.
Yeah. I think it works wonderfully well. There's a question here on embolization.
Yes.
So could you explain about pre-op embolization? Why can't we embolize the maxillary artery directly? There maybe it's a miscommunication when you mentioned the first time around. But so the question is, why can't we embolize the maxillary artery directly? So could you
We do embolize through the maxillary artery.
Right.
But it is very highly selective catheters now that they use.
Right.
Because if you do the maxillary artery, there's a chance of rebound. And embolus going into the accessory meningeal and going from there towards the ophthalmic artery. So therefore, they don't. So it's a highly selective narrow catheter which goes in as opposed to the previous
Right. I think just to give some clarification, it's distal selective embolization. So it's through the maxillary artery into the tumor bed also. You're looking at the blush, but what madam was meaning to say is that the artery per se is not formed. It's not like a glue cast, which was done in the older days. And that's to avoid the risk of distal embolization.
Blush when I say. Equal. Touch.
Yes. Yes. So our intervention department usually would do a transfemoral catheterization and through that access the tumor. We used to in the past do a direct tumoral embolization too, but that they have stopped doing since a long time.
You see now we've come to the edge of the tumor. Give me a through cut, straight through cut. Debrider. Blakesley. Suction. Flush. Yeah. So just to reorient everyone.
Yeah.
This is the inferior turbinate. This is the cut end of the middle turbinate. This was where the septum was, which we have removed. And this is the ipsilateral sphenoid on the left side. And this is the tumor within the sphenoid.
Right.
This is the basal sphenoid, which we have cauterized.
Correct.
And this is the tumor. This is the septum.
Right.
And this is the tumor.
The upper septal adhesions. And the tumor can be seen on the right nasopharynx too. Maybe
Yes. Now this little bit of the septum we are going to remove so that both sides are joined.
Right.
Make it straight every time, no? Yes. Touch.
So that's the upper septal adhesion cut.
So now you can see the tumor in toto.
Yes.
Okay, joined together, septum is completely out. As you saw, we didn't go for the whole septum in one go. We went bit by bit, Blakesley.
Right.
Got it. so that we know exactly how it's connected. And every bit that we are cauterizing, we are first looking where it's attached and then cauterizing.
Correct. So you're proceeding with the right side cut of the tumor on the roof of choana?
Yes,
Okay.
in a little while.
Okay.
Is everyone oriented?
Yes, there is no one raising hand for disorientation. At what stage would you start using the other nostril also, since you have created that access?
We are already using it.
Oh, you're already using binostril?
Yes,
Okay.
yes. But
So maybe that you could,
Debrider.
who's using which side and how does that, your scope is on the left side?
The scope is in the left side. My
Right.
instruments are on the right side. The suction on the left side is managed by Anaga.
Right.
Okay, debrider. The suction is blocked.
Yeah.
Debrider is blocked. Stop. Give me a break, Steve.
We have a couple more questions when you're ready for it.
Yes, yes.
So one is a little not theoretical, but in this case, so for example, say the question is if the tumor were reaching all the way till the external nostril, the anterior nair, then
Yeah.
what?
Then we
How
do
would
a
you look to handle
segmental.
it?
Then we do a segmental approach. In which
Could
case
you-
we use either the cautery or the coblator, whatever is working well.
Right.
So we will do a segmental approach where we will remove the part from the nasal cavity, and then
So
go
that-
ahead. Walter.
Right. So when you say segmental approach, you mean divide the tumor into smaller segments to create
Not
space.
debride, not debride.
Divide the tumor.
Divide, yeah.
Divide. And that you would do
That's-
it till you had space in the nasal cavity?
Yes, yes.
All right. The second half of the question says that what if it's reaching the choana posteriorly, which I think you're demonstrating right now?
Yeah, I'm showing that. Yes, I'm
Yeah.
showing you that.
Correct. And there is a corollary question to this, again,
Yes.
depending upon experience, but when will you choose to convert to an open approach?
So the second case that I did in 97, I converted to an open approach. Subsequently, since then, I'm not needed to convert to an open approach as an emergency. But I have sometimes used a combined approach.
Right.
But
Could you
as an emergency, because I couldn't, because it was difficult to handle endoscopically, we haven't done that. Give me a patty.
Right. Could you explain your philosophy of when you say combined approach, or
So,
maybe later on?
So give me one patty, but cut the thread. And staff, please remember that there's one patty inside. Yeah. We do a patty count before the surgery and we do a patty count after the surgery. In between, we don't count patties. But there's a specific count kept about any patty which is in without a thread. Yes, what is it?
No, so since we were talking about open approach and you mentioned combined approach,
Yeah.
could you walk us through when you say combined approach, what's the philosophy
So we'll
behind
show
it?
you part of what we call a combined approach today. Okay, I'm going to show you.
Right.
Depends, we'll see. As we go along, I think that will answer your question.
All right. So essentially the endoscope is a tool that is
Flush.
used all the time. Even if you're doing a combined
Suction.
approach.
Flush. Now that we can see the edges properly, now I'm going to cauterize here and remove the rest of that middle turbinate, which is adherent to the tumor.
Right.
Okay. Keep another ballpoint ready. Yeah. Bottle. curve section here. Touch. Medium. Okay. Turbinectomy scissors. Debrider. Functioning. Leave it like this. Little fibrous. No, it's not cutting. To cut. Straight. Okay, now what we can see is we can see the attachment to the lateral wall of the nasal cavity. Can you see that?
Yeah, we appreciate that.
Okay, so now we are going to, so there's a thing about this. Angiophymas attached to the lateral nasal wall anterior to the eustachian tube. They attach to the fossa of Rosenmüller posterior, but they never attach to the eustachian tube itself.
Yeah.
So this is the attachment to the lateral wall that we are detaching.
Yes.
Just a minute. Yes. Come. मैं हे करते हैं.
One of the questions that we have asked here, there is a huge trend of promotion of the I like the question. Thanks a lot.
So, madam, there's a question here.
Yeah,
It'll put you on the spot, though. Should I ask?
just stop. Yeah, of course you can.
So, this is what's your personal preference, cautery or cobblator?
Mine is cautery. Mine is cautery. Like I said, whatever works well in your hands, that's the right instrument for you.
Absolutely. And having said that, we see you use the cautery. The benefits, if I may point out, is that it's very precise. You have a small footprint and you're doing exactly what you want to do.
No, what I would say is I prefer it because it has a smaller footprint. I'm
Yeah.
also very clear that it doesn't lead to atrophic rhinitis as we originally used to think so.
Absolutely. Yeah.
So, see, that's the lateral wall being detached. Okay.
Yeah, we see that. So the bone underneath would be the middle pterygoid plate.
Take suction. It's blocked. So it's detached from the lateral wall now.
Yes.
निकालेंगे तुम। पैटी दे। Two, okay. Take section. Which of the cost is that? That's fine. That one. Okay, now what we are coming to is the roof of the posterior choana. Okay.
Okay.
Hmm. So what we are going to do now is open the sphenoid from laterally, so that we've
Yes.
already seen the tumor from medially.
Yes.
Now we're going to look at it from laterally.
Yeah.
Okay, give me a ballpoint. छोटा दे. One Blakesley. So this is from laterally that we are opening, Blakesley. And we can now see the tumor from laterally.
Yeah.
Punch. Just removing that mucosa. Punch. Blakesley. Flush. Cautery. Hmm? No, wait, no. Touch. Debrider. Touch. Turbinectomy scissors. Blakesley.
So you're looking to take off the anterior sphenoid completely now, is it?
Yes. Yes.
Okay. There are a couple of questions here. They're not relevant at this stage of surgery. Maybe we could take them later,
Oh.
unless.
Yeah.
Yeah.
Cautery. So there's an intervening part which I'm going to remove now.
Yes.
Touch. Okay. Done. Okay. Give me a turbinectomy scissor. So that's the entire sphenoid bit. There's a little bone here. So straight Blakesley. Upward. Punch. Okay. Flush. Locked. I have Dr. Shivali and Dr. Shreka assisting me. So we are ready to now deliver it from the sphenoid.
Yeah.
You see all the bone. This little bit of bone we'll remove.
Yes.
Straight.
It's free in the sphenoid. So are you planning to deliver it down or go for the lateral
Yeah,
bit first?
no, we're going to go for the lateral, but first I'm just
Right.
delineating this whole thing. There's a
Right.
reason why we do this. Because when we are delivering the lateral part, the
Yes.
part which goes into the inferior orbital fissure will not
Yes.
budge until this area is loose.
Right.
So for that
you're
reason,
freeing it up.
we are freeing it.
Yeah.
I think that should be enough.
Yeah. The intersphenoid septum is partly left and that's all right.
Punch. Suction. Blakesley. Okay, it's now fairly free.
Yeah.
So I can leave it behind. Yeah.
Yeah.
Okay.
That's,
So what is bleeding is near the vidian. Okay.
yes.
One more. Okay, now we're going to go for the lateral extend.
Sure. You're good to take a couple of questions, madam.
Yes.
So this is regarding embolization and embolized tumors. Do you feel there's a chance of recurrence if a tumor is embolized?
Sorry, I wasn't with you. Tell me.
I said this is regarding embolization and embolized tumors.
Yeah.
What do you feel? Is there a chance of recurrence if a tumor gets embolized?
No, there was a paper on that stating that, the lateral margins get obscured.
Yeah,
At what point has the lateral margin been obscured?
exactly.
Okay, so that actually, I think that paper was the pre-endoscopic era.
Yeah.
But definitely there is. So we're going to remove part of the inferior turbinate.
Okay. Also, in continuation to the same question, does it pose a challenge in revision surgery?
No. The main thing in what was the challenge? Embolization.
So a little vague, it's framed. It's written in continuity. Chances of recurrence in embolized tumors, challenges in revision surgery. So I'm not sure if it's two
So
different
challenges in
questions.
revision surgery in general is that, you see, there's an angiofibroma. Okay, it has an angiomatous component and a fibrotic component.
Correct.
So the what happens is when there's a revision surgery, you have fibrosis, and then demarcating the tumor margins becomes much more difficult.
Correct.
Yeah. Touch. Okay. Section. Backbiting. Give me the drill. Call Sachin. Do you know what to do? Attach neck. Okay, we'll come to that later. Okay. Backbiting. Give me the debrider till then. Okay. Hold. Give me a through cut. Legs. So this what is coming out is the perpendicular plate of the palatine bone.
Yes.
That's the one which is dumbbelling the lateral aspect of the tumor. Okay, there's a little more bone here.
When the situation is right and you guys are comfortable, we'd like an external PIP to show the position of the entire team, the trolley, the assistant.
Yeah, everything.
If that could be arranged as and when convenient.
Give me a upward flexing.
Meanwhile, there's a question for you, ma'am, whether the neuropathies that you're using, they are soaked in adrenaline. What kind of concentration?
30 cc with 3%, 3 to 4 ampules.
All right. 3 to 4 ampules of adrenaline, 30 cc of lignocaine, 4% lignocaine.
The line, yeah. Back. Give me the debrider. Oh. Has the drill started working? Yes. Ileka. Sachin, Baga. Yeah, okay. Flush. Flush. You don't come more anteriorly to that.
Yeah.
Grills. Mm. Mm. Ah. Okay, flush. Straight. Yes. Straight posture. Mm. Upward. This is again coming down to the gross maxillary tuberosity.
Yeah.
So again, the same principle, remove all the bone in between. That's one out. There's one more in, okay? एक अजून आहे आतमध्ये. Straight sections. Pottery. Pottery. That. Stop. Okay. Now I'm going to remove some of the, give me a patty on a straight forceps. Okay. अजून थोडं काढ. Give me a cautery. We'll remove. So we've taken out half the inferior turbinate, but we feel that it might be better to take out the whole posterior part.
Right.
Okay, what I'm doing is I'm judging whether how that tumor will move. Touch. No. Another your suction. Yeah. Touch. Okay, turbinectomy scissors. Blakesley. Backbiting. Turbinectomy scissors. Cautery. Touch. Touch. Stop. Blakesley. Backbiting. Curve debrider है? Keep the curve debrider. Quick. Hey, can't. No. Less than this. 15. Yeah, that one.
Could we have a few questions to you, ma'am, as you get things ready there?
Yeah.
So it's an interesting question, but someone's wanting to know about post-operative pain in using cautery versus coabulator versus cold instrument. Is there
I didn't get
anything
that.
different in JN
Post-operative
you
what?
feel?
Yeah, what?
Any post-operative pain while using cautery versus coabulator versus cold steel? Do you feel JNA would be different from any other sinus or skull-based surgery in using any of these instruments?
Surprisingly, in spite of so much of dissection and bone drilling and all, with medical management,
Pain is not usually a challenge because
okay, that's
maxillary
upward
mucosa is
Blakesley.
what.
So that's maxillary mucosa coming off. In
Yes.
this case, there's no bone
Yeah,
over
we see the
that.
periosteum.
Yeah.
So usually you'll have a thin egg-shelled bone, but yeah, you can't see bone.
Pottery. Greater palatine epithelium. So this last piece of bone,
Yeah.
I'm just cauterizing. I'm not removing just now, unless
Right.
I need to, because that's where the greater palatine will be.
Correct. Just behind that.
Yeah. So this is actually bone of the maxillary tuberosity. Cut. Pottery. No, its suction is blocked. Give me the straight one.
There's also a question for the anesthetist out there.
Yeah.
Any particular changes in regular anesthesia for hypertension as vis-a-vis endoscopy surgery versus surgery for JNA?
Are you giving no? The BP is 103/63. You could bring the systolic down a little, but I don't tell them what to do. They decide what to do when they're looking at the field.
No, so this is a question from the delegate that compared to routine sinus surgery versus surgery for a tumor like JNA, do they have any particular changes? As and when they could answer this?
Yeah.
Good morning, Shittis.
Can you hear, madam?
Hello.
No, she'll have to be a little louder or.
Sachin. Hello, can you hear me?
Yes. Yeah, Kanchan ma'am, I think we can hear you now.
Good morning. Yeah, in this JAT case, we are giving tranexamic acid in IV infusion form.
No. Your voice is not effective enough. We're not able to understand.
Hello, can you hear me?
Much better.
Yeah. Means compared to other surgeries in JNA, we are using tranexamic acid infusion, IV infusion, to give good field and hypotensive anesthesia. Also, we are using injection dexmedetomidine, which is alpha-2 agonist drug, which is sympatholytic and it also gives hypotensive anesthesia. So these two agents we are using in JNA surgery, which we are not using regularly in other type of surgery, especially tranexamic acid IV infusion continuously.
Right. Any specific thing just to cause hypotension, madam?
What, sorry?
To cause
Any specific
hypotensive
drug
anesthesia.
to cause hypotension or what you mentioned, Dexmed and Tranexa
Yeah,
infusion?
we are giving inhalational agent also desflurane, and we do induction with propofol and intermittently we are giving fentanyl.
Okay. Thank you.
So overall, then, all these drugs acting together, they are giving hypotensive anesthesia.
All right. Thank you so much.
Thank you.
So we've made another port, like I said, with the. Okay, so this is a canine for support. So we've kept the pyriform aperture intact. Okay. Now in this case, no, the issue is that the tooth root is very high.
Yeah.
So it's a little difficult. So we can see now the lateral extent of the tumor, right?
Right.
Give me a Blakesley, a straight Blakesley.
At this stage, there's a question that's inevitable. There are two of them.
Want to drill it? Yeah, what was the question?
Yeah, so I'm going to read out the two questions verbatim. When do you plan for a modified Denker's approach? Any reason why an endoscopic modified Denker's approach not used in the left side or in JNA?
Yeah, I don't use modified endoscopic Denker's because I don't like that pyriform aperture drilled out. It flattens the curve of the face, and it also, in long term, because the anterior wall is out, the posterolateral wall is eroded, and the pyriform aperture is removed, my personal experience is that it causes over a period of years a flattening and the retraction of the cheek, which is why I don't use it.
Which is irreversible, not correctable.
Yeah, it happens gradually over time.
Yeah.
So that's why I don't use a modifier. Okay.
Do you embolize all cases of JNA irrespective of size or extent?
No, certain size tumors where we feel that there's good adequate control over the entire tumor, we don't embolize.
Right. So any guidelines you'd want to suggest which tumors? You carry on right now.
Tumor infratemporal fossa plus
Right.
is one guideline.
Yeah.
Yeah, because of the tooth, we are not able to put in our instrument. So this thing is the tooth root.
Yeah.
Inordinately high.
Yeah.
I think
are you considering the push-pull approach?
Transnasal with a push-pull. Okay. So we're making that fourth port that we were talking about. That's the push-pull port.
Yeah. A generic question at this stage. Any advice for budding ENT surgeons how to get training for skull-based surgeries?
Why don't you ask Apostolos to take that question?
Sure. They'd be more than happy to.
So the most important thing is to go to the lab and have dissection, cadaveric dissection, and know the anatomy. I think is the most crucial thing, to have a lot of courses and individual dissection in order to have all the anatomy known. Then, of course, the pathology will change the anatomy inside of the nose and paranasal sinus and skull base, but always you can have landmarks and you know what to do and to be oriented and have three-dimensional reconstruction of the anatomy of the patient, each patient. I think the most crucial is to know the anatomy.
Thank you. And I think you'll see a demonstration of that in the afternoon when they get onto the cadaver dissection. We look forward to that.
So we are taking an incision in the subgingival sulcus enough for an assistant's finger to go through.
Yeah.
So all this that we are doing is to avoid, avoid a modified endoscopic Denkers.
Yeah, and these incisions heal pretty well without any morbidity.
Mm-hmm. So now we are going for the lateral extent.
Yes.
Flush. Usually we'd use the canine fossa port as well. This time because of that tooth root flush. Flush, flush. We've decided to use the push-pull approach.
Yeah.
Cautery ballpoint. So I'm going to cauterize the periosteum over the tumor in the infratemporal fossa.
Yeah.
So it's a touch and go kind of thing. Yeah. This particular band of periosteum needs to be cut properly.
Yes.
This one. Okay, that should be it. Just a little bit more superiorly. Okay. Blakesley, straight Blakesley. There's some more bone I want to remove. So that's the periosteum that we are opening up. Little bit more over there. Hmm? Yeah. Okay. There's a little bit of bone I want to remove. Upward Blakesley also. And that is this. This is the bone which will lead you into the inferior orbital fissure. Okay. Will we come to that later? We will remove the rest of it a little later. Flush. Flush. Okay, bus. Straight suction. Blakesley. So you see, Dr. Anaga is putting her hand through that
Yeah, we can see
buccal
that.
sulcus
We can see that.
incision. Okay, so she will support that tumor and prevent it from falling back.
Yeah.
Tumor में आना? में आना? नहीं. जाते ये ना लगते ते इथूनच करू. Pre-operative. Flush. Dissection. Flush कर ना. सगळं फ्लश कर. थोडं थोडं नाही. Dissection. Give me a straight Blake sleeve. First, give me an upward Blake sleeve. हे काढून टाक. Scissor. हा. कुठे? Okay. Yeah, there's thin bone there. Upward Blake sleeve.
Yeah.
Okay, I've loosened that.
Yeah.
Straight Blake sleeve. Bigger one. Tuck here. थांब इकडेच राहा थांब.
Yeah, we can see that. Okay. If you're okay taking a question at this stage, ma'am.
Tuck here. upward.
There's a request if the audiovisuals could give an external PIP. We'd like to see how the team is working.
Look at this. Wait, adhesion.
That's the
Cautery.
greater palatine. Have we heard in the OR?
That there's some adhesions there. What is it?
Is that the greater palatine vessel?
No, we are more lateral to that.
Okay.
That was probably the descending palatine. Flush. I mean, the audiovisual people are not here. Just a minute. Blakesley. Pakad. You will at some point see the maxillary artery.
Yes. Is the assistant finger still there, stabilizing the tumor?
No, at the moment, no.
Okay. That seems to be the ITF component.
That's the part which is going down.
Yeah. Yeah, seen well.
We're keeping a close watch for the artery.
Yeah.
At the moment, we can't see it.
Yeah, it was seen just lateral to the tumor on the scans.
Burda. So what the assistant, Dr. Anaga, will do is, she's putting a finger through that port in the buccogingival sulcus to support that tumor so it doesn't fall back.
Right. I think we get a glimpse of a finger now.
Yeah, that's her finger there.
That's a finger,
And can
right?
you see the pterygoid muscles now?
Yeah, we can see strands over her finger. So usually the index finger of the assistant surgeon goes into the push-pull port, and that helps it's not to dissect the tumor, but to stabilize the tumor.
Okay, you see we've got to the lateral extent of the tumor. Can you see the pterygoid muscle? And there
Yes,
I
we
think
can.
is the maxillary artery. Wait a minute.
That is not yet visible to us.
Yeah, wait, give me a little time. So you see how she supported the tumor, okay?
Yes, yes. There has been a question, and answer it as you can, ma'am, at your convenience, that why don't we first identify this vessel, IMA or the sphenopalatine?
Yeah, that's a good idea to do.
Yeah. Yeah.
Okay, cautery.
If the AV guys are ready, a PIP at this stage would really
That's-
help.
That. So we're cauterizing the lateral extent of the tumor.
Yes.
Pushkar. That's the vessel, most probably. That.
Do not take off the endoscopy picture, please. Yeah. Audio visual, the external picture which you gave us, we want in PIP and a zoomed out picture, please. Yeah, you can see that well now.
So these are all feeder vessels.
Yeah.
That we're cutting.
Yeah.
The big artery is not seen.
All right. Distal selective cauterization, even better.
Okay. Okay. Yeah. So the lateral extent of the tumor has reached. We now need to, for whatever reasons, the maxillary artery hasn't come and doesn't seem to be anywhere in the field of our dissection right now. We see it's blocked. You look at sections.
Yeah, okay.
Yeah.
That's not the vessel, right? Where the suction is right now.
Yeah,
That seems to
You
be
know?
the,
Yeah.
I think what you've cauterized is
Yeah.
the
Can you
same
see
thing
that
lateral.
artery?
Yeah.
Yeah. Can you see the
Yeah.
artery now?
Yeah.
Okay. Before it starts bleeding, let's.
Yeah. You've got a cautery done lateral to it though.
Yeah. Let me get you a clear vision of that.
Yeah.
Yeah. Can you see this artery now?
Very well seen.
Yeah. Okay.
Yeah.
Wait, a little bit of medially also. Okay. That was the main maxillary artery. So it usually splays on the tumor as we are doing it. And because it's redundant, you can stretch it. And then it comes into view.
Ma'am, Professor
Yeah.
Alkis would like to know that, have we tried clips before? What's your take on that?
I've tried clips before, and we had an experience where it slipped off and we had a post-operative hemorrhage. We find that this works. This is the artery. Touch. That's the end of it. Okay, give me an upward Blixen. Hmm? Petri? Blixley? Hmm. Flush? Yeah. Suction? Blixley? That's her finger. Okay. And that's the end of the tumor there. This is all muscle and fat. Okay.
Yeah. That's seen very well. So the lateral bit is done.
Okay.
Yeah,
Don't
you
bring
can
your finger
see
any further.
Dr. Anaga's finger well.
Now what we need to do is, now that we've rotated this little bit of thing, wait, don't suck on that. Pottery. Yeah. Thumb, infravital nerve containment. Wait, let me dissect that.
Sure.
I'm not sure that, I want to make sure that's not the infraorbital nerve. Yeah, that is the infraorbital nerve. Okay, so we are separating it from the tumor. Flush, please. Oh, God, nothing. That's the nerve going up. Can you see that?
Yeah,
This
it's seen
one.
well.
Okay. Okay. I'll just cauterize all these adhesions. They usually contain smaller arteries.
Yes.
हे मला दाखव ना. Flush. That's it. No, please. You couldn't get it. You want to go from there? No, done. Retract down. That. Okay. Blixley. Can you see the infra?
Yes, we can see the adhesions which you just cauterized there.
And can you see the intraorbital nerve going up? Here.
Yeah, very nicely.
Okay.
Yeah.
Now this needs to be cauterized.
Yeah.
And now we're going to open the orbit.
Yes. So do you push this tumor down towards the nasopharynx, or is just
At the moment, we're going for that orbit thing.
okay?
Just
if you could orient us to the floor and the medial wall of the orbit.
Just a minute.
Yeah. There may be a slight rotation of the camera currently.
Yeah, there is. Because I'm angling it.
Yeah. Yeah.
Okay, now give me a straight suction, give a flush.
Yeah. Now we see the medial wall of the orbit and the floor well. And that's the inferior orbital fissure.
Yes. Okay.
Yeah. Yeah.
So can you see that bit here
Yes.
going through the inferior orbital fissure there? Okay.
Yes. Very
Give me
well.
a punch. Okay. Flush. Fox, please flush.
Yeah.
Did Blakeslee.
With that, we could see the orbital periosteum, just lateral to it.
काय म्हणतो तो पुष्कर काय म्हणतोय Can you see it go in?
Yes, we can see it entering the orbit from here, and that's the orbital periosteum, just over it.
So this is what I'm removing is the lateral wall of the sphenoid. Can you see
Correct.
the sphenoid part? I'm removing
Yes,
the
the
lateral wall of the sphenoid.
Correct, correct. Yeah, we see that well.
A little more of the bone.
Okay.
So I've removed the floor of the orbit. I've removed the lateral wall of the sphenoid.
Correct.
Upward Blakeslee. This is the tumor going, this is the periosteum that I'm separating.
Yeah.
Yeah, can you see I'm separating the periosteum?
Very nicely. So essentially following the tumor into
Flush.
the orbit.
Yes.
That's seen very well. You didn't have to incise the periosteum, is it?
Actually, what happened is with the Blakeslee, it opened up because it was thinner, no? It was quite
Yeah.
thin.
Yeah.
Others usually we take a sickle.
Correct. And it's a nice chunky tumor there. So that's coming out from the orbit. Any precautions?
And yeah, so the anesthetists are looking for bradycardia.
Right.
If we get bradycardia, it means that there's a vessel coming from
Right.
the embolization report didn't say, but we
Right.
always ask to look for bradycardia.
Right.
We'll just cut that periosteum a little.
Yes.
Give me a sickle.
And also we usually have
So that's the intervening periosteum we removed.
Yeah.
And then we
Yeah, it's seen well.
first you go inferiorly
Yes.
and then you come anteriorly.
Right, because the tumor is going back. Wonderful.
Do you understand why I had to mobilize this sphenoid first? Give me a cautery. And that's bleeding from the cavernous, okay?
From the cavernous, yeah.
You can
That's
see that it's
expected.
dark blood.
Yeah.
So when it unplugs from the cavernous, that's when you start getting this blood.
Yes.
Okay. So as it unplugs, so that's the part which was intraorbital and in the cavernous. And the moment you unplugged it, you got
Yes.
bleeding from the cavernous sinus, okay?
Yes. Yes.
Suction.
So I guess your freeing of the tumor is per se from all areas apart from the nasopharynx is done.
So this is the part in the sphenoid
Right.
and we are taking it out. Now you see why the sphenoid thing had to be made loose.
Yes.
Because otherwise without that, that intraorbital part would not have come out.
It wouldn't have moved. Yeah.
Okay, so now we've got all the extensions of the tumor.
Yeah. Very nicely
And
seen.
Okay, and we are pushing them
Mobilizing
down,
it down. Yeah. Yeah.
towards the nasopharynx.
Yeah. The
Now
spatties
this
on your
is-
way.
Yeah, so this is the point at which people get, or rather we get impatient. Let's put it that way. Okay, give me a laddu.
Would you be taking off those patties or are they fine there?
What did you say?
The patties in the basis
Yeah,
sphenoid
we'll
area?
take them out. They're not coming in my way right now.
Okay. Okay.
So what I'm going to do is suction. Put that there. For the time being, we're going to remove it after some time. Okay, cautery. That's
Yeah. So you see the. No, I didn't know. Yeah, this one is only the patty that this is not the. Yeah.
now as we rotate this down,
Yeah.
मोठा लाडू द्या करा. Wipe this, wipe the nostrils. Okay. Flush. काढू नको बाहेर. Flush. I don't know. Suck. Are you holding it? Yes. So you can do that with flow seal, but we have difficulty with availability of flow seal. So this is what we've devised. No, don't. So Cautery. Give me another suction, Cautery. Is everyone oriented?
Yes, we're good. We're with you. We've seen the areas that you've dissected and
Not
mobilized.
suction, Cautery, just the suction. Just a
There
straight
is
suction.
a lot of blood collected in the nasopharynx.
Yeah,
so-
I'm trying to get a suction.
Yeah.
Do that. So that's the sphenoid. This is where the cavernous sinus is.
Yes.
Okay.
Yeah. The orbit on top.
Okay.
Yeah.
Give me a Blakeslee.
Yeah.
That's the infraorbital nerve. Give me a Blakeslee. What I mean is the maxillary nerve. No, that's higher up. It's over there. It's not here. Cautery. Touch. Flush. Okay. Touch. Touch.
So we have the PIP with us now, where you can see Madam is on the right side of the patient. Dr. Anaga
Oh, you
is
didn't
to
have the
her right.
PIP till now?
Yeah. No, we didn't have so far. Now we have it. Okay. So they want to understand more the arrangement. So the audiovisual guys can zoom out of the PIP.
Yeah, but
Not-
yeah, I won't talk about that. You can have a look. Okay.
Yeah, we'll explain. We'll explain. So that's Madam operating, Dr. Anaga to her right.
So now what we are doing is we are pushing the tumor down.
Yes.
And as we push the tumor down, we'll see its adhesions to the nasopharynx.
Perfect. Yeah.
So this is the sphenoid. That's the paraclival carotid. That's the pituitary fella.
That's
And
your-
this is where we are coming down. And now we are coming to
That's-
the vidian.
The Vidian.
Okay.
Yeah. The expanded
Yeah.
Vidian. Yeah. Seen well.
Now this is
You can
another
start-
place where you can get a significant amount of bleeding.
Yes. Yes.
You see how the cavernous bleeding has become less.
Yes.
Yeah.
And just run the video.
So, I want you to see how she's put the suction through the canine port. Can you see
Yeah.
that?
Yeah.
Okay, so we use alternately. Sometimes people ask me which instrument goes from where. It just depends on what we need at that particular point.
I guess that's surgical intuition.
Okay, this is where it's going into the pterygoid base.
have the assistants on the other side. Usually, two assistant residents will be operating. The scrub nurse is at the head end of the
दाखव
patient.
मला माझी mom. Yeah, give me a punch.
Yeah, I think we could take off the PIP or
Yeah, okay. You can take off the PIP now that they've had a look. Cut कर म्हणजे दिसू. Give me a straight faucet. That's the pterygoid base. Can you see that?
yes,
Wait, I'll
we
just
do.
show it to you. That's the pterygoid base.
Yeah,
That's
that's
the
eroded.
That's the eroded portion.
Correct. Very
Okay,
nicely
so actually,
seen.
it has come out through the eroded portion.
Yes.
As
Yes.
I pushed it, it came down. Now I'm going to
Yes.
look at the nasal. So did you see that? Well, I'll
Yes,
show
we
it to you
did.
one more time.
Yes.
So I thought that it will go deeper into the Vidian canal, but that is the pterygoid base. That's the raw area from where we took it. I told you it's not going into the greater wing of the sphenoid.
Yes. And eventually at the end, you'll be drilling off the base completely.
Okay. Now this is the
Yeah.
part in the nasopharynx.
Yeah,
So this will be drilling ultimately.
exactly. Yeah.
Now those are nasopharyngeal adhesions that you can see.
Yeah. Yeah.
Okay. Yeah. This is the cartilage of the eustachian tube.
Right.
Okay.
Yeah. The lateral nasal cut which you've taken has been completed over there.
Yeah, it's been completed. You saw that I
Okay.
did that at the beginning of the surgery. So point is I
Alright.
made the tumor loose from everywhere before I started delivering it.
Correct.
Okay, either laterally or
Right.
so that's the nasopharynx now.
Right.
And I push down so I can portray.
So there are a few more questions that are lined up, but we'll let you finish the surgery so that we can take
You
this
can ask
as-
them if I don't want to answer them right, then I'll just not talk and then I'll talk later.
All right, sure. So one question is that what are the chances of fat prolapse while removal of tumor from the orbit? The next is how
Can
to
happen.
pack. Yeah, in fact, you'll always expose a little
So
bit
now
of
this
fat.
is the nasopharyngeal adhesions, okay?
Yes. Next question was, how do you pack for a cavernous sinus bleed? Well, you've seen that. When will you also use Surgicel?
Can we
So
just, we'll ask these a little later, okay?
All right. All right. Yeah.
I think I can answer them. If there's anything pertaining to this step, ask me.
No, they're not pertinent to the steps. So we'll take them later.
Curve section here, no? Curve section here. Give me a straight section. You see, it's adherent there, okay? That's the part of the eustachian tube. So we don't
Yes.
cauterize there. We just peel it off.
Yes.
Now, as we start pulling it from the oral cavity, we'll look for any further. Yeah, there's one addition here, Anna. This one. No, this. You want to use the straight section? Okay. ते पुश करायला ह्याच्याने दाखव ना काय तर 40. That's I think that's about it. It's like that. Okay, it seems free now. Give me a Blakesley. Mouth again. Hey, pakda start. No, go from under the tube. No. Okay. Cut it, cut it.
It's a nice tumor.
Section.
It could be non-functional. Vision loss is such a big thing.
Okay. So I'm checking whether there are any adhesions still as it goes down.
Yeah.
Now be careful of the uvula. Got a good grip? Okay. Yeah. Okay, so there are no adhesions. Can just hold on, Jan.
Yeah, it's seen well. The entire nasopharynx
let
is
me-
seen free. Right.
Flash once. So you can see that's the adenoids.
Yes.
This is the eustachian tube here. Can you see that?
Yes. Yes. The left
Okay,
side
this
you
one.
can see
This
that
one.
left
Okay,
tube.
and you can see
Yeah,
there's no cauterization or damage over the eustachian tube.
absolutely. Yeah.
Okay.
You've got
And
applause
are you
starting.
ready to deliver it? Wait a minute. Take out the tongue then. Yeah. Yeah. With all its extensions. Can you see that?
Wonderful.
So it's an in toto removal with all its extensions intact.
Wonderful. I think you could hear the applause.
No, I can't, but
We'll do it once again when you come here.
okay. If there has been applause, thank you so much.
Yeah, for the
Okay.
entire team. Yes, and you. Yes.
Yes.
So, Dr. Janki has been coordinating with me, and he just wants to know when would we be ready to switch. You can take your time,
So,
but
no, it's 11:52 now.
it's past 12,
12.
just past 12. Yeah.
Just past. So it's actually about 12 o'clock, 12:05, is it?
Yeah. Yeah.
Yeah,
We're
we're
doing good
going
on
ready
time.
to go. I'll just talk about what these various parts are. So
Sure,
that, give me
sure.
a nice flush. Got it. So what we're going to do is we're going to keep Surgicel ready. And, but first I'll show you all the different regions. Flush again. There's a little, there's a bleeder here, which over here somewhere, which we'll cauterize later. Yeah, it's from the nasopharynx. Give me a cautery.
Yeah.
Yeah, touch. Bas. Okay. So now I'll tell you what the reasons. I'll just flush one more time. Okay. So that's the nasopharynx. That's the nasopharynx. That's the sphenoid. I'm going to take out this in a little while, but before I take that out. So that was the thing we had used to plug the cavernous sinus.
Cavernous, yeah. Yeah.
Okay.
Would it be all right to just take off all packs once? Maybe I feel really better.
Okay, I'll take
Or-
that out. Actually, it's not sitting in the cavernous any longer, so.
Yeah, it's, yeah.
Okay. Hold all this, take the mouth gag away. So that's the nasopharynx sphenoid. That's the infratemporal. Can you see the intraorbital nerve?
Yes, very well seen.
Yeah, and
That-
going
yeah.
on to become the maxillary nerve.
Yes, yes.
Okay. Going on to become the
There,
maxillary
you
nerve
follow
there.
it there.
Okay, so
Yeah.
you need to be careful about that. This is
Yeah.
where it was going. That's the where it was going into the orbit and the cavernous.
That is right. Yeah, so the inferior orbital fissure.
That's the foramen rotundum. Can you see that?
Yeah. Yes, you can
This
see
is
it
the
entering
foramen
there.
rotundum.
Correct, correct. Would someone
Okay.
demonstrate this Stankiewicz, the inferior part of the
Pancreas.
orbit?
Can you see
Yeah,
that?
so there you can see the movement of
That's
the
where
orbit.
the orbital periosteum has been opened. And
Yeah.
then we went, because we followed the tumor and stayed close to the tumor, the orbital fat has not prolapsed out.
Right.
Suction. So that's the orbit. This is from where it was going into the cavernous. This is where I removed the
Yeah.
lateral wall. This is the paraclival carotid. So you can imagine that
Exactly,
it
yeah.
was abutting that, right?
Very
Can you make out
beautifully
that?
seen.
Okay, that's the
Very nicely seen.
paracellar. This is the paraclival. Sorry, this is the paraclival. This is the paracellar. And you can see that this tumor which came out from here was abutting that paracellar that I'd shown you in the MRI before we began.
Yes, very
Okay,
nicely
that's the
seen.
entire infratemporal fossa. You can see the pterygoid muscles.
Wonderful. Could you just show us the optic nerve bulge if it's seen well
Yeah,
or not that prominent?
it's not that prominent, but this is where the optic nerve would
Yeah,
be.
yeah, right.
That
So
there.
again, the trajectory is different from the tumor to
Yeah.
the nerve.
Now, if you want me to,
No.
so
not
that's
really.
the optic nerve bulge.
Yeah.
Okay.
Yeah.
Okay.
Wonderful.
That's the clivus.
Yeah.
Any more? What I'm going to do now, because I'm going to, just
What all would you be drilling, ma'am?
this is the eustachian tube.
Yeah, that's seen well.
Okay, this.
What
this
all would you
one.
be drilling?
We'll be drilling the basisphenoid completely,
Right,
and we'll be drilling this Vidian canal
right, and
and the entire. Flush it a little.
the pterygoid base too.
Yeah. So the entire, and now this pterygoid base is solid.
Yeah.
Okay, there's nothing in it. You see that the tumor stopped here. So we are not going to go drilling this.
Correct.
This is
Just
the
polish it.
cortical bone, and you can see that it ends here. So we're going to drill out this entire area.
Correct.
This entire area, the basisphenoid.
Yeah.
And that's it.
Okay.
And this was not related. Well, it was related to tumor, but usually tumor doesn't erode here. But still, we will be drilling out all this. This
The lateral nasal wall. Yeah.
yeah, the edge of the erosion of the pterygoid base, the entire pterygoid base except this part, which we don't need to
Right.
do anything to, base
Right.
sphenoid, and that's it. So
Right.
I think we'll hand over to okay.
So what we're looking to establish connection there.
Okay,
I
I'll
mean,
just
we
show
have
you
the
how we
patient.
drill.
Yeah,
So
so we can keep your transmission on, and you can also keep talking till such time.
suction. So I understand that a large part of the audience will have multiple queries about the technique that we do, because I know
Yeah.
that the technique we do is very different from what most people do. But it's been now 23 years, I think. No, 23? Yeah, 23.
Yeah.
No, 3 and 3, 6. Yeah, 24, 25 years. 20. That we've been doing this. Of course, this is not the way we did it when we were so long ago. We added push-pull to it. We added port to it. We added the grid to it. So there's a lot of growth which has happened. But we function like this, and it has worked well for us.
Yeah.
One thing I didn't get to show you in this case is that when we are delivering a tumor, we can see vessels coming from the carotid. And that's where we use the bipolar. You saw that everything away from the skull base, we use the monopolar. That's the entire pterygoid base that I'm drilling out. So I think, Kshitij, you can put us in PIP and go back to Richie.
Yeah.
Any questions relating to the surgical procedure per se?
So I have a last set of questions with me right now. Let me just take you through them. So there was a question on how to pack the cavernous sinus, which you showed us. When will you use Surgicel? So will you put in post-op
I will be putting Surgicel in the cavernous sinus. You know those things that I made, those Frankies I made. Okay, wait, just a minute. This, which you see, this is where the palatovaginal canal would be. Okay, this. Okay, so that would be the Vidian canal, and this would be the palatovaginal canal. It's not seen here. It's not widened by tumor involvement, but otherwise that is where the palatovaginal canal would be.
Possibly was bleeding right now.
Drill.
There was also a question that how to approach tumor.
Packing will be putting 2 net cells.
Yeah.
1 or 2 net cells. That's it. And the cavernous sinus, I'll be packing with Surgicel.
Right. How would you approach a tumor with parapharyngeal extension and greater wing of sphenoid? I mean, they're two different
So
questions.
greater wing of sphenoid, just a minute. Greater wing of sphenoid is that we would follow this tumor here.
Laterally.
This is the greater wing of the sphenoid. So we would open up all the bone here and then deliver it out under vision. As you must have seen, all the extensions are removed under vision. Okay. So even the greater wing, this is the greater wing of the sphenoid. If it is widened and there's tumor inside it, we would drill out all the bone, see the extension, and then gradually deliver it out from there with all its, satellite extensions. They're usually tiny extensions. So we would deliver it like that.
Right.
Okay.
Yeah. Yeah, I think that's the end of the questions asked. You already spoke about the fat prolapse and the orbit.
Okay. So you see now, if it's done right, if it's done right, then at the end of the thing, the field is absolutely, there's no bleeding.
Yeah, well appreciated.
Can you see that? So this is, if it's done right, if the whole tumor has come out intact, it's not torn anywhere. If you've taken care of all the bleeders, there you can see the maxillary artery pulsating.
Yeah, that's that's the artery pulsating.
Okay, and if you've taken care of all the bleeders, then at the end of the surgery, the field should look like this.
Yeah.
Okay. And now we can go off air. Is there anything else we need to do? Yeah, we can go, we'll go into a PIP and please ask Dr. Janaki Ram to start.
Yeah, we're just looking to switch.
Yeah, actually my watch here shows 12:02.
No, you're doing very well
So-
on time. And we'll just
Okay.
take a short, maybe 2-minute break also if people want to stretch around.
Okay.
I think I see Dr. Janki ready, or this somebody.
Yeah. So, give me scissors.
Hi, good afternoon, Trichy. Dr. Monica, is it? Monica, you're not heard yet.
You're not heard. You're not heard. Wait. Wait. Switch on my mic too.
Dr. Janki, good afternoon. You heard very
Good morning, everyone.
Good afternoon, Dr. Sitij. Good afternoon, Dr. Bradu, madam.
Good afternoon.
Yeah. Now,
Welcome to ASCENT.
thank you, madam. It's all your blessings. So, yeah. So,
No, Janki, it's not. My blessings are always there, but it's your doing. See, this is the palatovaginal canal here. Okay,
No,
this is
just
where
hang
the
on.
vaginal process of the medial pterygoid meets the ala
No,
of the vomer.
Just if you could hang on for a second, because they have. Yeah, now you can please continue.
Should I? So this
Yeah,
is
yeah,
the
please go ahead.
palatovaginal canal. This is the vaginal
Please
process of the medial pterygoid, and this is the ala of the vomer.
Yes.
Okay, that's it. I'm done now.
No,
Finally
but you're
done.
still online, because I think we're on Zoom possibly, and we can hear 4 microphones on.
you can show my face.
Yes, you're on to Dr.
No, you can
Janki,
shut.
and,
Mera microphone shut kar do.
and we could hear Dr. Monica too. So I think now madam is muted. Dr. Janki, you are on.
Hello.
Yeah, we can hear you.
Just a minute. I'd like to thank Dr. Kanchan Rupwate, the entire team of anesthesia, Dr. Shivali, Shrekha, and of course, my partner in crime, Dr. Anaga Joshi, and Dr. Pushkar. Thank you so much,
Perfect.
everyone.
We'll
and
see you guys in the
sister,
auditorium
and
in
sister
about
in
some time.
charge. Okay.
Yeah, we'll see you soon here. That's the third applause. Okay,
Hello.
Dr. Janki, you're on.
So, very good morning, everybody. First of all, I would like to thank Professor Renuka Bradu, madam. In fact, this slot was supposed to be, I think, for Professor Castelnuovo. And unfortunately, he couldn't come. And one fine morning, Dr. Bradu, madam, rang up to me. She asked, can you do a live? I have great respect and regards for Dr. Bradu, madam. And I have been following her since 1998 without her knowledge or with her knowledge. And I'm a big fan of her because she was the first lady in India, or maybe perhaps in the world, to start doing a tumor, which is actually a very dreaded tumor called the JNA. And I have seen her classification, which is very, very sort of, original. So I like people who do original work. And so I really thank you, madam, for this wonderful, lovely opportunity. And I'm sure that the delegates would be enjoying the ASCENT. ALCHEM has always been an academic forum, and it has always tried to propagate academics. And we from Royal Pearl are proud to be associated with this particular event. So to tell something about Professor Castelnuovo and his team, I have been there at least 4 to 5 times in Varese as a faculty, and all the Italians, all the Italian friends I have there, Professor Castelnuovo, Professor Paolo Battaglia, and then Dr. Puya, Dr. Dalan, Professor Piero Nicolai, so many. And now we had Alberto Strider and his resident called Francesca, who came from Milan to our center for training. So we have a strong association with Italy. And I'm sure there are 2 Italian faculties here. And really proud to see Professor Bradu, madam, bringing, the faculties from Italy. Now, without much ado, I have 1.5 hours to demonstrate this case. It's a case of pituitary macroadenoma. And I am giving the mic to Dr. Monica, who is our fellow, and she will brief you about the case. Dr. Sitij, are you there?
Yeah, we're with you. and we can see
Okay.
Dr. Monica on screen.
Good afternoon, everyone. I'm Dr. Maunika, fellow at Royal Pearl Hospital, Trichy. Thanks to ASCENT Advanced Surgical Conclave ENT for giving us this opportunity for performing a live surgical demonstration of pituitary macroadenoma case. Sir has a very good relationship with Professor Brado Madam and Professor Castelnuovo sir. This surgery is based on the book which is authorized by Dr. Janakiram sir. Coming to the patient details, a 27-year-old male who is a resident of Maharashtra, a software engineer by occupation, has presented to the ENT outpatient department with chief complaints of blurring and double vision since 5 months. There is no history of headache, no history of vomiting and fever, no other comorbidities. Coming to the examination part, in the nose, there is a DNS to right, ear bilateral TM intact, and the ophthalmic finding is normal fundus. In the visual field, bitemporal hemianopia was present. And in the investigations, cortisol levels are 16.61, prolactin is 11.35, free T4 1.13, and TSH 4.17. HbA1c is 6. I would like hand over mic to Dr. Janakiram sir and request sir to discuss the MRI of the patient. Thank you.
Okay. Did you hear the history?
Yeah,
Toxicity,
thank
sir?
you for that.
No, I have a mic. Hello?
Yeah, we got the history. Thank you.
Okay. Now, actually, this patient is a patient who presented sudden history of blurring of vision. And then, of course, he had bitemporal hemianopia and headache. And on examination, first of all, in a pituitary, we first check the hormones and whether it's a secretory macroadenoma or a non-secretory. And this is a non-secretory macroadenoma. So the aim of doing a surgery in a non-secretory macroadenoma is decompression of the optic nerve. That is the primary aim.
Right.
Of course, total removal would be definitely preferred, provided there is no morbidity and mortality. This is clear. But in a secretory macroadenoma or a microadenoma, the aim of surgery is complete, total excision, because you don't want the patient to have hormones again. Now, whenever we are looking at the pituitary, we should always look for the CT scan. The CT scan gives you an idea of how the pneumatization of the sphenoid is, what kind of pneumatization it is, and of course, the presence of Onodi cell, the septum, and things like that. So this patient had a septal deviation towards the right side, gross septal deviation towards the right side. And so planning of reconstruction always before tumor removal carries priority. So the best, as you know, is the workhorse of the skull base, is the nasoseptal flap. My friend, Professor Gustav Haddad, whom I've met a lot of times, we had several discussions. I really love him. And this is, dedicated to him. Whenever I take a flap, I tell his name. Well, the next investigation of choice is the MRI. So what you see in the MRI, number one is the T1. For the T1, you should look for the following things. Number one, whether the presence of apoplexy. Number two, presence of normal gland. Off on it. Where is the normal gland? It is seen in T1. So the pathology is seen in T2. So you will see whether the tumor is involving the cavernous sinus. How is the consistency? A rough estimate of the consistency of the tumor. If it is got to be heterogeneous, then it could be liquid.
Dr. Janki, we have your audio, which we've lost now. Your video is frozen. And if you could hear us, we are currently not able to hear you. Soin OT, we have your endoscopy picture with us. We've lost connection to Janki for a bit. We're just looking to re-establish. There's a So that's the packing material that's being used in itself, and tamponade on the maxillary artery.
This is our picture. हाँ क्या हुआ भाई? हमारा इंटरनेट तो अच्छा है. हेलो
Hello.
हेलो
Hello. Sir, you're heard in the auditorium, sir.
हेलो Can you increase your volume, Dr. Satish? I can't hear you.
Hi, sir. Good afternoon. I'm Dr. Gopi Shankar.
Hello.
Now we can see you and we can hear you as well, sir.
Where did you lose me? From which sentence?
Actually, at the starting of T2 MRI images, that is where we lost you, sir. So can you please continue with the MRI scan, sir?
Okay.
The T2
So
images. Yeah.
So in the T2, we have to see the heterogeneity of the lesion. If it is heterogeneous a little bit, then nobody can say for sure whether it is liquid or solid. This is for sure. There have been several studies. So a fair degree we can make out because some parts of the tumor can be solid, some parts can be liquid. So basically it is true, but T2 gives a fairly good, idea. But more important would be the T1 with contrast, fat suppressed, and also the DWI. So diffusion weighted images. So now in the T1 with contrast, if you look for hyper intense, like a potato, something very, very homogeneous, hyper intense, then you can for sure say this is going to be a solid tumor. And diffusion is restricted. And also, if it is going to be a solid tumor, your plan will completely change. It is not the same as a liquid tumor. So what is the difference? I will tell you during the surgery. Now, without much ado, I have time. How long can I operate?
We're looking at 1:30, but you take your time. Don't no pressure.
Yeah, max will be 2.
All right.
Because so many delays in between. Now let us see this. First, I'm going to show you the T1 image. Can you see here the T1 image here? You can see very, very clearly.
Yes.
T1, always look at the coronals. You can see that this is normal brain.
Right.
And you can see here that that's a sphenoid sinus, that's a lateral recess.
Yeah,
You can see that the tumor is protruding. The cella is widened. The cella is widened here. And you can see the cellar component. This is the cavernous carotid. And you can see a supracellular component compressing on the third ventricle. And you can see here that this part of the tumor is slightly darker than this part.
Yes.
And of course, there's no cavernous sinus involvement as such. And it's going down right till the level of the paraclival carotid here.
Yeah.
So now I'm just not able to see the normal gland though. Let us go to the T2. When we see the T2, you can see that is definitely heterogeneous enhancement here with definite fluid, liquid or bleeding here. You can see that very clearly that this is a liquid part of the tumor and that's a solid part of the tumor.
Yes.
And you can see that this tumor is going right behind and that's a basilar artery. Cavernous sinus not involved in this case. This is the bifurcation of the carotid artery. Now looking at the SAG, so you should always look for, there are two important things in SAG you should always look for. One is called the type A and second is called the type B tumor. What is a type A tumor? You draw a line from the cellar floor straight up. If it is extending anterior to this line, then it is called type B tumor. If it is extending posterior to this line, it's called type A tumor. So this is essentially a type A because you have a different approach for a type A versus a type B.
Right.
So this is actually the type A tumor. And same way, you should always look for the clival component type A or type B. So if you draw a line from the floor of the cella, this is the floor of the cella, we're extending down to the clivus here. It might go like this. It's called the type B. And if it's going up, it's called the type A. So type B clival tumor or type A clival tumor, type A planum tumor or a type B planum tumor. So this is, then you can see here the normal gland. This is the normal gland here. Very beautifully seen normal gland. It's like a cap. It's like a pancake appearance. We call it the pancake appearance. And of course, this is going right high, very high. But honestly, the upper part of the tumor is a little liquid. So it's sort of easy. Now we'll go for the contrast. Take this off, put the contrast, and there we will get an idea of the definite consistency of the tumor, how it's going to be. Now you can see here, that's a contrast. And definitely it is not iso-intense. It is, you can see heterogeneous in appearance. So definitely it looks like a liquid tumor. The upper part is liquid, lower part is, jelly-like. and seems to be a straightforward case. I'm going to start the case without much ado, and let's get started. Okay.
Sure.
Right. Let us have it two-way communication so that we'll have a lot of questions. So the audience can have a mic and they can actually ask questions.
Yeah.
Let's make
we'll
it
keep going
absolutely
there.
two-way.
Yeah.
So since I didn't have much time, I had to do a few steps before. I couldn't show all the steps to you because, in 1 hour,
Yeah, that's all
maybe
right.
I'll
Just
do
walk
it
us
for
through the
45
steps
minutes
you've done.
now. Hello?
Could you walk us through the steps that you've done?
Yes. So the first step was there was a gross septal deviation here. So
Okay.
I did a septal correction here. So that was the first
Okay.
step I did. And then hey, can you put on the light? The light is not on.
Yeah, there's
Light. Full. Wait. Pause. Now you can see here, this is actually the septal correction done. And you can
Right.
see here that what I did was I have done a posterior ethmoidectomy and
Yeah.
I took a Haddad flap here. So that's the
right.
nasal flap which I've already done because, so these are steps which if you want to do a pituitary surgery, then you should be very conversant to at least to take a Haddad flap. So I'm
That's
not going to show that. Of course, you can see that book in which I have a lot of videos on that. So you can see here what I did was I have done the nasal septal flap. That's the nasal septal flap. And where do you
Yeah.
park this nasal septal flap? You park it in the choana. If it is going to be a
Correct.
clival tumor, we park it in the middle meatus. So we create a middle meatal antrostomy. So here we are. I parked this in the choana.
Yeah.
Now, the next step which I did was, you see here, that's the planum. You always visualize the planum. That's the planum here. And you can see very beautifully the owl's eye appearance. Can you see the owl's eye appearance, my dear friends?
Yes. Yes.
Very beautifully seen owl's eye appearance. That's a posterior ethmoid on this side. Now, what did I do on this side? On this side, I lateralized the inferior turbinate, lateralized the middle turbinate, and I did what is called the rescue flap. It's called the rescue flap. This is called the rescue flap. So basically, either we do bilateral rescue or because it's very high suprasellar, I did a nasoseptal flap. Or else basically what I do nowadays is I don't even harvest Haddad flap. I do a bilateral rescue flap. Because most of the times we don't produce a CSF leak. So see here, that is the, so till what? So there are some nuances in this. Till what level should you raise the Haddad flap? Give me an elevator. I want to show you what is the technical nuance involved in this. So basically, what you do is you raise it till the level of the palatovaginal canal or the pterygosphenoid synchondrosis. This is the, you can see the synchondrosis here. You can see here. Can you see here very
Yes.
clearly? So
Seen,
till
sir.
the level of the pterygosphenoid synchondrosis, you raise this flap. And this side also, you have to do the same thing so that you can do what is called the shoulder osteotomy. That's called the shoulder osteotomy. So
Okay,
it's very clear now. Till now, you can see the owl's eye appearance. That's the rostrum.
Yes,
This
sir.
is the keel. That is the palatovaginal canal. That's the palatovaginal canal on this side. So this is the final view you get after the nasal stage. From
Yes,
the
sir.
nasal stage, I'm going to start getting you through. So basically, I want to tell all the fellows that don't take a Haddad. Haddad is an overkill for a pituitary, in my opinion. So try to take a rescue flap. And if necessary, you can convert it into a nasoseptal flap. This is my take on pituitary surgeries. Right.
Right.
If you're going to do an extra capsular dissection, if you're going to do an extra capsular dissection, if the tumor is firm, then go ahead with a nasoseptal flap. If it is not a firm tumor, then don't go ahead with a nasoseptal flap. So this is my formula for taking up. So I'm doing, you can see the outside camera. Can you show? So Dr. Shiva, can you show the outside camera? So how we stand, it's typically the Pittsburgh group. I got trained by Professor Kassam and exactly following him. And you can see here that this is how we operate.
No, we don't have the external yet. Yeah,
Can you
okay.
see
Now
now?
we do.
This is
Yeah,
how
now
my
we do.
table setup is. And you can see here that Shiva is holding the scope like a baby. It's called a baby hold. See that? You hold that like a baby. And I stand behind. And there's of course, Professor Karao, what he does is he also irrigates. but I have a person just in front, Dr. Monica is going to irrigate. So I have the luxury of 2 assistants, but if you don't, then you can have a table. You can have a table here to rest, and left hand can hold the camera and right hand can irrigate. So that's how Carl Schneiderman and Paul Gardner do it. I mean, we just change a little bit because I have one more assistant. Now I'm now going to start my triple osteotomy. This is called the triple osteotomy. You can see how I lean on the patient now.
Okay. Please go ahead.
Yeah. Now I'm just going to go here. And you see that is actually a Karl Storz S3 neurodrill system. Now you see here, the first cut will be given at the level of the planum. See that? So that's the first cut I give at the level of the planum. I like this irrigating drill, of course. Some people don't, but I love the irrigating drill. So that's the intersphenoidal septum there. It goes towards one of the medial opticocarotid recesses. Now here we are, when you have a rescue flap like this, suction block. So this is what is called the shoulder osteotomy, suction block. So this is what is called the shoulder osteotomy. So you go along the pterygosphenoid synchondrosis here. You see here. So let me show you how we do that. So Shiva is slightly new to four-handed. Pardon for his views if he is creating, because Shilpi is my usual surgeon who holds. She's in Hyderabad now. She has taken over as the director of Hyderabad. Now you can see here that you see how to prevent the nasoseptal flap from rotating from the drill. That's a small trick. Don't drill like this. See, half the drill out, half the drill inside. Instead of that, go fully inside. And then you see here, you can drill like this. So it's by sort of rotation pressure that you do that. So you can just come out like this. Of course, your suction can also prevent it. So see that. See, my whole drill is inside. Can you get that point which I'm trying to tell you? So that is very, very important. That's the shoulder osteotomy which I've done on this side. And I'm going for the shoulder osteotomy on this side. But here now the suction is holding my drill. You can see that. Now I go for the U-turn of the car. I call it the U-turn of the car. I just turn towards the midline. See that? Now I turn towards the midline. And then see that. Now you can beautifully see that the whole rostrum is coming out now. You can see that. I've removed the rostrum now. I mean, made it so fractured the rostrum. Basically, some people use the mallet and a gouge or something like that. But of course, it's not the instrument. I always say it's not the instrument. It is the man behind the instrument which matters. Like Professor Bradu showed a beautiful JNA surgery with a diathermy. So basically, whatever works in your hand, use it. It's not that you have to. There's no one way to bell a cat. Please understand that. So surgery is all about your experience. Whatever works in your hand, that's very, 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 very important. Now here we are. You can see that very beautifully that we are exposing the sella. Now, what are the boundaries of sellar exposure? This is very, very important. Give me the drill. So basically, I'm going to give you the mathematics of the exposure. So the first step is expose the sella. The sphenoid exposure starts from the planum. That is the planum. So this is going towards the left MOCR. You can see that this intersphenoidal septum is going. So we generally don't take the scope out. The irrigator actually helps to prevent the fogging. So here we are. So I'm trying to get that something very, 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 very there is something over the drill bit. So the formula here is get till the level of the planum above. Okay, do we have to do a transplanar approach in this case? That's a question I'm going to answer to you later. Now, this is what I'm going to do, take off the, whenever you take the mucosa, you see what my assistant is doing.
some
She
bleeding,
irrigates a lot
Yeah.
because the sphenoid mucosa is very vascular.
Yes.
So she keeps irrigating. That's the best way to control bleeding during this step. So that is the first thing you should learn, because you might have bleeding, and don't worry, sphenoid mucosa is vascular. So that's it. So that's the first step. Yeah, stop. That's the first step we have done during the sphenoidotomy. The next would be, that is the tumor. You can see that. Give me a drill. Now, where do you stop drilling in the sphenoid sinus? Above is the planum, as I already told you. Now you can see the mucosa there. So
Yeah.
you should be very fanatic about exposure. Exposure is very critical in pituitary surgery. Whatever surgery, craniosurgery or whatever. Now I'm now going to take that bone out. Give me a drill. So there will be a little venous bleeding from the sphenoid mucosa on the scope. So my assistant says on the scope, and then she irrigates. So that's how we have trained our fellows. You can see here,
Yes.
that's the non-dominant sphenoid. That's a non-dominant sphenoid. And you can see here that we are actually trying to open up the non-dominant sphenoid too. Why? Why should I open the non-dominant sphenoid? Because I have to get the optic to optic exposure.
Right.
Because the optic nerve will be there in the other sphenoid only. So basically, get optic to optic exposure. This is the most important part of the lateral exposure. So I told you the superior exposure is still the level of the planum. The lateral exposure will be till the level of the optic nerve. So that's the orbital apex. On the scope, see how beautifully we are able to get that. So the critical point here is the exposure. Again and again, once the exposure is done, it's a matter of a few minutes to get that tumor out. Tumor out is no problem at all, provided you get that exposure very well. Now, I'm going to take off the mucosa from the left sphenoid sinus. Get ready with a little irrigation, my dear friend. Go inside, my dear friend. Okay, so you have that sphenoid mucosa. No. Not on the scope. Not on the scope. Yeah, see that mucosa coming out? Can you all appreciate that clearly?
Yeah, we did.
Why
Yes,
you
we
want to
did.
take off all the mucosa? Why you want to take off all the mucosa? Because you're going to place a nasal flap at the
Yes.
end. Sometimes
Yes.
nowadays what we are doing is take mucosal flaps from the sphenoid sinus itself. So
Okay.
that's something which we have started doing. Of course, now we have started taking bones also to cap the whole sphenoid sinus. Now I have done my superior exposure here. That's the planum here. I've done my lateral exposure, which is the optic to optic, carotid to carotid. But what is going to be my inferior exposure? That's very, 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 very important. And the answer to the question is 2 suction tips below. You should have one, see, the only one suction tip now. I need 2 suction tips below the level of the floor of the sphenoid sinus. So that means I have to remove this keel completely. Or sometimes I even drill off the floor of the sphenoid sinus. So that's what I do. You can see here, see beautifully that I'm going to drill that out. Now drill. So that's it. So I'm going to drill that out. So it's called 2 suction tip exposure of the floor. So floor, that means the floor of the exposure will be 2 suction tips below the lower level of the tumor. Dr. Sitich, you can stop me for any step. You can ask questions. I think my Italian friends are also there. Are they there?
Yeah, you have Professor Alkis and Professor Mario here. I'm just going to hand over.
Yeah,
to
you can give the mic to them and ask them to just keep talking.
Hi, Janaki.
Hi, how are you, my dear friend?
Hi, it's great to see you live
Yeah.
in surgery.
Always great to see my Italian friends, I think we have met several times in Italy. And I'm sure you are in touch with Paolo Battaglia, like my brother.
Yeah, for sure. Daily.
Yeah, daily. I love them. The suction block. Paolo.
You are doing a great job.
Thank you. But this is a simple case. Not a tough case at all.
You are exposing all around the landmarks, yeah, before approaching the tumor.
Absolutely.
This is really important to have under control all the landmark all around before approaching the tumor.
Absolutely. Don't touch the tumor unless you expose. That's very, very important in skull-based surgery. Spend a lot of time in exposure.
Yeah.
So you can see here that I'm taking off the clival mucosa, and you see what my assistant is doing. She's irrigating. Irrigation. See, I'll tell you, the brain likes two things. Number one, it loves water. I always say, the brain loves water, man. Why? Because as you irrigate, the bleeding comes down, number one. Number two is you hydrate all the flaps. So the most important thing in skull-based surgery is one person keeping on. Even yesterday I showed you the acoustic neuroma live. I do live every day. And I told you in the acoustic also the same thing. When you are operating on the brain stem, keep irrigating. So irrigation, the brain loves fluid. Okay, here we are. Now I'm going to take off this keel. I don't like to have this keel when you have the tumor jutting down, because that's going to obstruct. See that? I took that out now. Now, what is the advantage of retaining the keel? Professor P.J. Ormold has got his own, theory of retaining the keel. He retains the keel. Why do you want to retain the keel? Number one, it protects the nasoseptal flap. Number two, if you don't have landmarks, if it's going to be a conical pneumatization, then the keel acts as the center point where your assistant gets oriented. But here, it's a very nice pneumatized cella, and you have all the landmarks. So that's why I decided to take off the keel. Get my point?
Yeah.
So that's very, very important.
Point well taken.
See how I'm drilling the floor.
Janaki, I have another comment for you. I'm Mario. I really appreciate the fact that you have removed mucosa from all the recesses of a sphenoid, because it's important finally in the reconstruction phase, in order to improve the possibility for reconstruction. Is important that the mucosal flap will stay directly on the bone without mucosa underneath, in order to increase the reconstruction efficacy, and also in order to prevent mucocele. So
absolutely, very nice point, well taken.
It's very important that you are removing mucosa from all the small recesses of a sphenoid, because this will help the final reconstruction.
Absolutely, I fully agree with you, Blue. So here you see, I'm now trying to get that completely out of my view. Of course, this is the rescue flap. I'm using the blue of the corblator. I am a guy who uses the corblator a little bit, not much. I don't indiscriminately use any instrument. I love the cold steel. The cold steel is what I love. If I'm given a pair of scissors and allowed to operate, I'll be the happiest person. Give me another coblation again. So if you give quickly. Coblation, yeah. So here I use the coblation. I know Professor Castello uses the laser a lot. I've seen him using the laser. Okay, each one has his technique. Now, give me a drill again. So I am very fanatic about small pieces of bone exposure. I'm trying to break that with my weight of the burr rather than the drilling. See, there's a little bleed. Don't worry. Give me a cobblator. So you might ask me, see, you're cobblating that vessel. Is it going to compromise the vascularity of that rescue flap? You can ask me that question. Please understand, we have done several dissections and we found that there is no one artery, but there are 3 branches of the posterior septal branch. So it'll definitely. So there's another way that is called the Rubina camera. Go inside, which actually gives you a beautiful drill. Beautiful view of the vascularity of the flap. And for that, you can get the Rubina camera from Karl Storz. That's also another good way to see the vascularity. Okay, now again there's a little bleeding. Give me cobblator. So see how fanatic I'm about bone removal. That's the pharyngeal artery.
Is from Italy. I would like to ask you: do you start your surgery for with 2 hands since the beginning, or you do the first steps by?
Oh, that's a great question. That's a great question. So when I do the nasal part, I use the debrider. Give me a pack. So it's basically 2-handed. Now I'm going 2-handed. It's the nasal phase is primarily 2-handed. When I go for when do I switch to the 4-handed technique? It is when I have exposed the sphenoid os, that is the owl's eye appearance. From there onwards, I go for the 4-handed technique. So here we are. I'm going to give you a complete view of the anatomy and the exposure, which we have done for the face. The sphenoid face now is complete. Give me a coblation, please. Okay, right. You can see that the tumor has slightly, protruded through the cellar floor. There's a little bit of mucosa here. Okay. Give me upturned Blackesley. You have lateral recess, as I showed you in the MRI. You have lateral recess. Be careful. Yeah. Don't close the lateral recess. I have seen 2 cases of mucocele in the lateral recess after completely closing it with the mucosa. That is something which you should never do. So I will take care not to close this lateral recess. Remember that. Now give me an irrigation. This is very important. Now that's going to be my final exposure. And for the sake of the postgraduates and the young consultants, I'm going to show you the landmarks here. Okay, right. Feel free to stop me, my dear friends. Okay, now here we are. So what is the landmark? So that's the planum here. Right. This is the tuberculum here. This is called the tuberculum. So what's the tuberculum? Tuberculum is a strut of bone between the 2 optic nerves. And the lateral part of the tuberculum is called the lateral tubercular strut, otherwise called the MOCR. That's where the carotid and the optic, that's the optic, enter into the intracranial structure. It is not a true structure. It is only an imaginary structure. The medial opticocarotid recess never exists. The middle clinoid exists sometimes. So this is something which you should understand. Many people say, show me the MOCR. MOCR is the lateral tubercular strut. That's it. This is the region. So if we want to do a craniopharyngioma, we have to remove this MOCR on both sides. Now you can see here that this is the carotid artery. You can see that's the carotid artery. That's the carotid. This is the what part of the carotid? This is the clinoidal carotid. Of course, you don't have the lateral opticocarotid recess very nicely defined here, which is otherwise called the optic strut. The optic strut pneumatizes to form the lateral opticocarotid recess. And the anterior clinoid process gives off 2 processes. One is the superior process or the anterior and the posterior wings. And between that, you get a pneumatization called the lateral opticocarotid recess. And the superior wing sometimes can get pneumatized from the supraoptic recess. So that's all significant in meningiomas. So you know that we have a huge series of meningiomas. I have given that in my book also. So we drill the optic canal in meningiomas. That's very important. Now you can see that's the optics. That's a carotid here. That's a carotid. Do we have to expose the carotid? This is a matter of how we read the MRI. If it's going to be a solid tumor, then we always expose the carotid. We always expose the carotid if it's going to be a solid tumor. Then you do what's called the extracapsular dissection. If it's not going to be a solid tumor, you don't have to expose the carotid. So this is very, very important. Now let me go ahead. That's a clival recess. You can see that beautifully seen clival recess, all of you. That's the floor. I have two suction tips, beautiful exposure. The optic to optic, carotid to carotid, planum, two suction tips below. And this side is the rescue flap. This side is the Hadad flap. Any questions so far? I'm ready to answer.
I think everybody's just watching. I think it's going on beautifully.
Right. Now I'm going to start my cellular phase. See how I start drilling the cellular phase. There are three techniques of drilling the cellular phase. You can start from above downwards or below upwards. But since the tumor is already eroded, I start from above downward. Usually I start from below. I just go like this. And then what I do, I raise a bone flap. I raise a bone flap and close that like a lid. Like a lid, I close it. So that means you don't want to waste that bone. Now here we are. What I'm going to do is, see, this is the carotid artery. Don't go like this. Never operate at vertical plane to the carotid. Go along the carotid. See that?
Yeah.
And always your bar should be like a paintbrush. It should be like a paintbrush. And the best instrument, I've seen the Pittsburgh group, they use a lot of punches. Generally, I don't use punches. Again, it's a matter of your convenience. Ultimately, you should get a good exposure. That's what you want. See that now. Come this side. Yeah. So Dr. Shiva and Monica are assisting me. They're doing a great job till now. And I hope they'll keep doing it till the end. Go closer. Go closer. Can you see the bluish dura there, please, all of you?
Very well seen.
Okay, having done that, now clean the scope. Give me a Rosen's elevator. Now there are some ear instruments which we use here. See how I use my Rosen's elevator. So that's the bone flap. Now what I do is, I see here. See what I do. 1, 2, 3, 4, 5, 6. And then gently try to elevate it. Of course, if the bone is in one piece, it's actually beautiful for you to reconstruct with that bone. I use that bone for reconstruction. You understand?
Right.
So that bone, don't waste that bone, because that's, to me, is a very good part of reconstruction. Now I'll just close it like a lid.
Yeah.
So here we are.
Here.
Yeah.
They're not related to the step of surgery.
I can't hear you, please.
I said there are a couple of questions not related to the step of surgery right now.
Oh yeah, please. Carry on. Whatever you want, you can ask.
All right. So one is a conceptual question. The question is image-guided surgery mandatory for pituitary?
Generally, I have two image guidance. We have the high-end brain navigation systems. Even in advanced intracranial tumors, I don't use the navigation. So again, it's a matter of convenience. So how you get trained, drill.
Right.
So it's a matter of convenience. So if you want to use it, yes. If you got trained in using it, yes. I don't see the necessity, because you do a lot of dissections. I'm exposing a little bit of the carotid here. Little bit of the carotid. That's a carotid artery.
Yeah.
And now I'm going in for, go closer. The tuberculum. That's the tuberculum.
Yeah. So the second question
Hey,
you could
come on.
answer as you keep operating. The question
can't
is on different intra-op hemostatic techniques.
Yeah. Best is saline. Best is saline, the hemostat. The best is warm saline at 40. But of course, the venous bleed can be stopped with flow seal, Surgicel, gel foam.
Right.
And arterial bleed, of course, you have to pack, weight, bipolars. And you can also use clips. So we have already got aneurysm clips, which we use.
Right.
Now, you see, what is the advantage of drilling the tuberculum in this case? Now, look at this pregnancy. I call this a pregnancy. This is maybe a 6 months pregnant. If I drill out the tuberculum, this becomes 9 months pregnant. So you can see now I'm going to show you how beautifully the pregnancy will increase. Oh, you see that? That's a small cyst.
Yeah.
See the cyst coming out. See that?
That's a
I
superior
told you the
component.
upper part is fully cystic.
Yeah.
Okay, right. Now I think I'm almost at the upper part. Let's
Yeah.
stop there, of course. And then I'm going to start my stellar phase of dissection. Okay. All of you happy with this step so far?
Yeah,
Any
it's going well.
questions? Give me a
Good.
Cadaveric knife. So I changed my table. There are 2 tables for me. I changed the table to no. Give me an elevator first. Give me a small.
Sides. Oh, you mean you change your side of the table, is it?
No, I have 2 tables for the pituitary. The nasal phase. Till this I have 1 table,
Okay.
and after this all the instruments change to the
Okay.
intracranial part of the stage.
Understood.
So I have all the pituitary Kasam set, or we have the Bitak set, and it's like that. So we change the
Understood.
table. Yeah.
Yeah, understood.
Okay. Give me a Cadaveric knife now. Zoom. Now I'm going for a little zoom. Yeah. So Shiva is zooming it. I use the Cadaveric knife. Cadaveric is a fantastic surgeon. I've gone there and watched him operate. He's also from Italy. Now I'm going to make that. Always I make the incision inferiorly. So you have a little bone there, a little bit bone there. Don't worry.
Do you prefer using bipolar on the dura before incising?
No, I don't. See, never use bipolar. The reason why you don't use bipolar is there are 2 layers of periosteum. One is called the endosteal layer. Second is called the meningeal layer. When you use the bipolar, both stick together. Okay, give me an elevator.
Okay.
Both stick together. No, not this elevator. Normal elevator. Normal elevator, please. Now give me the carotid Doppler. Carotid Doppler. Always operate only if you have a carotid Doppler. Please understand. In skull base, you don't need a navigation, but you need a carotid Doppler. This is something I keep telling all the skull base surgeons across the world. The carotid Doppler is a must for surgery of any skull base because okay, that's it. So here we are. So I'm now trying. I'm going to use my Doppler and show you where the carotid lies. Can you hear the noise? Just check. Can you see that?
No, we don't hear it, but if you're hearing it, we trust you. We need more amplification here.
You can't hear it?
No, not really. It's not coming across to us. But do you hear it there clearly? Yeah, maybe now. Yes, we do.
Yeah.
Yes, we do. On the right, we did.
See, I can hear it very well. Both. That's MOCR on both sides. That's MOCR. And that's a carotid. Can you hear it or not?
Yeah, we do. Okay, I do hear it. No, no, we trust you. It's not very loud here, but we do hear a faint beat.
See, the Zoom has got a filter where they filter off the high frequency noise. Give me the Kassam scissors. Now I'm going to cut the endosteal layer of dura. And only after you have traced the carotid should you do this step. It's very important that you trace the carotid. So I know where the carotid is. A little bit of bone here, it's okay. I made the incision here. You see that? I'm making that incision very, very, very carefully. I'm using my suction tip as a counter traction. This is very important, my dear friends. See how I'm using my suction tip here?
Yeah.
I use my suction tip as a counter go closer.
Right.
You see that? Now I go this side. I use my suction tip again. Now I tilt my Kassam to hit only the endosteal layer, my dear friends. I know the carotid is here. So if it's going to be a solid tumor, I would have made the incision slightly laterally. Please understand that. Now give me the Rosen's elevator. Okay, Rosen's, please. Now I'm going to remove the endosteal layer of dura. Go closer, go closer. Again, using my suction as a
as an elevator.
Suction is the counter and that is the elevator.
Yeah.
So usually sometimes what happens in such cases is that the dura, the endosteal layer of dura is infiltrated by the tumor. You can see here, there's a small tunica. That's a tunica of the tumor. So you have two layers. One is the endosteal layer and second is the tunica of the tumor. So here we are. Give me a scissors. See, that's a little bone there sticking there. Yeah, give me a scissors, please. So it's very important that if you have infiltration of the dura, then you have to resect that part of the dura.
Right.
Kami. Jai Shiva. In the side, Kami. In the side. Hey. Okay, right. Now give me the elevator, Rosen's elevator, please. So nowadays we start also suturing the dura. If it's not infiltrated, I suture the dura. I'll show you also maybe. Give me a scissors. There's something sticking there, maybe a bone piece or something like that. Give me a scissors, please, quick.
It looks like bone.
Yeah, the thinned out bone inferiorly over the dura is always a matter which has to be dealt with. Okay, I think I did it. Okay, give me an elevator now. Elevator. Right, give me the Rosen's elevator. Yeah, here we are. I'm now going here. Don't shake. There's still a problem. You see here, even though I've cut it, there's some addition here. Okay, right. Now you can see that I have now raised the dural layer. Can you see here very clearly, my dear friends? All of you.
Yeah.
In fact, the dura is a little infiltrated by tumor. I might have to resect the dura later. That I will do later. I will do that finally. Now you can see the tumor very, very beautifully. Can you all appreciate the tumor, please?
Yeah, we can.
Now, I don't know what is... Give me a tumor holding. So never pull at the tumor. This is something which I have seen being done by ENT surgeons. If you pull, that is not neurosurgery. You have to do micro dissection. You have to do micro dissection. So this dura, I'm sure, cannot be sutured because I don't like the dura. It's being... Come, go closer. So what I will do with this dura is I will take off the dura finally. So the first step is I'm going to take a biopsy. That's a biopsy.
Yeah.
That's a biopsy. Now give me 2 suctions. So we do what's called the 2 suction technique. I think in another 10-15 minutes we'll be through. Not a very difficult case, as I told you. Give me the suction. So we start with the 6 o'clock technique, 6 o'clock position. We have keyhole suction, and the Monica is going to irrigate when I suck. You see here, see my left and the right hand. It's like the Russian ballet dance. So we move it up and down. My left hand sometimes, my right hand sometimes. So you go there inside, and you have to see the leaf of the dura, the leaf of, see that irrigation, which Dr. Monica keeps doing. You have to go till the level of the dorsum. That's the dorsum. Always when you start the 6 o'clock dissection, go till the level of the dorsum. You get my point? So don't just stop because you know exactly. So that's the level of the dorsum. See, there's some infiltration of the dura by the tumor here.
Yeah, that was,
And I'm not happy about that. I'm going to take that out.
yeah, that looks thicker.
Right now, I'm not going to do that because you might have the inferior intercavernous sinus and that will start bleeding. Okay. Now, the next step is to use the cavernous sinus suction tip. So I'm going to use the cavernous sinus suction tip, and I clear the, give me the cavernous sinus suction tip. I'm going to clear the 9 o'clock position. The 9 is the second. The second is the 9. That's a 9 here.
Yeah.
You can see here that I use this. Yashoda. So whenever I do the 9, you see my direction of movement is always along the carotid. That's a carotid artery. See the meningeal layer of dura there. Can you see the meningeal layer of dura, my dear friends?
I appreciate that. Yeah.
Go inside, go inside. See the carotid, beautifully seen. Okay? Right, that's beautiful now. That's a carotid artery. Wonderfully seen here. And you will find something here. You see here, there'll be something going like this here. What's that? Anybody from the audience? If you lift that dura, you'll find a structure here. Exactly here. What's that structure? Ask the audience. Ask the audience what that is. If you lift that dura here, you'll find a structure here. Yeah.
Any answers? They're asking what's the price?
What is that structure? That is the inferior hypophyseal artery. Okay. So you will have the inferior hypophyseal artery right at the level of the, this is the 5 o'clock and that's the 7 o'clock. So at the level of 5 and the 7, you have the, see the carotid again. Always the cavernous is covered by the meningeal layer of dura. See the carotid. Can you all appreciate the carotid, please? Here you will see a white band. You find a white band just above the carotid. What is this? What is this white band? Anybody? Ask the audience what that is. You will find a white band here.
Sympathetic plexus.
That is actually the interclinoid ligament. Okay. So it is the boundary of the Pernick's-Keys triangle. John Pernick's-Key was a very fantastic neurosurgeon, and he described a triangle called the Pernick's-Keys triangle, which is otherwise called the oculomotor triangle. Okay, it's called the oculomotor triangle. You might have a patient with a third nerve palsy in a case of a pituitary, and those cases you have to attack the Pernick's-Keys triangle. So that's very important. So people might ask you, so you might have a 6th nerve palsy in a case of a pituitary. Where is the tumor going to hit the pituitary? So it's called the retrogenu region. This is the region here. This is exactly the region where the 6th nerve palsy occurs when you have a pituitary tumor, and that's called the retrogenu. It's called the Gulfar region. It's called the Gulfar region. And see here, this and this. So is the level where the 6th nerve can get paralyzed. Now what you do is you keep a little lint there. You keep a little lint. Give me a lint, neural lint. So I have cleared the cavernous sinuses on both sides. I have cleared the floor. Of course, there's a small, give me a larger lint. So now, how do you start your suprasellar dissection? That is very important. You should have a formula for it, you know, not like this. Give me a lint. Give me a lint. You should have a formula for it. Very, very important. Many people just do the suprasellar dissection. Don't do that. You have to start always from posterior to anterior, whether it's cranial, whether it's meningioma, whether whatever. So why you have to do from posterior to anterior? Because if you have done it from anterior to posterior, what happens is that the diaphragma starts falling, and then you will not see the hidden area, something like the sinus tympani in the ear. The sinus tympani is here. This is the sinus tympani of the pituitary. The postero-superolateral recess. It's called the postero-superolateral recess. This is where you leave behind the tumor very commonly. And that's actually called the sinus tympani. Now, what I will do now, I've kept the lint here. Give me a suction now, straight suction. See, I'm just using the straight suction. I'm using a straight 0-degree telescope. That's it. So I have another 10 minutes according to my time. 1:30. I will try to finish it off. The next 10 minutes. Ma, come out. Whenever you have your four-handed, he should not. See here. Now, you see here, I'm taking that up. See that? See the postero-superolateral recess. Can you see that very clearly, my dear friends?
Yes, seen well.
Very beautifully seen, the postero-superolateral recess. That is where the tumor is left behind, my dear friends. So here we are. Use the lint. Go and see the postero-superolateral recess. Now this is all the Billavada. Okay. Now after doing that, I have now very clearly seen the postero-superolateral recess, and now we have to go right on to the all the both lints out. Irrigate. Now that's the suprasellar component. Now give me. Suction. Okay, here we are. Now I'm going for the suprasellar component again with a straight suction tip. See here. Now I go from behind, not from anterior.
Yeah.
See that? It's all with a straight suction tip. Only thing is Shiva is trying to hitch against me. Keep irrigating, my dear friend. The problem is the moment the diaphragma descends, it's going to be a problem for you. Now, why do we have to do a transtubercular drilling in this case? Because I need to hitch like this here. I need to hitch like this and go up. Now the problem is, you see, this is called the inverse rose petal appearance. You see one petal here, you see one petal here, you see one petal here, you see one petal here. This is called the inverse rose petal appearance. I call this something like if your lotus is inverted, you have like this. The problem in this is that you will retain tumor in between here. So that is called the nipple. That is where the stem is, and you will have tumor there. So how do you get the tumor out of that area? That is very, very, very important in skull-based surgery. So I'm going to show you the trick to take the tumor out from that nipple. So that is actually the dorsum. Beautiful irrigation. See, you can see how nicely we are able to get the tumor out. You should keep irrigating. Please understand, there are two important reasons for irrigation. You have what is called the paradox of the saline. That means, you know what the Inca shadow is, right? Now give me what is called the Q-tip technique. I'm going to show you the Q-tip technique. So this is again published by the Pittsburgh group. So the commonest cause for CSF rhinorrhea in the diaphragma is the suction. So if it's a powerful suction, it will cause a CSF rhinorrhea. So the best thing is to reduce your suction now. Give me one more. So this is what is called the Q-tip technique. It's called the Q-tip technique. So how we do that is we press against the leaves of the diaphragma. See that? I'm pressing against the leaves of the diaphragma. That, can you see? Can you go closer? Go closer. Can you see here something yellowish in color here? I don't know if you can see that. I can see that very beautifully here. And that is the normal gland. Can you see here there? The normal gland is seen. See that? See that yellowish color? Can you see that? This is bluish here.
Yes.
நீ ரொம்ப இடிக்கிறடா என்ன பிரச்சனை நீ பாட்டுக்கு இடிக்கிற என்ன see here this is bluish here and that if you go laterally is yellowish in color so the yellowish color is the normal gland it has got vascularity now I'm going towards the nipple see that how I'm rising this is the normal gland here the normal gland is here it's like a pancake go closer see the vascularity can you see the vascularity here my dear friends
Yeah.
See here. Yes or no?
Yes, we do.
Yeah, give me a suction now. Now, give me the suction. I'm now going to see whether you have residual tumor at the level of the nipple. Hey, come out. Shiva. The most important thing, in my opinion, is to train a good four-handed surgeon. Because you can't work with people just like that. You have to train them. So Shiva has been trained for some time now and of course not equal to Shilpi. Shilpi is a different class in 400. Now you see that's a nipple. And now see the problem is when the diaphragma comes down like this, you might have retained tumor in the suprasellar quadrant. This is the commonest thing we have found for the cause for the recurrence. So how do we actually get that tumor? Now give me a big lint. So what I am going to do is to just press. This should be a fanatic experience. You cannot leave behind that nipple of the rose. See here. Now you should go at least once or twice. Move the leaf of the diaphragm upwards nicely. Now you go and show me, man. Now I will see whether. So you can see the bluish diaphragma here. Can you see the bluish diaphragma? The difference between the bluish diaphragma and see that's the yellowish diaphragma here. Can you see the difference, my dear friends?
Yeah.
Now I'm going to see. Give me a curved suction tip. Now can you show this way? Yeah. Curved suction. I'm now going to press that right up and see where this can go because it's a very high suprasellar tumor. I don't want to leave behind anything here. This is the area. So I'm going to push the diaphragm. Hey, காமிடா என்னடா நீ நவுற நீ இத காமிடா So it's called a rollover technique, right from behind or from anterior. Anterior posterior or posterior anterior. I have to see that area or else you will leave. But of course, in this case, I'm sure I've cleared the tumor. Why? Because the suprasellar part was liquid. Okay, if it is solid, then I have to see. So, and believe me, there are some tumors which have got caps. We call it caps, topi. We call it topi. And those tumors, there's a bright chance that you can leave behind tumor behind. Of course, in this case, I'm sure that, please understand that descent of the diaphragma is not the end of the surgery. Many people think the descent of the diaphragma is the end of the surgery. To me, that's the beginning of the surgery. That is the anterior leaf, the right leaf, the left leaf, the 1 o'clock leaf. That means this should be the level of the stalk here. And since it's a liquid tumor, I am very sure that I have cleared the tumor completely. So Now, what is that which I have to do? Give me a through biting. So, I'm very, very sure about the tumor clearance in this case. So, there is no CSF leak. Try not to produce a CSF leak. So, what is the commonest cause for a CSF leak? The suction. Believe me, it's the suction. So, you should reduce the suction pressure. The suction pressure, give me a through biting now. So, I'm going to take off that part which is there inferiorly along the dural leaf. See that? You might get a bleeding, don't worry. I'm not pulling, I'm just through biting it. See that? Can you see that, my dear friends?
Yeah, we do see it. We see it well.
You might get the inferior intercavernous sinus. Don't worry. We are not afraid of any cavernous sinuses. We are afraid only of the carotid. Even that, you should know how to manage carotid bleeds. So, okay, I have taken them out. I'm going to take off the dural leaf. I'm sorry, I'm not able to show you the suturing technique. Usually we show the suturing technique. That's it. See that now? Can you see that very clearly? Now, give me Blexley now. I'm going to take off these two, something like dant. Hathi ka dant hai yahan pe. Take that off. You don't need all these, bone pieces. Now I'm going to irrigate. Now, what I will do now is I will irrigate. And should I use a nail septal flap? Really not, actually, in this case. But since there was a small arachnoid, I'll show you the arachnoid there. I don't know if you saw that. I saw the arachnoid there. Oh, so that is the only reason why surgery is ready. See, I'll show you where I saw the arachnoid. Huh? No, nothing. Give me a irrigation.
I'm Mario from Italy. I have a question for you. Do you
Hello? Yes, Dr. Mario.
Hi.
How are you?
Fine. Have you ever used at the end of a procedure the so-called diving technique, which is a sort of irrigation directly with the irrigation system of a telescope? And basically, you have to press the pedal of irrigation in continuous way and go very, very close with the scope in order to remove very, very small remnant of pituitary tumor, for example, from the dural layer of the cavernous sinus and so on. It's quite easy and good in order also to visualize structures. It's a sort of irrigation.
Elevator. So that's a very good question, actually. That it has been described called the hydrodissection technique. So give me the pituitary elevator. So basically, we use hydrodissection technique. I told you it's called the saline paradox, the same like the Inca shadow. So whenever you use saline, what happens is it looks as if the tumor is nearer. So that is very, very important. I fully appreciate that comment from you. So basically, what we do is we use irrigation while dissection. So that, that small residual tumor, go closer. Now go closer, please. See the normal gland? That's the cavernous sinus. Can you see that cavernous sinus, the carotid? All of you?
Yeah, it's well visible.
Is it clearly seen, Dr. Mario? Now this side, again, I'm going to show you the cavernous sinus. See that carotid artery? Go closer, closer, closer. See the carotid artery. Can you see that very clearly, my dear friends? Now go up, go up. Now, this leaf might have a little tumor. See that? You have to be sure that you have removed all that tumor. See how she's irrigating now. Give me a curette, a small curette. See how the diaphragma, oh, there's a small leak. It's okay. That's not a problem. Give me a curette. So I told you there was an arachnoid here. This is the arachnoid here. A little bit of the arachnoid was seen here. So that was why I actually wanted to close it with a... Okay, you might ask me, how do you seal this leak? So there are two ways of sealing this leak, of course, with a... Give me a bipolar. So am I exceeding my time? I can stop. You want me to stop?
On time.
Ah,
You're good on time, so you can continue the surgery.
so you see, I want to show you if there are small leaks, how do you stop it? The best way is to use bipolar. See here, I'm going to use the bipolar. Bipolar seals leaks, and neurosurgeons use that very often. And you see here how I will be using the bipolar now. See here, that's a small leak there. Can you all appreciate that? Now you see that fluid coming out, right?
Yeah, we do.
Now see here now. See that? See what happened? Sedius, can you see that or not? So
Yeah, we
this
do
is
see
one
that.
way you use the bipolar sometimes, and you can actually, but that's not a foolproof way. If it's a small leak, we use the bipolar. Just want to show you that. Give me a Surgicel now.
Are you going to put any fat
What?
inside? Any fat inside to fill the cavity?
No. I don't think I need a fat here. I'm going to use the Haddad flap. I have already harvested the Haddad flap. Of course, the big advantage of using the fat is that you will not have a pull of the stalk. So the stalk is not pulled. Give me the Surgicel quick. But of course, I keep the Surgicel nicely, and then when I use the Haddad flap, see, if you don't use a Haddad flap, then there's a chance. I have seen one case where the third ventricle was pulled down to the nasopharynx. It is the nasopharynx. So you can actually pull that so bad, actually, because you didn't have a nasoseptal flap. Okay, now I'm now going to take the Surgicel again. I'm going to close it. You have that piece of bone? Yes. Do you have that piece of bone? Yes, sir. Give me that bone. So usually when you have the dura here, I suture the dura. I have the dural suture. I suture the dura.
Is there a second hole over there again? Or something?
What is that?
It seems like there is some arachnoidal defect, some CSF coming out.
You're
still,
right.
Or it's
Yeah.
an impression. I don't know.
Where?
Do you feel that? Do you see that? From the diaphragm, it seems that there is some CSF coming out, or it's our impression over there.
Dr. Sitiji, can you just tell, because I'm not able to.
Yeah, what it seems to us over here, that from the diaphragm where you had bipolarized, maybe a millimeter or two over that, there seemed to be a small black hole where there was still CSF coming out from.
No, let the CSF come out. That's not an issue. Anyway, I'm going to, right.
Okay.
I understand that there is CSF coming out. That's why the diaphragm collapse. Sometimes what happens is, if you remove a huge suprasellar component, diaphragma comes out here. It comes out here. You would have seen in my YouTube, I create a CSF leak.
Right. The
I
question was
puncture.
that do you use fat to seal the leak, or do you let the leak seal off by itself?
It will seal off by itself. You have Surgicel. You have Surgicel there. And of course, you have, come out. Of course, you have the nasoseptal flap, right? So what is the problem? The nasoseptal flap is the ultimate enclosure of any CSF leaks, as you know. It's the workhorse. Am I right, Dr. Sitich?
Yeah, personally, we believe we'd like to use some fat to plug the leak. And
Of course, you can use that. I didn't want to make an incision in the thigh, my dear friend.
Yeah.
I see when you, I mean, of course, it's a matter of why should I unnecessarily make some incision there? Ma suction or kalama. Pudikada. So that is the final step. Really, yeah. Thank Dr. Vikas for this case. Wonderful case from Maharashtra. See that? So what you do is what is called the trial Haddad. Trial Haddad means, hold. Now you keep that Haddad flap and just check whether that Haddad is going to close the defect completely till the level of the, and whether it sits on raw bone or not.
Right.
So never twist the hadad. It's very important. Don't twist the hadad pedicle.
Yeah.
Very, very important. These are the things the postgraduates or the youngsters should learn. And see that? That is actually the small bone piece which I'm going to remove.
Yeah.
Always, always, always this dictum, harvest a big nasal flap. So
Yeah.
some people actually think the defect is going to be small and they harvest a small flap. No, 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 no. You should not do that. You should always, always harvest a big flap. You get my point? Pudichuko.
Yeah.
So this is what is called a trial flap, trial hadad flap. See how nicely it's closing? Absolutely closing the
it's sitting well.
defect.
Yeah.
Are you happy, Dr. Sitich, with the closure?
The hadad is sitting quite well.
Yeah. So the next step, what I will do now is now I can use the fat, whatever I want. But here what I'm going to do is I've used Surgicel. Ma ulla poa, nee pesada. Nee eduk pesra. Yaar no need, I told. Summa avana poi eduk kekra. Give me the bone. So nowadays we have started using the bone cap, the bone cover. This is a beautiful seal, believe me. And see, if I take that as a single piece, of course the lower part was actually deficient in this case, as you saw, because the bone was eroded, right?
Yeah, it
By
was
the
eroded.
tumor.
Yeah.
Give me an elevator. So I use that as a lid. In fact, sometimes I don't even take it out. I just make it here with a pedicle-like bone, and then I close that like a lid. But this case, we couldn't do that, as you saw. Why?
Yeah.
Because there was an erosion of the bone.
Yeah, the bone inferiorly was eroded.
So now what I will do now is pudichuko. That's exactly how I took the bone, right?
Correct.
So replace bone by bone. That's it. Finished. So we always either suture the dura by dura. If it's going to be a cranium, it'll be different. It'll be totally different. I would then be very aggressive in my closure. I would definitely use fat, fascia, because, you know, it's a high flow leak. This is a very, very low flow leak. And you don't need anything to...
Right. Do you also put a lumbar drain in your patients or not really?
No. Never. Lumbar drain indication is when you create a high flow leak, like third ventricle or two cisterns. When you open two cisterns, yes. Now, after this, we do what is called the bulldozering of the hadad flap. So how do you bulldozer it? Give me a lint. I'll show you how to bulldozer it. So, of course, you can see all the steps in my book as well. And Dr. Lakshmi, who has worked with me, she's sitting there in the audience. And she was a fantastic skull-based surgeon who worked. And
Hi, sir.
yeah, actually.
Hi, sir. Lakshmi here.
Yeah, hi, Lakshmi. How are you?
I'm fine. Perfect.
You know,
It's always a pleasure watching you operate.
at Royal Pearl Hospital, and she has penned the mucormycosis book. And of course, Dr. Vishal is also there. He was referred by Dr. Renuka Bradu madam. Very nice person, learning a lot in skull base. So I can see here that this is what is called the bulldozering of the flap. What is the meaning of the bulldozering? You don't want any air.
Yeah.
So you want that to stick closely to the bone which you placed. So the hadad should sit on raw bone. That is very, very important. Give me Surgicel. Can you see the closure now?
Yeah, it's sitting well.
So I think I'm up now. I know you're seeing the watch. I guess. And you can actually mute, or you can ask questions or whatever you want. So before I close, I just want to thank Dr. Renuka Bradu madam.
I'll just, before you, I hope you can hear the applause.
Oh, it's okay. Thank you very much.
Yeah, just one second.
Hello, Dr. Jankiram.
Madam, it's all your blessings, madam.
Yeah, so I saw the end of the surgery last half an hour or so. It was absolutely spellbinding as usual.
Madam,
And
madam,
thank you
madam. We learn
thank you
from
for-
you. We learn from you. That's it. One word. You're my teacher. So thank you so much. You could have called anybody, but you thought of me. I was telling my residents, Dr. Bradu madam could have called anybody in the world, but really it's a privilege and honor that I am there in the bottom of your heart. That is, that means a lot. That's more than anything for me. That is the Oscar for me.
Thank you. Anyway, that's you, as very particularly you. But anyway, thank you so much. And it was an excellent surgery, and I look forward to meeting you soon. And if it's all right, can we go off air now?
I'm just, can you, boss, is. So, big thanks to Mario and team. I'm sure that all the delegates are going to have a great time watching the two dons doing a lot of surgery. Of course, the boss, Professor Castelnova, is going to give a lot of lectures. I love his biking, I asked Dr. Bradu madam to give him a race bike, and you should see him drive the bike. And fantastic, racer. Thank you very much, and good luck for the conference.
Thank you so much, Dr. Jankiram. It's a pleasure having you with us always. Thank you. Okay, we'll take a short break for lunch. Well, it's not really short, it's 45 minutes. Please be back in your seats latest by 2:25.
Hello, 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 hello. Hello. Sure. Hello, hello, hello.
रुक अभी नहीं, इसके लिए नहीं पकड़ा, हल्का सा गेंद देके फिर खोल,
नहीं नहीं,
हल्का सा गेंद देके ना,
गेंद बाद में
बाद में अब
Check.
तो खोल,
हेलो
खोल,
हेलो हेलो.
सीटी नहीं लगा।
नहीं, कौन डबल आवाज आ रही, रिपीट आ रही है क्यों? नहीं इधर नहीं. हेलो, चेक चेक. हेलो. इसका गेट. हेलो, चेक चेक टेस्ट. हेलो 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 हेलो. चेक चेक टेस्ट. हेलो हेलो
गेंद थोड़ा सा खोल के फिर इसको
हेलो
नीचे
हेलो
रखने का।
हेलो
खोल।
हेलो हेलो हेलो. चेक हो गया.
Hello. Check. Hello. Check. Check. Hello. Check. Hello. 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 Check.
हेलो मुझे इसके साथ है फोटो निकाल
Hello. Hi, doctor.
Hi, how are you?
Yeah, good, good, good. So everything is set. So you can see that, and I can see you very clearly, sir. And we are the behind of the schedule. So I will tell you exact time when you need to start.
Okay.
Okay.
Right.
So let me ask actually how much behind schedule we are, sir. Madam. Yeah.
Professor,
Okay.
Yeah, you can talk now.
can you see me now?
You can't see.
Yes, of course.
Thank Professor,
Yes.
I have sent you a message. We'll start in about 20 minutes, if that is all right with you.
Okay, it's fine.
Thank you. Play it now.
No. Next.
May I also request our MMC observer, Mr. Dr. Amol Sarvade. Okay, fair enough. So once again, welcome, and it gives me great pleasure to welcome all of you all to Soin Hospital. And to kickstart this inauguration, I would like to call upon Professor and Head of Department of ENT, Soin Hospital, Dr. Renuka Pradu, Madam.
So good afternoon, respected Dean, sir, dignitaries, Professor Mario Turi Zanoni and Professor Apostolos Karlikiotis, Dr. Dere, who is the head of Department of Forensic Medicine, our NMC observer who will be joining us shortly, Amol Sarvade. Ladies and gentlemen, welcome to ASCENT. This was born out of a request made multiple times to me by multiple of my students. They said, Madam, you're very right. Basics are very important. Basics are very important. But it's time we did something beyond basics. Because Soin Hospital has always been famous for the fact that we targeted the first 3 to 5 years of consultants doing endoscopic sinus surgery, because we believe that if you know the basics very well, everything, including skull-based surgery, becomes much, much simpler. And today, a lot of my students came to me and said, Madam, finally you did it. So I said, yes, this is something from my own heart, because I know Mario and Alkis from many years, and they're excellent orators and excellent teachers. And when Professor Paolo Castelnuovo said that he would join us and he was actually willing to do live surgery with us, it was a great honor that he was coming along with his team. Unfortunately, due to some health reasons concerning his wife, he has not been able to join us, but he will be with us online. Once again, welcome to all of you. I hope you have a wonderful 2 days and go home happier and wiser. Thank you so much.
My pleasant duty to formally welcome Dr. Alkis and Dr. Mario in our Indian traditional way.
Professor Zanoni, he had a very bad experience. As soon as he came to India, he lost his luggage. So we are trying to find his luggage for him. May I request, though sir is presiding over this function and is not a guest, but sir, we would take this opportunity to show our appreciation for all the cooperation and support you give us for anything that we choose to do. Thank you so much, sir. It is truly a wonderful opportunity for me to voice our feelings towards sir. Thank you so much, sir.
May I now request all our dignitaries to please step forward and light the ceremonial lamp.
May I request Mr. Rana Bose to join us, please?
दबाइए।
Request Dr.
या श्वेत पद्मासना या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा वन्दिता सा सरस्वती भगवती निःशेषजाड्यापहा
Thank you for that lovely prayer and lighting of the lamp. May I please request our Dean Sir to address the delegates.
Our international faculty coming from Italy, Dr. Mario and Dr. Alkins, Professor Head Department of ENT, Dr. Renuka Bradu, Dr. Anagha, Dr. Kshitij, and some of the distinguished my friends who are sitting, Dr. Ahire, my own roommate, sitting in the delegates practicing in Ulhasnagar, and several other senior delegates and professors of ENT. I think that when we started learning about anatomy and dissection of various parts, I remember that we used to have superior extremity, which used to be very easy, inferior extremity. Then coming to abdomen, thorax, and the last part used to be skull. And every teaching, at the end of every teaching of the part, there used to be a part exam, and maximum people would fail in head, face, neck, or the skull anatomy, because it is very complex and three-dimensional thing. And the whole thing, skull base, is divided into anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. And the surgery, which is once upon a time in the domain of purely in the domain of neurosurgeons, have come across in the world in the domain of ENT surgeons, supported at all sometimes by neurosurgeons and plastic surgeons. And out of this quantity of surgery, the added factor which is there now is the endoscopy, ENT endoscopy. And this endoscopy has given a brighter view, an enlarged view of lot of turbinates, openings, sinuses, and the skull base cribriform plate in particular. We have traumatic skull base surgeries which are needed to be done. They fall into what is called as skull base surgery. That is optic nerve compression and the fractures of the orbit, which are needed to be corrected, which are jointly corrected by plastic surgeons and ENT surgeons, and sometimes ophthalmic surgeons join. Then we have a lot of patients of CSF rhinorrhea in this very same institute. But the most complex surgeries probably are the surgeries which are of neurofibroma. And I think that I must congratulate the head department of ENT surgery as to make this center almost as a referral center for skull-based surgery in the country, as well as a known center for skull-based surgery all over the world. She has been called at very many places for various demonstrations and lectures, and the angiofibroma, which is very important and a complex surgery, she's very at ease for demonstration of that, and which I think that she demonstrated. I wanted to see but couldn't come And I think that I really congratulate Dr. Renuka Bradu for leading the whole country for the skull-base surgery, revision of the skull base, understanding of the anatomy, studying the skull base and the skull structures in particular is utmost important. And I think that our head of the Department of Forensic Medicine, Professor Dr. Dere, is highly supportive, not only for our hospital, but the other colleges also come and ask permission that please give us. Dr. Dere has agreed to support us by cadaver, and he supports everybody with cadaver study and restudy, because lots of important structures go to the brain, lots of important arteries and the veins come out from various foramina. So I think studying the skull base, exact nature before we really perform, and review and consider the neuro ENT endoscopy, for doing various surgeries at ease is very important. And I think we have, the Department of ENT has already mastered the technique. So many people have, registered for this particular workshop who are coming from all over the country. This itself shows the name, fame, and the reputation of this surgery. I hope that the deliberations that we are mostly doing, large number of, if I am correct, I don't know, anterior cranial fossa or skull base surgeries. The other surgery, which is wherein the neurosurgeon may come into picture, and that is the middle cranial fossa surgery and the surgery of pituitary. And I am sure that the neurosurgery department of this hospital and the plastic surgery department, whenever required, they go hand in hand with ENT surgery, leading the whole show. Thank you so much, and congratulations. And the deliberation in this particular workshop will definitely benefit each and everybody. And eventually somebody going to Assam, somebody going to Uttar Pradesh, learning the skull-base surgery, practicing there and helping the patient is helping the mankind. Thank you so much.
Thank you, sir, for those kind words. And we'd like to say it with flowers. Professor Alkis Karliakoutis. Professor Mario Turizanoni. Dr. Amol Sarvade. Can we please recognize Dr. Dere, who's sitting in the audience? You will see today the cadaver dissection. You will see the quality of the cadaver. And this has only been possible over the years because of Dr. Dere's truly well-deserved, Dr. Dere's contribution. For the last 18 years, we have trained over 1,800 ENT surgeons in SFES surgery. And this has been only possible because Dr. Dere supported us throughout those 18 years. We'd also like to recognize the Associate Vice President of Alkem, Mr. Rana Bose. Thank you very much.
Thank you, Renuka Madam, for that. Thank you, Dean Sir, for your kind words. Yes, knowledge indeed spreads, and no one knows what the potential of spreading knowledge is. I mean, that we see later. It's been wonderful having all of you all with us, and I'd like to invite Dr. Anaga Joshi, a professor, to propose a formal vote of thanks.
Thank you, Dr. Kshitij, and first of all, welcome all. First and foremost, I would like to thank our Dean, Dr. Mohan Joshi, to have taken time out to come for this inauguration. He has always been a constant source of encouragement and support for us. Thank you, sir. I would like to thank Dr. Castelnovo, unfortunately, who couldn't be with us due to personal reasons, but he is going to be with us for these 2 days virtually and mentally. And we are looking forward to have been enlightened by him through these 2 days. Professor Alkis and Professor Mario, we are ever so grateful to you for coming all the way from Italy and gracing this event. And I think every one of us is looking forward to an excellent dissection demonstration from you and enlighten us with your skull-based knowledge. Thank you, sir. I also take this opportunity to thank our esteemed guest faculty who have consented to be on the panel and who will be sharing their knowledge with us. Dr. Nishit Shah, Dr. Dwaipan, Dr. Sahu, and Dr. Deepak Haldipur. We'll be looking forward to their expert opinion tomorrow during the panel discussion. I think heartfelt thanks to Alchem Nexa division, who have brought this event together, and without their support, this wouldn't have been possible. They have managed to get so many number of ENT surgeons and esteemed guest faculty under one roof, and we really thank you for this. Oh, so there are on the count 780 online also, apart from the various centers which are all over India. So it's a great achievement. And special thanks also to Carl Stores and Medtronic for giving their wholehearted support in terms of equipment. So we'll be looking at the great equipment that we'll be dealing with during the dissection. I think we can't thank Dr. Dere, who's the professor and head of Department of Forensic enough. He has always been a constant support for us in all our endeavors, and we look forward to your support for further endeavors. Thank you, sir. Professor Dr. Kanchan Rupwate, who's a professor in anesthesia. I think you have seen the wonderful support that they gave us during the live surgery event. We thank the anesthesia department. I also take opportunity to thank the radiology department, who have always been with us hand in hand, be it at the 11th hour, any CT scan or maybe VIR required for any patient. We thank Dr. Anaga Zoshi, who is the head of Department of Radiology. We also thank the Department of Physiology for lending us this beautiful conference hall auditorium for us. And I think you saw an effortful collaboration or effortful cooperation of all the team members in the OT today. So I thank the nursing staff and all the servants who helped us during the live surgical demonstration. And I can't thank all of you delegates enough for being present and physically as well as online for this event. We thank you, and also take this opportunity to the entire ENT department who have worked very hard to make this event a success. Thank you so much. I think I'm so sorry, I forgot to mention Mr. Dinesh Pal, who has been handling the event management. Mr. Dinesh Pal, thank you so much. Thank you, and we look forward. I think we are very eager to see the dissection by the professors. And yes, we'll begin with the lecture. I think Dr. Kshitij will introduce the topics and the speaker. Thank you.
Before we get off the dais, could we just assemble for one group photograph on the dais? Just for one photograph, please step in front of the dais. So without much ado, we will move ahead with the program. And I think all of us are very excited for what's coming up next. Yes, Professor Paolo couldn't travel with us here, and he's regretful of that, but he's so graciously agreed to be with us online today and tomorrow both. And I believe we have already set up connection. We'll take a minute or two to just clear the dais. And we're looking forward to 2 lectures from him coming back to back. The first one being anatomical journey around the rhino base. And the second would be a surgical radiological collaboration in the management of carotid bleeding. I think both these lectures for anyone who's looking to even explore skull base would be absolute pearls of wisdom. Professor Paolo Castelnuovo needs no introduction, but it's my pleasant duty to introduce him. He is the full professor in otolaryngology, University of Insubria from Varese, Italy. He's the chairman and head department of otolaryngology, Azienda. All right, pardon my, this is in Italian now. Well, his CV actually runs into 9 pages and it's impossible. I'll probably have to take a lecture to cover the entire thing. Shortly said, he's been teaching for the last 35 years, whether it is endonasal surgeries or skull base. As I look through his publications and contributions towards ENT and the medical fraternity, I mean, it's overwhelming. Professor, can you hear us? Are you with us?
Yes.
So over to you. We're eagerly looking forward to listen to you.
Okay. So many thanks for the invitation. I regret to be not possible to be with you today, but I will be sure in the future. So now try to share my lecture. And thank you so much, Dr. Nuka Brado, for invitation. And I give you the greetings from my university and city, Varese, in the north part of Italy, and of my skull-base department with my neurosurgical partner, Dr. Locatelli. Greetings from Skull-Base Italian Society and from Italian Academy of Rhinology. This is the sentence of Professor Sussenti. He passed away some decade ago, but he was the one who bring in Italy the new rhinologic surgery. And he promote our studies in anatomy. And I want to acknowledge all the professors and colleagues who joined us and who promote our studies and training in anatomy. We start in '96 in Bruxelles with Emile Godefroy and Pietro Palma. And then we go ahead in Europe, in Vienna, with Manfred Schabicher, and in Barcelona with Prats Gallino and Manuel Bernal Sprekensen. Since many years, we have a collaboration with Philippe Herman in the venue in Paris, and in Tübingen with Bernard Hirt, all very famous anatomists who supported us in the anatomical lab activities. And this is our lab in Varese, born in 2014. In the lab, we learn from our masters, and we love to share time and knowledge in the lab. And with Wolfgang Draff, with Heinz Stamberger. So what is our task in the lab, which is the goal, the target in the lab? First of all, to get orientation, then to get the right suavity of surgical gesture, and to widening the surgical horizons. Of course, the first target we have to reach is the orientation. And to have the orientation, we have to join in our brain the images from macroscopic anatomy, from endoscopic anatomy, and from radiologic anatomy. So at the end, we have to be ready to have our personal navigation system in our brain with all these three different input. So it's very important in your activity in the lab to have CT scan and to have a cranium. And this is because you need to face all the three different, because anatomy is always the same, but is different the system we are looking at anatomy. So orientation means to make a fusion in radiological anatomy between the three different planes, axial, coronal, and sagittal. And again, this is to be the feeling where we are always. You see, this is the shape of suction tube penetrating the skull and reaching the third ventricle. So the surgeon was completely disoriented that time. We have to know all the different structure around our journey in the nose and sinuses, what anterior skull base, middle, and posterior skull base. So all the rhinologic skull base. We have to catch our landmark for the beginner when they enter in the nose with the scope. The first important landmark is the superior border of the choana. The shape of anterior skull base is like an hammock and is very dangerous if you keep a direction parallel to the nasal bone. You have to be parallel to the floor of the nose, and your first landmark has to be the superior edge, the superior border of the choana. Then in the lab, you have to get the safety of your surgical gesture. You have to training yourself and your partner. So in the lab, you have to start to work with the forehand, six hand in the specimen, because you have to be ready for surgery. And for advanced surgery, the forehands is mandatory. And then again, in the lab, you find the new idea and you can develop the new surgical horizon with the multiportal approaches, trans-nose, trans-orbit, trans-oral approach, with the combination to get the target, the surgical target, keeping intact the surrounding tissue, and this is mandatory. And you can train yourself and your partner in the lab. So now we can start our journey in the nose and rhinologic skull base. And the first step, the first door for the skull base is the frontal sinus, and how to catch the posterior wall of the frontal sinus. Then we move for transethmoid and cribriform approach, then for middle skull base, and then posterior skull base and craniovertebral junction. the first, and for all these different steps, we need to know the landmark, the key landmark. For the first step, the draft type 3 procedure is the first septal branch of anterior ethmoidal artery, and behind the olfactory fiber, the landmark. Then for the transcribriform, the landmark is the medial orbital frontal artery. Then we have the optic chiasma and the superior epiphyseal arteries for middle skull base, intrasphenoidal landmarks and clivus for posterior skull base, with the Vidian canal and the Eustachian tube for the far lateral approaches. Again, this is to keep the main landmark for all the journey. Well, first step, the frontal sinus. The frontal sinus, we have to remove the floor of the frontal sinus to identify crista galli and resect crista galli to have the possibility to dissect the epidural space on the posterior wall of the frontal sinus. This is a key point where for the skull base reconstruction and to approach the anterior skull base surgery. So how to keep the orientation for the to drill out the base of the frontal sinus. You have to consider that the ostium of the frontal sinus is quite medial. Posterior, we have the posterior wall, and on the lateral side, we have the lacrimal pathways and the lacrimal sac. So the endonasal approach is to drill out the beak and the floor of frontal sinus to perform a draft type 3 procedure, resection of the superior portion of the septum and resection of the floor of the frontal sinus from one orbit to the other. The first key point, the first landmark is the first branch of the septal branch of anterior ethmoidal artery. And you can dissect the mucoperiosteum with a 0-degree scope starting behind the axilla of middle turbinate. And the first structure you will find in the skull is the septal branches of anterior ethmoidal artery. And just behind, there is the first olfactory fiber. If you drill out the bone anterior to this landmark, you can enter in the frontal sinus without any risk to damage the anterior skull base. So this is the landmark, the axilla. We go on the skull, resection of mucoperiosteum, then dissection of mucoperiosteum, and the first structures is the septal branch of the artery. So you can go directly and drill out the bone just in front of this, and you enter in the frontal sinus. This is already the floor of the frontal sinus. And this is the landmark. And in the same position, we have the superior attachment of middle turbinate. So we resect the axilla, and this is the superior attachment of the middle turbinate to the skull. And this is the artery. So they are on the same coronal plane. Just anterior to this coronal plane, we can enter in the frontal sinus, you see? Then we can do bilaterally, and we resect the septum. And finally, we have, this is the attachment of the middle turbinate, the artery, and so we have the so-called T of draft. septum, middle turbinate, artery, frontal sinus. So, again, frontal sinus, posterior wall, ostium, lacrimal sac. So the first landmark is the posterior wall of the frontal sinus. Then we have the lacrimal sac on lateral. So if you are doing revision surgery and you don't have any landmark, it's not possible to catch the first the artery. You have to expose the lacrimal sac, and superior to the lacrimal sac there is a frontal sinus. Then this is the common lamella of turbinate, so the superior attachment of middle turbinate. And then the first branch of anterior ethmoidal artery, septal branch, the first one, and then the olfactory fiber. All these 5 landmarks are in the same position on a coronal plane. And all these landmarks are anterior to the anterior cranial fossa. So you can identify the one you want in relation with the anatomy and with the scar of this patient. But all these 5 landmarks are in a coronal plane, and they are safe landmarks not to damage the anterior skull base, opening the frontal sinus. So we are on the right side. This is a draft 2B procedure, and this is the first branch, septal branch of anterior ethmoidal artery, and just behind you see the olfactory fiber. Okay, so this coronal position for all the 5 landmarks. Again, frontal sinus, this is the position, artery, olfactory fiber, orbit, and lacrimal sac on the right. So, draft 2C and draft 3. So, now you see a completely draft 3 with the resurface of a septal flap based on the anterior ethmoidal artery of the posterior wall. Okay. Second step. Now we move for the transethmoidal transcribriform. And in those cases, we make the completely subperiosteal dissection of the tumor, and we need to expose the arteries, the skull base. So we need to know where are the anterior ethmoidal artery and the posterior ethmoidal artery. We know that the radiological landmark of the anterior ethmoidal artery is a coronal plane at the end of the optic globe. And this is the spatial distribution of anterior ethmoidal artery, posterior orbital artery. Remember your first 2 fingers, anterior left and anterior right, and posterior. This is the direction, the spatial distribution of the artery. And these are the arteries. Sometimes there is an ethmoidal artery. Okay, we identify the artery and we make a coagulation, bipolar coagulation of the artery. Now we remove crista galli. The resection of crista galli is mandatory to have a large dissection of the epidural space. And this is pouch where you insert your second level for the reconstruction, and it is an anchorage for the skull base reconstruction. So you need to resect the crista galli, because in this way you can dissect posteriorly the wall of the frontal sinus and the epidural space, and you can insert here your second layer. The first layer is intradural, the second layer in the pouch of the epidural space you create. But is it possible? Only if you remove crista galli. And now you make a large dissection, so at the end you can resect all the dura and the forks, and you have the space for the skull base reconstruction. This is an olfactory bulb, and then you resection of the tumor, and then coagulation of the forks. We cut the forks so we can do a reconstruction. So the identification and resection of crista galli is mandatory. Now we have removed the bone. We have made this large dissection over the roof of the orbit of the epidural space and to insert the second layer of reconstruction. And this is the resection we have to do, we have done. And of course, we need to consider that the first artery we meet is the MOFA, is the medial frontal artery, medial ophthalmic frontal artery. The origin of this artery is at the level of A2. So A1, communicating anterior communicating artery, A2, and this is the MOFA. This is the genu of the sellar cavernous carotid artery. This is the ophthalmic artery, and then communicating artery, A2, and this is MOFA. And this is the first artery met when you make the dissection of the anterior skull base. So this is olfactory bulb. We make the dissection, and you have to pay attention not to damage this artery. It's very important not to have a complication on the frontal lobe. So identification and preserving of the medial ophthalmic frontal artery is mandatory. And this is an important landmark. So now we have done a completely dissection of anterior skull base. This is the anterior ethmoidal artery on the right side, and then on the left side, and then the posterior one. To make the dissection of the epidural space, we have to bipolar coagulate it and cut the arteries. So you can perform the dissection, and then you can resect all the skull base. This is the MOFA, the chiasma behind. This is the chiasma, and you will see the olfactory tract. Superior epiphyseal artery, hypophysis, and the cavernous side, and the chiasma with the superior epiphyseal artery and the A2 anterior communicating artery. Now we move for the transplanum and sellar approach. Once again, the landmark, the first landmark, is the superior edge of the choana. How to approach the sellar floor? We can do in a different way, paraseptal or transethmoidal. Is related to the need of room, of surgical room we need. For the paraseptal approach, the landmark are the tail of middle, superior, and supreme turbinate. And the natural ostium of sphenoid sinus is just behind the supreme turbinate. Tail of middle, superior, supreme, just behind the natural ostium. Different is if there is a bulging of the rostrum. Sometimes this ostium go posterior to the tail of the on the lateral position. So if the ostium is close to the septum, we make the opening directly. We can open enlarging the ostium very close to the septum. If the osteo is lateral, because there is a pneumatization of the rostrum, we do perform a transrostral approach. So this is an example. We are in the left side, middle turbinate, tail of superior turbinate, and tail of supreme just behind. So middle, superior, supreme, and here is the ostium. So we can enlarge easily the ostium of the sphenoid sinus, and we are in the in contact with the floor of sella. Okay, now if there is a bulging, a protrusion, we have to go transrostral, but we have to preserve the septal branches of sphenopalatine artery, and they are between the tail of middle turbinate and the tail of supreme turbinate. There are at least 3 branches, so we have not to damage. For that, we make a rescue flap. We can do inferior and superior incision. The landmark is the tail of middle turbinate, and make the incision that reach the floor. And here the landmark is the tail of middle turbinate. Superior, supreme. From the supreme, we go on the septum at the level of the axilla of middle turbinate. So the V shape of the incision, remember, tail of middle turbinate, inferior landmark, tail of supreme turbinate, superior landmark. In the septum, not higher than the level of the axilla of superior turbinate. And we can move this pedicle. We don't need to harvest all Haddad, only rescue, only the pedicle. Now we can resect the intrasphenoidal septum. We can resect the rostrum, moving the pedicle, and you see, now you can control, preserving the sphenopalatine arteries, you can control the floor of the sphenoid sinus, the sella floor, the clivus, the bulging of the carotid artery, the optic nerve. So we have now this landmark, optic nerve, lateral OCR, we are on the right side, medial OCR, genu of a cavernous carotid artery, and sella floor. On the left side, again, lateral OCR, medial OCR, optic nerve, genu of the carotid, and then clivus and sella floor. And rotating the 45-degree scope, we can have the landmark of the second branch of 5 nerve, the Vidian canal, the bulging of the paracleval carotid artery, and the clivus. So it's very important to have this landmark to preserve the arteries in the approach to the sella. In this way, I don't have the flap in my surgical field, but I still preserve the arteries. Okay, in the sphenoid sinus, we can have different morphology with the sellar, presellar, and conchal sphenoid sinus, and the landmark on the posterior wall we have already saw medial OCR, lateral OCR, optic nerve, genu of the carotid, paracleval, clevus, median nerve, and second branch of fifth nerve. Inside, we can have the landmark of the optic canal, of the optic strut, and of the maxillary strut, the rotundum foramen, and we can match the inside landmark and the endonasal landmark to build up in our brain a three-dimensional navigation. The hypophysis, the chiasma, and the superior hypophyseal arteries that make the blood support also for the chiasma, and the inferior hypophyseal artery, the meningo-hypophyseal trunk. This gives the major blood support to the gland, again, and superior hypophyseal artery, optic chiasma. You see the origin of the superior hypophyseal artery from the carotid out behind the ring, and the origin of the ophthalmic artery. This is the first artery, the first branch originating from the carotid artery behind the ring, the dural ring, and the anterior communicating artery, A1, A2. And this is an overview of anterior skull base, intercavernous sinus, and the transplanum, the chiasma. You can appreciate the arachnoid, ophthalmic artery, and how thin and multiple are the superior hypophyseal artery. And you have not to press when you perform the skull base reconstruction. It's dangerous if you push here pressure with flat, because you can have visual impairment only to compress these very thin arteries. The approach to the posterior fossa with the transcleval and transodontoid, the main landmark is the Vidian canal. The Vidian canal is like two arrows that bring you to reach the posterior cranial fossa without damaging the carotid artery. The connection with the petrous horizontal carotid artery is just a little bit lateral to the genu, so the lateral to the anterior foramen lacerum. In this specimen, we have already drill out the floor of the sphenoid sinus, and you can appreciate the two Vidian canal just above the eustachian tube. So the eustachian tube above and lateral is the medial plate of pterygoid. If you drill out above this, you can dissect the Vidian canal, and you have clearly the position of the genu of the artery. If you stay down inferior to the Vidian canal, you can go lateral without any risk to damage the artery, because the artery in this position go posterior and lateral. So if we look for the petrous apex, we go behind, but our landmark is the level of Vidian canal. Again, eustachian tube and the middle plate of pterygoid, drilling out the superior edge, we find the Vidian. Of course, in many cases, the two carotid arteries, the vertical portion, are very evident. In this case, you can resect the bone in between the two arteries and the cella floor, and you reach easily the dura of the posterior fossa without encounter any vital structures. And then you can open, you have to pay attention in the opening the dura in this position, not to damage the basilar artery just behind. Here, the basilar artery. And on the lateral side, you cannot dissect the epidural space because there is the sixth nerve that enter in the dural canal and behind the artery. So this is the basilar artery with the superior cerebellar, the third nerve. Now with the 45-degree scope on lateral, we can rotate the scope and make the vision of the cranial nerves. So this is the fifth cranial nerves. The four are just above. This is the 7, 8, and this is the 6. Enter in the dura, passing behind the carotid. This is the 6, 7, 8, and 9 and 10, 11. And with the 45-degree scope, you can see a 360-degree around. Now we look at the landmark to resect the odontoid. The first landmark is cleavage, the anterior arch of the first vertebra. We do perform an inferior base flap of the floor or roof of rhinopharynx of the posterior wall. We like to use diode laser, a contact laser, to make this flap. And then we encounter the landmark, the anterior arch of the first vertebra. And after the resection of this arch, we get the odontoid, and we can resect the odontoid. Again, tube odontoid. Now we make the resection of the odontoid and put a stitch behind the tube, putting in position the flap with a stitch behind the tube. And this is for the resection of the odontoid. This is a case, and then with the blockage of the skull on the neck. Well, now we move for the approach to the coronal plane. We divide the coronal plane in anterior, middle, and posterior. With the anterior coronal plane, we do perform the transorbital approaches. With the middle coronal plane, the transethmoid pterygoid approach, and with the posterior coronal plane, the approach to the upper parapharyngeal space and rhinopharynx. The transorbital approach through the orbit is an additional port to the middle cranial fossa, to the anterior cranial fossa, and to the cavernous sinus. And the landmark inside the orbit are the optic canal, the superior and inferior orbital fissure, and the canal of anterior and posterior ethmoidal arteries. And the greater wing of the sphenoid, the resection of the greater wing give you the approach to the middle cranial fossa, the resection of the lesser wing to the cavernous, to the roof of the cavernous. So middle cranial fossa, front anterior cranial fossa, and the cavernous region. We do perform generally the superior eyelid approach. And when we do perform the superior eyelid approach, the key point is the preservation of the levator palpebrae. The fiber of the orbital are horizontal. The fiber of palpebral elevator are vertical, and we have to identify. Then we keep the plane of the subperiosteal plane on the superior and lateral edge, and then we use silastic sheet to protect the periorbit. And this point, we have dissected periorbit, and we have the greater wing of the and the lesser wing of the sphenoid and the frontal bone, superior and inferior epiphyseal fissure. And this makes the division between the anterior cranial fossa and the medial cranial fossa. And resecting the dura, you can have the lateral wall of the cavernous sinus with a 5-3, 5-2, 5-1, and in between, inside the cavernous, the third, and superiorly the third and the fourth. And you can have a journey around the cavernous through the orbit. So, incision of the skin and the separation of the orbital fiber, horizontal one. Now the vertical fiber give you the landmark of the levator palpebrae that you have to preserve. And now you move to the lateral edge and take the subperiosteal approach and dissect the periorbit, protecting the periorbit with the silastic sheet. The first landmark is the recurrent meningeal branch. And just behind the recurrent meningeal branch, there is the superior orbital fissure. So, recurrent meningeal branch, superior orbital fissure, optic nerve, posterior ethmoid, anterior ethmoid artery. It's easy if you preserve the periorbit. It's easy to take this landmark because the periorbit enter in the canal. Recurrent meningeal branch, superior orbital fissure, optic nerve, posterior and anterior ethmoid. Now we go on the lateral side, we make the dissection, and we have to identify the superior and inferior orbital fissure. The angle between the two orbital fissure, superior and inferior, give you the landmark, you can appreciate, give you the landmark, the angle between superior and inferior orbital fissure, give you the landmark to resect the greater wing of the sphenoid. So locate and then start. This is the superior one, the inferior is here, and start to resect. This is the temporal muscle, and this is the dura of middle fossa and the dura of superior fossa. This is the lesser wing, and now this is the lateral wall, and we start to dissect the lateral wall of the cavernous. This is the floor of middle fossa, and this is the lateral wall of the cavernous, and you start to see the nerve. This is the 5-2 entering in the rotundum foramen. If you dissect the floor, you reach 5-3 and medial meningeal artery, 5-3, medial meningeal artery, 5-2, and then the lateral wall of the cavernous, and you are extradural. So now you can cut the temporocavernous ligament, and it's easier to dissect the lateral wall of the cavernous. Now resecting the lesser wing of, you can identify resector lesser wing, you can identify this is the optic canal, and you can make a decompression of the lateral wall of the optic canal with the optic nerve. Now you have decompressed the lateral wall of the optic canal, and you still are extradural. This is the third nerve, the carotid artery. Okay, this is the lateral wall of the cavernous sinus, and this is the medial wall of the cavernous sinus with the carotid. And the third nerve, 5-1, 5-2, 5-3, third, fourth, and carotid. And now if you dissect the medial, you can see the sixth, that is the only one inside the cavernous. So finally, you can have a final vision. You can have a final vision of optic nerve, internal carotid artery, third, fourth, 5-1, 5-2, and 5-3. Cavernous, the sixth. Medial lateral wall of the cavernous and medial wall of optic nerve, the ophthalmic, the origin of the ophthalmic, the origin of the ophthalmic artery, optic nerve, cavernous carotid artery, and you can control all the anatomy cavernous. Through this way, you can resect such a meningioma, spheno-orbital meningioma. Now we look the medial wall of the orbit through the endonasal approach, and resect apiresia. We can have two main windows. The inferior window to the orbit is between the medial rectus and the inferior rectus, this one. And this is the larger window, and there is no any vessel that crossed this window. The superior window between the medial rectus and the superior superior oblique muscle are crossed by the ethmoidal arteries. So middle rectus, inferior rectus, and the superior oblique, and the two windows in between. We can enlarge the inferior window, and we see in the apex the division of the third nerve, and this is the optic. Again, a division of the third nerve entering in the apex of the orbit, immediately divide. So it's very important to know this position and to know the position of the arteries inside. It's a very delicate space. And this is the dissection of the endonasal approach, frontal sinus, anterior ethmoidal artery, posterior ethmoidal artery. We are on the right side, resection of the papiresia and identification of the muscle, optic nerve, medial rectus, superior oblique, ophthalmic artery, cavernous sinus, and now we can have a dissection. Okay, this is the third nerve, the optic, and the ophthalmic artery in the apex of the orbit with annulus of Zinn. Now we dissect the cavernous. This is the cavernous carotid artery, and you can clearly see the sixth nerve inside the cavernous, from inferior to superior, from medial to lateral, and this superior orbital fissure, there is the cross position of the sixth and of the third. Okay, now, optic nerve, ophthalmic artery with the loop, the third and the sixth. And this is the point where the sixth go lateral and the third came medial. And the annulus auxine is open. So optic, ophthalmic, sixth and third. The cross point between third and sixth. Okay, now we can move to the transoral approaches, because in a multiportal vision, we can approach with the transoral, and transoral we can reach the CVJ or the superior parapharyngeal space on the infratemporal fossa, and the is the medial pterygoidal muscle. So we have two main corridors, medial to the medial pterygoidal and lateral to the medial pterygoidal and to the masticatory space. And we can dissect, we can enter anterior to the anterior pilaster of the tonsil, and we have the division of the stylopharyngeal, styloglossus, and medial pterygoidal muscle. And we stay medial or lateral to the medial pterygoidal muscle, and we can reach the carotid space. So through this approach, we can reach the internal carotid artery in the parapharyngeal space, and this is the medial again, and the mandible, the sphinx, and the inferior velar nerve, mandible, and we can enter in the masticatory space. Through the median approach, we can reach the posterior fossa and resecting the anterior arch, and we can make a flap inferior base, and then we can resect the odontoid, and we can open the posterior fossa with the vertebral artery, the pica, the ica, and we can have a control of the inferior nerve and arteries. A complete control of the posterior fossa with the 12, 9, 10, and 11, and the 7, 8, and the ica, and the pica here. On the other sides. Now we move to the middle coronal plane. Middle coronal plane means the transethmoid pterygoid approach with the transantral approach to have a complete control of the lateral space of the sphenoid. We have to locate the arteries on the lateral wall of the nose, the sphenopalatine complex. Now we are on the left side. We have just opened the pterygopalatine fossa, and we can dissect the sphenopalatine with the turbinate branches and the septal branches, sphenopalatine arteries, turbinate branches, and septal branches. And behind, the descending palatine artery, and straight, the Vidian and the pharyngeal artery. So we have these 5 arteries. It's easy to remember, it's like your hand. So descending palatine artery, sphenopalatine septal branch, sphenopalatine turbinate branch, sphenopalatine septal branch, palatovaginal, and Vidian pharyngeal. So 5 arteries. And we can dissect all these arteries on the lateral wall, maxillary sinus, ethmoidal crest, behind the ethmoidal crest, sphenopalatine foramen. We can resect the optic process of palatine bone to expose the sphenopalatine arteries, and we will see the descending palatine artery just behind. And then this is the descending palatine artery, and then the sphenopalatine turbinate branch and the sphenopalatine septal branch. And we can remove, okay. Now we resect again the sphenopalatine, and behind we can appreciate, this is the infraorbital nerve, rotundum foramen, Vidian, and on 45 degree, the pharyngeal of palatovaginal. We remove the bone between the Vidian canal and the foramen rotundum, and we expose the lateral wall, and we follow the Vidian artery, and now we have 5-2, 5-3 with the venous plexus and Vidian. So this is 5-3, Vidian, 5-2. So through a transpterygoid approach, we can dominate the lateral space of the sphenoid sinus, and we have the landmark. The landmark for the cavernous is just above 5-2. So just above 5-2, you can open the cavernous sinus. And this is the vertical parapharyngeal carotid artery. We are now on the other side, and in this specimen, the sphenopalatine complex, Vidian 5-2, you see, this is the landmark to open the cavernous sinus. This is 5-2. You have just above 5-2, you can open the cavernous, and you can appreciate the 6th nerve inside the cavernous. This specimen presents an anomalous ophthalmic artery. So it's very rare. In 100 and 100 of specimens I have dissected, there was the only one who have the ophthalmic artery originating in the anterior genu of the carotid. So cavernous sinus, the 6th nerve, and this is an anomalous ophthalmic artery. Behind the petrous apex. Okay. So you can appreciate the anterior genu with the anomalous ophthalmic artery that follows the 6th nerve. Usually, the origin is above the dural ring. Again, Vidian, the dissection of the lateral cavernous. Now we have 5-2, 5-3, and we make the removal of the bone. This is the Vidian, below the Vidian, and we reach the petrous apex. The cavernous again, and behind, this is the petrous apex, the dura, the 6th, penetrating the dura inside the Relo canal. and this is the petrous apex. So the landmark to reach the petrous apex is to stay just below the Vidian. And you see the genu of the artery, and behind there is the petrous apex. And this is a cholesterogranuloma with the carotid resection and then resurface with a Haddad flap of the carotid genu to keep open the marsupialization of the granuloma. The cavernous with the third, 4, 5-1, 5-2, the approach, the inferior hypophyseal artery and meningohypophyseal trunk, and again, all the carotid in the skull base, paracleval, cavernous, and with the opening of the cavernous sinus again. Now we move for the posterior coronal plane. In the posterior coronal plane means the approach to the rhinopharynx or upper parapharyngeal space. The critical point is the variation, the anatomical variation of the parapharyngeal internal carotid artery with such a kinking. Such a variation can be very dangerous, the damage of the cavernous. So the Eustachian tube, it's an important landmark that protect the genu between parapharyngeal and petrous carotid artery. And the risky point to damage the artery is mainly inferior to the Eustachian tube. So Eustachian tube, it's a very important landmark. If you stay lateral to Eustachian tube here is being resected, and you see the lateral genu of the carotid. But if you preserve the Eustachian tube, this is protected. Transmaxillary window to the parapharyngeal space in infratemporal fossa. Approach through endonase, enlargement of the piriform and resection of the posterior wall of maxillary sinus, and we reach in this way. Now we are on the right side. This is the tube, the Vidian, 5-2 resection, the lateral pterygoidal muscle, the pterygoid isolated, medial pterygoidal muscle, lateral pterygoidal muscle, temporal muscle, Vidian 5-2, tube, 5-3, resecting and dissecting the lateral pterygoidal muscle. We have 5-3 and 5-3 and the tube, and now behind 5-3, medial meningeal artery, and if you resect the tube, you have the possibility to see the carotid. So the tube protects the carotid in the skull base. Another way to reach the carotid is in a pad fat lateral to the tensor veli palatini muscle. Now we are on the right side. We are dissecting the pterygoid, and we open the pterygoid, the maxillary, the sphenopalatine complex, lateral plate, medial plate of pterygoid, Vidian, lateral plate of pterygoid, 5-3, 5-3, dissecting the lateral plate of the pterygoid. Now we remove the pterygoid, and there is the medial pterygoidal muscle and lateral pterygoidal muscle, tensor veli palatini. Now following the tensor veli palatini in the pad fat, we follow the tensor veli palatini and we find the carotid artery. The parapharyngeal carotid artery is there. Eustachian tube lateral to the tensor veli palatini carotid artery. So we make this corridor lateral to the tensor veli palatini. And this is to resect the, I show you, now we are resecting the transpterygoidal transantral approach, the rhinopharynx, and this is the Eustachian tube. Now we look the landmark of the tensor veli palatini, and this is the fat, the pec fat. This is the Doppler, and you see the position of the parapharyngeal anterior carotid artery, and you can resect the rhinopharynx and then resurface the carotid artery with the flap. We have another way to find the carotid artery in the skull following the foramen ovale, foramen spinoso, spina sphenoidalis, and musculotuber canal. And this is a more difficult approach, and we use this approach when we have to resect and look. This is the pterygoid. This is the third nerve, third branch of fifth nerve. And now we go ahead and in the skull, and we locate the 5-3, and we resected the third nerve, medial meningeal artery, median nerve. In this way, we find finally the position of the carotid artery. So the landmark, foramen 5-3, medial meningeal artery, sphenoidal spine, and Eustachian tube. And here we have the artery. And you see in this resection of the rhinopharynge, the artery was there. So we reached the position of the internal carotid artery. Finally, you see the parapharyngeal carotid artery, the temporal carotid artery. The Vidian artery is an arrow to the medial genu between vertical and horizontal carotid artery. And the Eustachian tube is an arrow to the genu between parapharyngeal and artery. Resection the tube, you see 5-2 Vidian Eustachian tube, the carotid, the parapharyngeal carotid. And now you see how the tube, following the landmark of the tube, you can reach the genu between vertical parapharyngeal. This is the resection of the tube. And now we are all the landmark. And this is the osseous portion of the tube. So how to locate the genu between parapharyngeal carotid artery and petrous temporal carotid artery. 5-2, 5-3, medial meningeal artery, osseous portion of Eustachian tube. Okay, I think we have finished our journey around. This is a book we published with Jacopo Dell'Anna and Manfred Schabischer on the carotid artery. Thank you so much.
Thank you so much, Professor Castronovo. We now have one more lecture.
Yes.
Of the surgical radiological collaboration for the internal carotid artery. Bleeding.
Yes.
Professor?
Yes, I am. Okay. Did you hear me?
Yes, we can hear you.
Okay. And did you see the image?
Yes, we can see the image. It's very clear.
now I want to share our experience regarding the management of the damage of the injury of the carotid artery in the skull-based surgery, in the skull-based surgery. We have to take in account that the 2
Professor,
point.
can
Yes?
I take a minute? I would like to know, will half an hour be enough? Because we need to mobilize the cadaver for the dissection. So,
Yes.
yes, right. Thank you.
Do you mean half an hour?
Yes, sir.
Okay, ready.
Right. Thank you.
Thank you. So the the position where it's a very dangerous and where we can meet the injury of carotid artery are from bifurcation to the carotid canal, so the upper portion of parapharyngeal artery, and in this portion we are now on the right side. Eustachian tube protect the medial genu between the carotid, and this is on the opposite side, petrous tract and parapharyngeal and Eustachian tube, 5-2, 5-3, Vidian canal. Again, the way to get the position and the identification of the carotid for the landmark of the different segment. So for the lateral genu between parapharyngeal and petrous carotid artery, the landmark we have to follow is the Eustachian tube. For the medial genu between the horizontal and vertical carotid parapharyngeal artery, not parapharyngeal, paracleval, and horizontal is the Vidian canal. And this is the position and the journey of the carotid in the skull. Of course, when we do perform extended procedure in the skull base, we need the collaboration of the interventional neuroradiologist. He has a very important professional position in the skull base board. And this is our first experience in the 98 doing a pituitary surgery. We got the damage of the inferior hypophyseal artery. And that time we were able to pack the nose and to block the hemorrhage, but during the night we still have a recurrence of the hemorrhage, and at that time we do perform a transcervical closure of internal carotid artery. It's 30 years ago. Then you have another damage of the artery in the 2010. And at that time, we do perform an endovascular embolization. So the collaboration with the interventional neuroradiologist was already started. And this case was a lady of 38 years old with a parapharyngeal papillary adenocarcinoma, low grade. And we admitted the lady 1 month before. This was the extension of the lesion in the upper parapharyngeal space, and with the contact with the carotid, without encasement of the carotid, but with the frontal anterior contact with them. So we admitted the patient 1 month before, and we did the balloon test, and we knew that we can sacrifice the artery because the venous drainage between the time was less than 2 seconds. So we know that we can sacrifice the artery. And this was the balloon test. And after 1 month, we admitted again the patient, we did the surgery, and the neuroradiology was with us. And we have just removed more than 95% of the lesion, and the neuroradiology went in the OR and told me that he wanted to go home. And I say, no, you have to wait until the end of the surgery. And it was a very lucky word, because after 2 seconds, I got this damage of the upper position of the parapharyngeal artery. We were able to block the hemorrhage with the oxycell sponges, and we moved the ladies immediately to the angiography room to control the bleeding. And the interventional radiologist made an occlusion of the artery with the coiling. The artery was completely occluded. And then the patient was submitted to proton therapy. The patient is already with the 13 years of follow-up, and she's well, no any complaint. And this was the completely resection. So when you do perform such a surgery, you can encounter the complication of the injury of the carotid. And you have to be ready, you have to have a secure plan to deal with this event. In the 2012, we start to use the endovascular stenting. And this is a case we operated for a mucoepidermoid carcinoma of the rhinopharynx, and we use this double stent inside, and we put the interventional radiologist put this stent inside artery. Of course, the stent cannot skip a direct damage of the artery, but make the artery more consistent to the management. And this was the first and the second stent they put. And this was the surgery, and the surgery went well with a complete resection of the lesion and without encounter major complication. In 2016, during a pituitary macroadenoma surgery, we encountered an damage injury of the carotid in the cavernous sinus again. We block the bleeding with the oxycell sponges, and the interventional radiologist put a flow diverter stenting. This is an evolution of the stent, and make this very malleable stent that permit a revascularization and can preserve the integrity of the vessel. This was the lesion of the pseudoaneurysm of the cavernous carotid artery. Once again, the critical point is the inferior epiphyseal artery, and this was the stent, the diverter stent we use, and you see that can have a control. This is after 1 year, a completely control of the vessel without any more progression of the pseudoaneurysm. The integrity of the vessel was preserved. Sometime using this endovascular stenting, we need to approach with the sandwich techniques. So we have to put a compression, an external compression on the vessel with ICA resurface. We can use muscle, we can use Haddad flap. This is a case of massive bleeding in this lady that after 1 month, after FESH revision done in another institution, got a severe epistasis with the bleeding of the cavernous carotid artery. And this was the pseudoaneurysm. So our interventional radiologist put the flow diverter stent rehab, and after 12 days, the patient was discharged. This is the stent inside the left cavernous carotid artery. But 15 days after discharge, she got another profuse bleeding. So we performed and Haddad flap, and with this Haddad, we resurface the carotid in the sphenoid. This was the control. So pre-stenting pseudoaneurysm, post-stenting, and Haddad flap resurface of this position. And we got success of the procedure, no more bleeding, but in these cases, we do perform stenting plus Haddad flap. And this is another case of carotid bleeding during pituitary surgery. There was a very small sphenoid sinus with the carotid inside, and you see the sphenoid was so small, and the protrusion of the carotid, and this is the carotid, this is the right sphenoid sinus, and this is the left sphenoid sinus, and this is the protrusion of the carotid. And during surgery, there was a damage of the carotid or the cavernous carotid. So standard approach, and you see the left sphenoid sinus, and this is, look, very high, and left sphenoid sinus. And this is already carotid, but the surgeon I was disoriented, and he, in this position, is the real sphenoid. And I provoke a damage with the shaver of the carotid artery, because I did understand that this is not the sphenoid. So we control the bleeding, packing with the oxycell, and then move to the angiography room, and this was the lesion, and this was the flow diverter stenting. The interventional radiologist positioned it. 5 days post-op, after the position of the stent, the diverter, there was again bleeding. So we make surgical revision, and we put muscle Oop. We take a fragment of the muscle and we put, okay, now we put muscle resurfacing the carotid. So the left sphenoid and the muscle resurfacing the carotid. And free graft of muscle, then oxycell. And again, before and after resurface. So here there is a pseudoaneurysm, no more. So once again, cooperation between interventional neuroradiology and surgeon with the position of the stent. When the interventional radiologists make the position of the stent, they use antiplatelet, use first tirofibram in a bolo, and then infusion for 12 hours. Then from the day after, double antiplatelet therapy for 30 days, and then single antiplatelet therapy for 3 months, for 4 months. So not for long life. The evolution of the quality of this stent permit nowadays to reduce the anticoagulation therapy post-op. And in the future, there is already experience of a single antiplatelet therapy. So the final consideration of this collaboration is that the collaboration with the interventional neuroradiologist is mandatory, because nowadays, also if you during the surgery get a complication with the injury of carotid artery, this is the possibility to control the bleeding and to have a rehabilitation of the artery. So 30 years ago, we make the closure of the artery on the neck. Then we use the coiling of the artery. Then start the experience with the stent. And nowadays, with the new diverter, we can preserve the function of the artery. Thank you.
Professor, I hope you heard the resounding applause.
Thank you so much.
Thank you so much. They were so interesting, and we learned so much. We realized how far we still have to go to be able to do this kind of surgery and to control the complications of this kind of surgery. It is truly an honor to have you here with us and to have you so generously share of your wisdom. And I hope that in future we will see you in person as well.
Yes, I hope to. And thank you for invitation. I like so much, and thank you for hosting my co-worker.
So we are going to have the cadaveric dissection start in about 10 minutes. And if it is possible for you, if you could stay online and give your comments as we go along with the dissection.
Okay. It is my pleasure.
We will prepare the cadaver and we'll get back to you.
Okay. See you soon.
Yes. We'll have a short coffee break. And by short, we mean 10 minutes. At the most, 15 minutes. Just give this to them.
side, this is middle turbinate. We can try to just a little make lateral with a gentle maneuver the inferior turbinate. This way we can see the nasopharynx, eustachian tube, both sides. Okay. We can also see that here in this position there is accessory ostium of the maxillary sinus left side. And here, by exploring the osteomeatal complex, we can see in the uncinate process and the bulla ethmoidalis. Medially, you can see the area of the sphenoethmoidal recess in this area, and this is the natural ostium of the sphenoid. So anatomy is very clear, and it's wonderful in this specimen. So it's time to start with surgery. Firstly, we'll do basic function endoscopic sinus surgery very fast, in order also to keep under control our anatomical landmark. So we enter in the middle meatus with a backbiting forceps, and then with a gentle maneuver, we enter at the level of a Nick triangle. Nick triangle is the area of a free border of a uncinate process when we can move the uncinate process in order to understand how much the uncinate process come anteriorly. I mean, we can identify the anterior insertion of a uncinate process in order to understand how much we have to cut uncinate process, because if I go too much anterior, the risky point is the nasolacrimal duct, and so we have to cut the uncinate process as far as the nasolacrimal duct, but without removing and without damaging the nasolacrimal duct. Then with a curette, we can make a removal of the uncinate process. You see, we are removing the uncinate process, and in this maneuver, it's very important to go very up in order to clean also the area of the Agar-Nazi cell. Agar-Nazi cell is this area, is the area where the uncinate process come really anteriorly, and it represents the cranial insertion of the uncinate process. Okay, with this maneuver, it's possible we have a wet. Okay, with this maneuver we can identify. Cosa caso? Anche una. No, faccio su. We can identify here the position of the cranial insertion of the uncinate process. So this is bulla ethmoidalis, this is Agar-Nazi cell, this is the infundibulum, this is the cranial insertion of the uncinate process. Please keep in mind that the medial and posterior wall of the Agar-Nazi cell is the cranial insertion of the Agar-Nazi cell of the uncinate process. So theoretically, Agar-Nazi cell is built up by the cranial insertion of the uncinate process. These are not two different structures, but it's the same structure with different name. I put the 45-degree scope. With the 45-degree scope, we can identify the natural ostium of the maxillary sinus, and here the accessory ostium of the maxillary sinus. Abbiamo un biscotto. Okay, and so we can join these two, because sometimes you may have some recirculation of the mucus between the natural ostium and the accessory ostium. In order to prevent these, usually we join the two. Of course, to do this, we have to remove just a little the posterior fontanelle area, but it's not a problem. Of course, we have to balance between the dimension of a maxillary sinusotomy and the ventilation, of course, but it's good to join the two. Okay? Just a second. Okay. I'm cleaning just a little this area. Okay. And it's okay. So maxillary sinus is good. This is the impression of the infraorbital nerve at the level of the roof of the maxillary sinus. Give me just a little more of a backbiter. Backbiter just a little. in order to palpate the uncinate process and understand not to leave some remnant of a uncinate process, because you know it's better to remove completely the uncinate process, not to leave some remnant of the uncinate process. Okay, usually we do this maneuver in order to rotate just a little outside the uncinate process, but I think we are at the target. No more uncinate process here. This is the area nasolacrimal duct. This is good. So we can turn upside down our scope and we can identify the bullet moidalis. We can identify here the area of the infundibulum and the area of the frontal sinus. So with our cutting instruments, we are going to disassemble the frontal recess by cutting this area. This is the medial and posterior area of the Agar-Nasi cell, and by cutting these, guardate se c'è funghetto frontale, and by cutting these, we enter directly in the area of the frontal sinus. Okay, so the so-called vertical bar, which is the arrow that brings you directly in the frontal sinus, is the cranial portion of the uncinate process, which is the medial and posterior wall of the Agar-Nasi cell. Give me the Carrison Ranger curved in order to cut just a little here. Curved one. Because I would like to clean the area of a natural. Okay. And so this is the left side frontal sinus, very good. And I try to enlarge just a little the sinusotomy, because you know it's quite important to enlarge here the bone in order to increase the space. And so, as you have seen, I've done this approach with the so-called intact bulla approach. When we talk about intact bulla approach, I mean that we have approached the frontal sinus without opening the bullet moidalis. This is feasible in this anatomical specimen because the bulla is very low pneumatized. Conversely, in other cases where the bullet moidalis is very high pneumatized and reach the ethmoidal roof, it's mandatory to open at least the upper part of the bullet moidalis. Moreover, another important thing is another landmark to keep in mind when approaching the frontal sinus. The lateral border is the orbit, and you can see this is the orbital level, and so it means that we have arrived laterally as far as the orbit. This is our target. I just try to enlarge just a little more here anteriorly in order to see better inside the frontal sinus, and it's very good. It's very good. We have at the level of the target of the frontal sinus. I can enlarge just a little more here, and after that, it's time to put once again 0-degree scope. With the 0-degree scope, we have to clean the ethmoid and reach the posterior ethmoid and sphenoid. Okay? Give me once again the cutting instrument for frontal sinus, the number 3 or number 2, if it is possible. Yeah. Because there is a septation inside the frontal sinus, and I would like to cut this septation in order to join the supraorbital recess with the true frontal sinus, you see? And so it's time to cut this septation in order to enlarge the diameter of the frontal recess and to enlarge the natural ostium of the frontal sinus in order to prevent restenosis and so on. So I'm cutting this small bony septation between supraorbital recess and frontal sinus. And this is quite important in order to prevent restenosis and also ensure good opening of our frontal sinus. Sometimes it's hard to work with both scope and curved instrument. Give me just a second more the circular punch for frontal, if it's feasible. Circular punch for frontal. Okay, so we have opened well this area, is not possible. But it's okay. We have to perform draft type 3 approach, and so it's good. So the area of the supraorbital recess is in connection with the through frontal sinus. It's we have a
Professor Castellano, can you hear us?
we have a una Weil curva, some Blacksley curved Blacksley in order to remove the small septation.
Professor, we've begun with the dissection and Mario is doing the basic phase. I hope you can see the picture.
I can see only very small. It's only I have a small image.
Please do
But yes,
stay
I
with
can see. I can see.
Okay, you can see. Right.
Yes, it's there.
Please do give your comments if you have any. Mario is continuing with dissection in the frontal sinus.
Okay. Now better.
Carry on, Mario, please.
Mario is doing very well, so he can go ahead with his comment.
Yeah. So this is frontal. Now it's time to put the 0 degree scope and go in ethmoid. You have seen we have opened the frontal recess, we have cleaned the frontal recess without opening the bulla. Bulla intact approach. Whenever feasible, it's much more safe. But of course, according to anatomy, you have to tailor your surgical approach, your surgical procedure, because not feasible in all cases. It depends on the degree of pneumatization of a bullet ethmoidalis. And so I put now 0 degree scope in order to check the ethmoid, and with the curette, I'm going to open the bullet ethmoidalis. The safe point for opening bullet ethmoidalis is the inferomedial angle of a bullet ethmoidalis. Why? Because in this way we are very far away from the orbit, and our movement should be from posterior to anterior and in a vertical direction in order to prevent damages to the orbit. And removing the anterior wall of the bullet ethmoidalis, the structure that come into view is the so-called second portion of the middle turbinate, because all we know that from an anatomical viewpoint, the middle turbinate built up by 3 portions. 3 portions are very important to be understood. The first portion is the coronal part of the middle turbinate that stay in the nasal fossa. The second portion is a portion that attach the middle turbinate, the first portion, laterally to the orbit. And this portion, also called common basal lamella, is in between the anterior ethmoid and posterior ethmoid. And so we have to open this second portion in order to get the posterior ethmoid. But we have to remember that there is also a third portion of the middle turbinate. Third portion of the middle turbinate stay at this level and make the stability of a middle turbinate. That's why it's so important to open the second portion, the basal lamella of a middle turbinate, in order to get access to the posterior ethmoid without damaging the third portion, because the third portion of the middle turbinate means stability. Otherwise, if we destroy the third portion, we make the middle turbinate floppy and with high risk of lateralization of a middle turbinate and high risk of disruption and synechia on the lateral wall of the nasal fossa. Okay, so it's time to open this area, which is the second portion of the middle turbinate, in order to explore the posterior ethmoid. For exploring the posterior ethmoid, it's very important to stay at this level, preserving the integrity of the third portion of the middle turbinate, and identify the superior turbinate. Why? Because superior turbinate represent the surgical window to access in a safe way the sphenoethmoidal recess and the lateral ostium of the sphenoid. So please perform a very gentle maneuver on this area, identify the tail of the superior turbinate, and with the tail of the superior turbinate under view, it's possible to get access directly to the natural ostium of the sphenoid. Just a little, I would like to clean here. And you see, by cutting here, by cutting the superior turbinate, step by step, we are cleaning the sphenoidal recess and the natural ostium of the sphenoid come into view. Okay, so now it's time to enlarge the
Mario, you can show the audience also the endo paraseptal view. So they can appreciate how small removal of the superior turbinate you have done.
Yeah. So if you see, the same area can be explored also by a paraseptal direct approach. And you can see third portion of the middle turbinate is still in place. The first portion of the middle turbinate is still in place. The middle turbinate is stable. And with this approach, we can see that we are at the same level. This is the natural ostium of a sphenoid. My instrument is there. And now I put the scope on the opposite side. And you can see that my instrument is a paraseptal and it's visible through the ethmoid. This is called transethmoidal approach to the sphenoid sinus. Okay? So now we can clean the posterior ethmoid and enlarge the natural ostium of a sphenoid. But remember that it's quite important to preserve the mucosa just below the level of a natural ostium. Why? Because at that level, we can identify the septal branch of a sphenopalatine artery. This septal branch is the arterial branch which supply the nasoseptal flap. And so it's important to preserve this area to prevent bleeding during standard FAS and also to keep in place the possibility for skull-base reconstruction with nasoseptal flap when dealing with advanced case or advanced skull-base surgery. And so I'm cutting the posterior ethmoid at this level in order to clean the posterior ethmoid and clean the orbit. You can see I'm cleaning all this area in order to fully expose the roof of ethmoid. This is very small septation of the posterior ethmoid. Adesso c'è una citella dritta. And then with the straight caries on rounders, I'm almost ready to explore the frontal. This is a small cell of a posterior ethmoid which stay over the level of a sphenoid. And so this posterior ethmoidal cell which stay over the sphenoid is called Onodi cell. And now we are going to enlarge.
And you can empathize, Mario, how the floor of the Onodi cell is flat.
Yeah.
You see there is the lateral OCR already evident, and the floor of the Onodi cell is flat.
Yeah. And so by removing this bone, which is the floor of the Onodi cell, we can enlarge our sphenoidotomy. And we can better access to the true sphenoid sinus, because of course this is posterior ethmoid, it's not sphenoid. Sphenoid is inside there. And so I try to enlarge this area. As already told you, I try also to preserve the integrity of the mucosa. No. Okay. I saw the CT scan of the patient just before, and there is no highly pneumatized lateral recess of the sphenoid. It's very small lateral recess of the sphenoid, so we can open it, but it's not so big. And so we are not to expect very highly pneumatized sphenoid in this patient because it's a low pneumatized sphenoid with very small lateral recess. I try to expose as much as I can the lateral recess of the sphenoid in order to keep under control our landmark. Okay, and so this is our sphenoid. We are inside to the sphenoid. We can see the clival recess just below the level of the cella floor. The cella floor here, and here at the level of the onodicell, the optic nerve. Unluckily, it's not so pneumatized. You know, much more the sphenoid sinus is pneumatized, much more visible will be the impression of a neurovascular structure inside the sinus. But in this case, it's not so highly pneumatized, but it's visible. Cella floor, carotid, optic nerve.
You can take a 45-degree scope and make a journey inside the sphenoid.
Yeah.
So you can see better the floor and the pterygoidal recess, the median crest.
As you can see, with a 45-degree scope, we are passing through the ethmoid, and now we are inside to the sphenoid. This is the clival recess. Here, laterally, it's visible the Vidian crest at the level of the basis sphenoid. This Vidian crest is a small bone impression which stay at the level of the Vidian canal. And here, this is the small, very small lateral recess of the sphenoid, and at the level of the floor, it's possible, at the level of the roof of the lateral recess of the sphenoid, it's possible to see the second branch of a trigeminal nerve. I am removing the mucosa because sometimes by removing the mucosa, it's better to see. Dammi la dritta. It's better to see the bony structure just behind. As Dr. Janakiran this morning has shown us, when you remove in live surgery, when you remove mucosa from the sphenoid, it's just a little bleeding. Because there is a venous bleeding just behind the mucosa of the sphenoid, it's no problem, but it's important to remove mucosa, especially for pituitary surgery or advanced surgery, because usually this area will be resurfaced using a nasoseptal flap. And so you have to completely remove mucosa in order to prevent mucocil formation just below the level of the nasoseptal flap. And so it's important to remove mucosa, no matter the bleeding, to better see anatomical landmark and to expose the nuded bone for eventual positioning of a nasoseptal flap at the end of a skull-base surgery. And so this is the very small lateral recess of a sphenoid, Vidian crest below, and on the top of the lateral recess, there is the impression of a second branch of a trigeminal nerve. And here, this is the impression of a paraclival carotid artery, which became, give me a cotton or some positioning instrument in order to show, to mark. So V2, cavernous tract of a carotid artery, and here in the inside of the onodicell, we can see the optic nerve. Okay? So cella floor, cavernous carotid artery, optic nerve, lateral medial OCR inside of the onodicell. And we have removed the bone between the sphenoid and the onodicell in order to enlarge the sphenoidotomy. Okay? And this is basically the standard function endoscopic sinus surgery. Another important thing I'd like to show you is the so-called rescue flap. not for basic surgery or for the so-called FES, but for advanced surgery, especially for transsphenoidal approaches to pituitary gland. It's quite important to keep in mind to preserve the mucosa which stay below the level of a natural ostium of a sphenoid, give me a cotton, in order to freer or something like that. In order to preserve the vascularization of the nasoseptal flap. You see, more or less, maxillary sinus is at the same level on the axial plane of the sphenoid, and passing through the paraseptal direct approach, we can see our sphenoidotomy. And the mucosa which stay between the tail of a superior turbinate and the middle turbinate is a very important mucosa, because inside here, 1 or 2 or 3 branches of a sphenopalatine artery, which supplies the nasoseptal flap, which supply the mucosa of the nasal septum, passes over. And so, if you destroy this mucosa, you cannot have the possibility to harvest the nasoseptal flap. And so, during surgery, especially during advanced surgery, our philosophy is to harvest the so-called rescue flap in this area in order to preserve this mucosa. Then, after surgery, you will decide if a very expanded approach has been performed. If you have had some CSF leak, you finish the harvesting of the nasoseptal flap. Otherwise, you can put in place the mucosa and stop. But if you have destroyed the mucosa of the pedicle and nasoseptal flap immediately as a first step of the procedure, you cannot harvest this flap. And so it's important to harvest the flap with a knife, with a beaver or other kind of knife. You can cut mucosa at that level, because of course, in order to pull down this mucosa, we have to make free this mucosa at this level. Okay.
And Mario,
yeah,
show them that it is important to preserve the olfaction.
Yeah.
The superior level of the cutting of the cut of the septum, of the mucosa of the septum. So the axilla of superior turbinate and middle turbinate, they have a parallel line, and you have to stay not above this line.
Yeah, more or less at the level of the line of the axilla. Okay, this is the axilla of a superior turbinate, and so I stay at this level in order not to get impairment of olfaction in the patient. Okay, I just a little cut the superior insertion of this mucosa, and this is important in order to harvest this flap. Okay, then with the freer, I can elevate the pedicle of the flap by pulling down this mucosa. And you can see it's not necessary to harvest completely the nasoseptal flap at the starting point of surgery. It's important only to preserve the mucosa in order to have a possibility to harvest the nasoseptal flap just in case you need. Okay? Usually, despite the original technique has been described with the dissection of both the superior and inferior part of the pedicle of the nasoseptal flap, usually we dissect only the superior part of the flap, because no need to perform now inferior incision of the pedicle at the level of the lower part of the tail of the middle turbinate. We can keep in place this area of the mucosa. We will do incision at this level at the end of surgery, just in case we need to harvest the nasoseptal flap. Otherwise, it's not need to perform the inferior incision. Usually, the inferior incision starts from the lower part of the tail of the middle turbinate and is a curved incision which stay at the level of the joining point between soft and hard palate, in order not to detach the soft palate from a hard palate. But no need to perform this incision now. This incision will be done only just in case we need the nasoseptal flap. Rescue flap is always important. Is always important in order to preserve this mucosa. And I show you that by performing this approach, theoretically, it's possible to completely expose the bone of the rostrum, of the sphenoidal rostrum, which is a key element in pituitary surgery. Because, you know, I'm dissetting this level of a mucosa in order to preserve the mucosa where is the pedicle. You see? I'm pushing down this mucosa. Inside there is the vessels. And here you can see there is other small vessel which supply the upper part of the nasopharynx. You see? Inside there is the so-called palatovaginal canal. Okay, here. You see? Palatovaginal canal, where runs vaginal artery, which supply the upper part of nasopharynx. And so, you can see in this way, I have preserved this mucosa, I have exposed the bone, and now I can remove all this bone until the level of the basis sphenoid without damaging the nasoseptal flap, without risky to destroy the nasoseptal flap. And we can do this maneuver on both sides in order to expose the bone of the rostrum. Yeah. So I'm just removing here the bone. During the harvesting of this pedicle, sometimes you have also to cauterize and cut the palatovaginal artery. Not always, but it depends. Because here is the canal, the so-called palatosphenoidal canal, where palatovaginal artery together with the pharyngeal bulk nerve runs. Palatovaginal canal is branch from maxillary artery and branch off at the level of the basis sphenoid and supply the upper nasopharynx, okay? And this is the artery. Okay, so I can perform the same rescue flap also on the other side in order to fully expose the rostrum, and then I remove it. First, I would like to expose also on the other side and remove the rostrum altogether. So this is the right nasal fossa. I can just a little perform now fracture of inferior turbinate. In a paraseptal approach, I get access here to the superior turbinate and to the natural ostium of the sphenoid. You can see natural ostium of the sphenoid. I would like to perform the same dissection of a rescue flap also in this side in order to fully expose the rostrum and with the hammer and chisel remove completely the rostrum, which is very important, for example, for pituitary surgery and for expanded transsphenoidal transplanul approaches. And you can see once again, I'm preserving the mucosa of the rescue flap. It's quite important to preserve the mucosa of the rescue flap in order to have the possibility to perform a very watertight and very strong skull base reconstruction at the end of surgery in case we need, okay? Of course, sometimes no need for skull base reconstruction in pituitary surgery, but you have to be ready. If you need, you have to have all the possibility to perform a very good reconstruction. And so go with the chisel and hammer in order to remove this rostrum, this bone. Okay, as you can see, this kind of surgery is always a two nostril forehand surgery because the first and second surgeon should cooperate together and should both know exactly what to do. They should understand exactly what to perform, how much strong should be the removal, how much strong the chisel and hammer. And so it's important to train yourself in working together, working in a team. This is one of the most important teaching of Professor Castelnuovo to all of us, which are young co-worker of Professor Castelnuovo. He teaches us to work together, because only working together you can reach important outcome, important results. Okay, Blexley? Usually we remove mucosa here with debrider or so on, with powered instrumentation, but here in dissection is good also to remove with the vial. The most important thing is not to remove bone or intersinus septum with the Blexley vial, because the risk is to destroy bony septation and give some problems. Okay, so it's quite more easy to understand now. The intersinus septum, both the optic nerve are well visible, but you know, with hammer and chisel we have to go just a little more lower, because we need to expose the basis sphenoid. The exposure of the basis sphenoid, it's mandatory for such a kind of approach. Very, very gentle. Okay.
Yes, you have to control the floor of the sphenoid sinus. This is very important for the surgery to give to neurosurgeon enough space to approach the cella. It's important to control all the boundaries and the landmarks. And then it's important for the time of reconstruction, especially if you need to do a skull-based cellar floor reconstruction with a dark flat. It's important not to have any remnants of bony spore at the level of the floor.
Okay, here very gentle, because you know that here the septation of the sphenoid could be directly on the carotid. So please, before starting surgery, try to understand where the intersinus sphenoid septum goes, because may happen that the intersinus sphenoid septum goes directly on the carotid artery. And so it means that you have to be much more gentle with your maneuver, because in removing the intersinus septum, if the intersinus septum goes on the carotid, you have to be very, very gentle. Otherwise, if you, for example, destroy the intersinus septum, or if you remove intersinus septum with a Blexley forceps, is 1 second to perform a fracture at the level of a bony carotid canal. Luckily, in this case, it's not to be at the level of a carotid, but may happens.
But inferiorly, if you look at the floor of the sphenoid, you see that inferiorly, this the median sedimentation go to the carotid.
Yeah. So it's important to understand these details preoperatively on the CT scan. Very, very gentle. Okay.
Of course, in live surgery, the resection of this sedimentation are done with a drill. with diamond bore and drill, never with hammer. But in dissection, chisel and hammer give you the possibility to have a better vision of the landmark because there is less powder and the visual, the field, the surgical field is more clear.
Now I'm cleaning the specimen by removing all these bony fragments.
And this is a very important consideration for the training of the doctors who start to make training in the lab. Your specimen has to be always very clean because you have to have the possibility to see always the landmark. And this is not possible if the specimen is full of the debrisement.
Sono come loca. Sono come loca.
I think you have to lower the rostrum more.
Yeah, because I'm not able to reach this area just behind the cella. It means that there is some more bone that should be removed. And so we are working 2 nostrils for hands, also on the other side, you see, because we have completely removed the area of the intersinus septum. No. Sì. Aspetta che lo tiro su così. Okay. This bony segment of the rostrum has been completely fractured and removed, but but it's completely open, only to remove it.
Okay.
This is our transethmoidal approach. And removing this bone here just a little. I pay attention in doing this because, you know, we are very close to neurovascular structure. I would like to clean. I know we lost some time to clean the specimen, but as Professor Castelnuovo emphasized to us, it's quite important because no sense to perform many things in a bad way. It's better to work in a very clean specimen, a very clean anatomical landmark, and this helps you also to have a very well organized mind also for surgery, in order to train yourself to stay every time the clean scope. Okay, it's important for training. So, rostrum has been removed, and so just a little I can enlarge here laterally the lateral recess of the right side with the caries around yours. It's visible, thank you. And then after that, with the ball probe, I would like to explore all the landmark of the sphenoid. Okay. I bring the mucosa, but you see, I will immediately leave the instruments because I have to remove only the bone, not destroying the mucosa. You can see?
Yes, you can take a 45-degree scope and have a look, because also on the right side can be a small node.
Yeah.
So you can have a look on the, yes, there.
Also,
Because
more or less
there
in this
is
area,
a
Prof.
small
Yeah.
node. Yes, exactly. If you
I clean
take
just a little.
if you take a 45-degree scope, you can show the audience the small node on the right side. Yeah, just there.
Okay. And we are opening the small node without a transethmoid approach. Okay.
Yes.
So
when you do perform this maneuver, opening the node with a paraseptal approach, you have always to remember to preserve the tail of supreme turbinate, because there is around the tail there is the septal branches of sphenopalatine artery.
So I put 45 degree now, and it's time to see our anatomical landmark. Maxillary sinus, of course, transethmoid approach with the middle turbinate keep in place, the rostrum, and the mucosa of the nasoseptal flap, of the rescue flap. And then rotating the scope, we can see all our landmark in details. We can see here the clival recess of a sphenoid, just below the level of the sella floor. This is the sella floor. This is the paraclival carotid artery. This is the cavernous carotid artery. And you can see here, there is also a very small bony dehiscence. You see, I'm pressing the cavernous tract of a carotid artery where there is a very small bony dehiscence. With a 45-degree scope, rotate laterally, we can explore the lateral recess of a sphenoid, which is this one. There is small lateral recess, but it's important to see. This is the Vidian crest. You see, Vidian crest, it means that this is the projection of the bony Vidian canal. Bony Vidian canal brings you directly at the level of the medial genu of a carotid artery. And just below at this level, there is the fibrocartilago basalis of a foramen lacerum. Okay, so Vidian crest and Vidian canal that bring you to the medial genu of a carotid artery. This is the lateral recess of a sphenoid, low pneumatized in this specimen. And you can see on the top of the lateral recess, you can see this projection, which is the projection of a second branch of a trigeminal nerve, which is the maxillary nerve, which runs until the foramen rotundum, exit the skull from the rotundum foramen, and runs more or less here, and runs at the level of the roof of a maxillary sinus. When the maxillary nerve come outside the rotundum foramen, it takes the name of infraorbital nerve. And another important thing, more or less, this area where the second branch of a trigeminal nerve runs represent the floor of a cavernous sinus, because this is also the medial wall of a cavernous sinus. Okay, so clival recess, sella floor, clival carotid artery, cavernous carotid artery, Vidian crest and canal, lateral recess, second branch of a trigeminal nerve, starting point of a cavernous sinus. Okay, and I rotate just a little the scope in order to see much better. This is the upper part of a pituitary fossa, carotid left side, carotid right side, optic nerve left side, optic nerve right side. This is the area of the optic chiasm in the deep, of course, okay? This is the carotid, and so this is the so-called lateral OCR, and this is the so-called medial OCR. Lateral OCR which is lateral optocarotid recess, might be more or less pneumatized. In this sphenoid sinus, lateral optocarotid recess is not so highly pneumatized, unluckily. But in some cases, when there is a very huge pneumatization of a lateral optocarotid recess, you can see optic nerve that runs in the space, more or less, because optocarotid recess corresponds intracranially to the anterior clinoid process. Medial optocarotid recess, conversely, can correspond to the medial clinoid, but not always is present. Okay, so carotid, optic nerve, and optocarotid recess. The true optocarotid recess, of course, is the lateral optocarotid recess. Okay, optic nerve left, optic nerve right, chiasm, and here is the area of the planum sphenoethmoidalis. More or less in this area, 7-8 millimeters just anterior to the course of the optic nerve, we can observe the posterior ethmoidal artery. So optic nerve, optocarotid recess, planum sphenoethmoidalis, and posterior ethmoidal artery. Okay? And so we usually observe all these landmarks with a 45-degree in order to keep in view all the landmarks together. Okay? And we have now explored on the opposite side the onodicell, as Professor Castelnuovo suggests us. Okay, here, probably also we can insert the scope on the right side. You can see this, in this approach, ethmoid is completely preserved, but we can explore this area, which is the posterior ethmoid and the onodicell on the right side. So in some cases, it's possible to expose and clean also the posterior ethmoid without opening the anterior ethmoid in order to be much more minimally invasive. Okay? And so this is the onodicell on the right side.
Good.
Okay.
So to have more room, you can cut the body of the supreme turbinate, leaving the axilla and leaving the tail, and you have a completely exposure of the posterior ethmoid.
Give me cutting instruments. Here we, on the left side already done, but here in the right side, according to the suggestion of Professor Castelnuovo, we can cut the tail of a superior turbinate. Cutting the tail means that we have to preserve the upper part of a superior turbinate, of course. It's important to preserve the upper part of a superior turbinate because of the olfaction, of the smell function. Pittsburgh group have performed many studies on the quality of life of patients submitted to transsphenoidal surgery in order to understand the morbidity related to the olfaction. And together also with some studies from our university, we have demonstrated that the large part of the olfactory mucosa stay at the level of the superior part of the superior turbinate. Okay. And so by cutting this area, it's much more clear, it's much more wide, the approach. I have a 45-degree, of course, and so probably can be just a little difficult to understand. But it's okay, I think.
So this is a selective posterior ethmoidectomy, leaving middle turbinate in place, so without any destabilization, and preserving the blood support to the septum.
You can see middle turbinate, uncinal process still in place, cohana and nasopharynx, and the mucosa of the ADAT flap, the mucosa of the so-called rescue flap is still in place. After surgery, if we don't need to perform nasoseptal flap, you can re-put it in place, you see? And it's good, on both sides. On both sides, because in this way, it's possible to remove the rostrum. The removal of the rostrum represent a key surgical step in order to approach the pituitary fossa. Okay, this is the area of the rostrum, you see, but rostrum has been completely removed because in this way we can get access straight to the clival recess and to the sella floor. Okay, now we can move just a little more to the draft type 3, okay, because another step which is really important for skull-base surgeon are draft type 3. Of course, you can approach draft type 3, also called Lohotrop modified procedure or frontal medial drainage. We can harvest such kind of approach in two different ways. The first one, the easiest way, is from lateral to medial. I mean, keeping under control the natural ostium of a frontal sinus and enlarging your approach from lateral to medial, exposing the so-called T of draft that Professor Casanova showed in the anatomical journey of this lecture. But of course, not always is feasible such a kind of approach, because sometimes we have a cancer, or you have a tumor, or you have osteoma, or you have other pathologies which involve massively the area of the frontal recess, and you cannot enter for oncological reason. You cannot enter, you cannot transpass the cancer in order to get access to the frontal sinus. And so, in selected cases, it's mandatory to perform the so-called from medial to lateral approach. From medial to lateral means that you have to perform an incision at the level of the olfactory cleft, identify the first olfactory fiber, and get access to the frontal sinus from medial to lateral. So it's time to turn the scope and put the 0-degree scope in order to train ourselves in both the technique for harvesting the draft type 3 procedure. Okay? So, c'è un più piccolo? No. Ok. Okay. So, our landmark in this case is the axilla of a middle turbinate. There is just a little septal deviation, septal tuberculum here that make the procedure just a little harder. But I'll do very small fracture in order to expose better the olfactory cleft. We have to perform an incision at this level in order to expose the olfactory mucosa and the first olfactory fiber. Why the first olfactory fiber is so important in harvesting such a kind of approach? Because first olfactory fiber represent the starting point of the anterior cranial fossa. So just in front, just anterior to the olfactory fiber, we will encounter the floor of the frontal sinus. Conversely, just posteriorly to the first olfactory fiber, we will encounter the anterior cranial fossa. But in such a kind of approach, we have tried to drill out the floor of the frontal sinus without damaging the anterior cranial fossa, without opening the anterior cranial fossa, without having CSF leak. Okay? This will be also the part of the nasal septum that should be removed after. I would like to cut this small part. Because now I'm exposing the mucosa. Okay, done. Perfect. Okay. So, as already told you, once you have done such a kind of round shape incision, it's time to elevate mucosa of the olfactory cleft along the subperiosteal plane. And so, what come into view? The first olfactory fiber. Here, you see? Nice. This is the first olfactory fiber. Sometimes, together with the first olfactory phyla, you can have also a very small arterial branch, which is the septal branch of the anterior ethmoidal artery, which runs just few millimeters anterior to the first olfactory fiber. And so both these two can be considered as landmarks for the point between the starting area of anterior cranial fossa, just posterior to this, and the floor of the frontal sinus anterior. So it appears clear that if you drill out there, you enter the skull and you will done a iatrogenic CSF leak. Conversely, if you drill here, you are drilling the floor of the frontal sinus and you can enter inside the frontal sinus for performing a draft type 3. That's why it's so important to
we have to
identify.
suggest also that usually the first structure is the vessel, and this is the vessel we use for the septal flap for resurface the posterior wall of the frontal sinus in a draft type 3, or we use this pedicle septal flap pedicle on this vessel for the reconstruction of the septal perforation.
So now I'm going to remove the upper part of the nasal septum, the cranial portion of the nasal septum, because I would like to show you the first olfactory fiber on both sides, which is a very important landmark for the starting point of a cranial base, anterior cranial base, of course. Okay? First olfactory fiber, right side. And then drilling out, on the opposite side, I immediately go on the left side. I perform the same things. I mean, the round shape incision at the level of olfactory cleft and the elevation of the mucosa along the subperiosteal plane in order to expose on both sides the olfactory fiber. It's quite important to see the two olfactory fiber on both sides, because this helps us in understanding the anatomy of this region. Okay? You can see. Probably this one is the small artery, which Professor Castelnuovo told us just before. This is the level of the right side olfactory fila.
We can show also the transethmoidally on the left side, the anterior ethmoidal artery and the relation with this vessel.
Yeah. I am opening a window inside of the septum. Okay, you can see the first olfactory fiber on both sides. Okay, so now it's well understandable. This is the artery, which is the first structure that comes into view. Okay. Okay. So we have to clean completely this area and approach the frontal sinus on this side. Of course, when doing this procedure, we have to just a little cut only the head of a middle turbinate. This is important. Discuss something like that. Okay. This is important because, of course, we have to cut only the anterior part, the anterior aspect of a middle turbinate. Usually we cut only the head of a middle turbinate because this structure then will become the so-called T of draft. Okay? And also the axilla, of course, of a middle turbinate should be cutted. Because in this way, we can preserve the body of a middle turbinate. Okay. I've cut it only the head of a middle turbinate. Okay. Another important thing is that usually when you perform a draft type 3, the area that blocks your visibility is this bone. And this bone should be drilled out. This is the ascending branch of a maxilla, also called the frontal process of a maxillary bone. And usually we try to preserve the mucosa at this level, but we have to drill out this bone. It's important to drill out this bone in order to increase the visibility of your approach. You see? So in the subperiosteal fashion, we elevate the mucosa from here because this mucosa can be reused for resurfacing the approach. And we have to drill out this bone because by drilling out this bone, it's quite easy to join the frontal sign, you see? We can try also with the chisel. And so I am with the 0-degree scope till now, because the large majority of the approach of a draft type 3 should be done with a 0-degree scope. 45-degree only at the end in order to clean, to refine, to enlarge the anteroposterior diameter, to clean the supraorbital recesses, and so on. But all this part should be done with the 0-degree. You see, middle turbinate, I remove only the head, anterior tip of a middle turbinate, but the turbinate is preserved. And this bone should be cutted. We can try with the chisel. Just a second. I try to be... Usually, of course, this maneuver in live surgery has been done with the drill, not with the chisel. But in order not to produce too much dust, I would like to try with the chisel. We try to be very, very minimally invasive. Once again, I will emphasize not to do in live surgery with the chisel. You remove this bone with a drill. Here, only not to produce dust in the specimen and to make dirty. Okay? Okay. Vai ancora? Okay. Okay. Is not safe with the chisel in live surgery because of the orbit, of course. There is orbit just behind, so it's not safe. But only in dissection, in order only to remove the bone without producing too much dust.
Sometimes you can use also the Carrison to make a small notch, and then it's easier with the.
Let me vial. Blackley. Then give me the curved Carrison Ranger. The curved one, if it's feasible to remove this bone, I don't know. I try. How much bone is here? Oh, it's very hard.
No, it's very hard.
Okay, I have to drill. No way to do another way. I have to drill, but no problem. We have a straight drill, yeah. And can I have a pedal also on my?
And to avoid the scarring, it's very important what Mario Turi just showed you. So to elevate the mucoperiosteum, and then at the end with the mucoperiosteum you can resurface. Otherwise, with the draft type 3, if you have a circular naked bone, during the healing, the granulation can give you some scar and closure of the neo-ostia.
Okay, so I'm gonna drill this frontal process of a maxilla, which is also called ascending branch of a maxilla. And you see, once again, I am with a 0-degree scope and with a straight drill. By removing this bone, you increase a lot your visibility for draft type 3. This is more or less the level of the orbit. If you press the orbit, we are at the level of the orbit, so peri-orbit is still intact. Orbit and lacrimal sac can be considered also as a landmark. For such a kind of approach. I'm drilling now anteriorly and medially, because drilling anteriorly and medially is safe. I'm cleaning just a little. This is our mucosa. This is the septation inside the frontal sinus. And probably this is the contralateral side, frontal sinus. That on the CT scan is very small. Going on with the drill. Of course, another important thing that can be done then is to enlarge the window on the septum, because in this way, in the septum is too much. We have to enlarge just a little the window. Okay. Yeah, it's better to remove just a little venasal septum in order to see better our structure. Okay. Giving back biting. I enlarge just a little anterior venasal septum removal in order to expose better. It's a balance, of course. You have to remove as much as the cranial portion of nasal septum as you need in order to keep under control both sides of a frontal sinus. But in the same time, you have to try to preserve as much as you can. Okay. On this side, we have not managed the ethmoid. But after the draft 3 has been done, we will have to open also the natural recess of the frontal sinus also on the right side, because this is mandatory to join the two sides. This is the mucosa that we have to preserve, okay? We can go on with the other side. We are at this level. And I go on with the drill. I'm just a little more with the 0. Okay. The intersinus septum is not exactly on the midline, but this should be anticipated on the CT scan preoperatively. And now I'm drilling the intersinus septum, of course. Once has been done this surgical step, it's time to put the 45-degree. Pay attention to our small flap. Just a second, Aki.
You have to elevate better the flap.
Yeah, this flap is just a little on the level of our sinusotomy.
Or if you have curves.
Give me a knife.
And curve and 45. So.
Yeah. With a sickle knife, I can harvest much more the flap in order not to risk to destroy the flap with the drill. And in this way, I can rotate all my flap behind in the area of the olfactory cleft like this. Okay. Give me a forbicina, small scissor.
Yes.
Okay. Okay. And now with the 45-degree, we have to drill out here, which is the frontal process of a maxilla on the other side. Of course, this is the frontal recess. And a draft type 3 is almost okay. This is the frontal recess, of course, on the right side. Okay. This mucosa can be used in order to cover here with the nuded bone. And we have to go on with drilling out this bone, but now it's better to go. Give me curved Blexley, just a second. Okay. And then we can go on with the 45 degree. And with the drill. I have to adjust the focus with the 45.
Okay.
So this is our flow, our frontal sinus. And now the pedal is the same, yeah?
Yes.
Okay, yeah. Okay. Now I've put 45 degree scope and curved drill. So you have seen the procedure start with a 0 degree scope. 45 degree only at the end. When you have to refine.
And you can use both the nostrils, so you put on one side the 45 degree scope and in the other side the drill, and you can cross to make surgery more on lateral position. So
yeah,
it's very convenient to use the two nostril for hands also in this approach.
On the CT scan, we have seen that this bony portion between is very, very thick. I'm drilling also just a little anterior here in order to increase visibility. And now I change the position of the drill in order to take advantages of the both nostrils. I'm cleaning here on the left side. Remember this bone in order to increase the visibility. This is our flap that has been elevated. Okay. Okay, this is the left side. And then we move on the other side. You can stay here with the drill just a second in order to expose this bone. The removal of this bone is important to better see. And I can... ma non riesco. I have put the scope on the right nostril and the drill on the left side in order to take advantage of the two nostril approach, of the two nostrils. Okay. Broken. Okay. You have another one or not?
Yeah.
Sorry. No. So, this is our flap. This is left side. This is right side. And of course, we need to drill out more or less this bone, just a little more, this intersinus septum, and this bone and this bone in order to refine the sinusotomy. Okay? I'll do a washing, yeah.
Ok, sono solo quelle lì.
Okay.
Ah, ok, quindi. Un altro. Aggressiva.
Se ce l'è. La curva per... No, non è la curva. Proviamo, dai.
Give me the other one.
Here, very thick bone, you see, here. And you have to drill out the intersinus septum, which is very, very thick, and this part of the bone, and it's done. This is our flap. This is the mucosa, already put it here. And so we need to drill out this bone. We try with a more aggressive drill, which is another kind of drill which can be used when we are dealing with a very, very hard bone, like in this case. Of course, I have to be very, very gentle, not to press too much, and control better the instrument because it's very aggressive drill.
When you use such an instrument, and always for all this kind of instrument, you have to control the tip of the instrument, like Professor Mario Turri is doing now. So never use instrument without the tip.
Very thick bone, but it's okay. We anticipate these issues on the... So you see, in order to completely finish the draft type 3, okay. Okay, next procedure. Okay. Okay. From the floor and from the audience, they say us that it's enough for the draft type 3. And so theoretically, to finish the approach, you have to drill out here, this bone, in order to join completely the two, and drill out just a little here, this bone. Okay. In this way, the approach will be complete. Okay. And
also the rostrum of the frontal sinus. So You have to enlarge the antero-posterior diameter, not only with anterior resection, but also the septum and the rostrum of this approach can be resected a little bit more.
So here, the so-called frontal beak, this bone.
No, no, no. On the opposite side.
Here,
the rostrum. The rostrum is on the posterior wall, the inferior portion of the posterior wall.
Yeah, here.
This one. Yes, exactly. This one. This one has to be drilled to enlarge this.
Just a little, yeah.
Never leave too high. Never leave too high, otherwise promote the
La mia ha preso
closure.
dritto un attimo. Ha preso dritto.
But of course, this is to complete. Now you can move on.
Yeah, yeah. This bone, and this bone.
Yes.
Try just a little more with the straight one, but only a few seconds because it's time to move to the second step. Yeah. My time is done. But
the trick, yes, of this procedure is to enlarge the antero-posterior diameter and the lateral to lateral diameter, and at the end resurface the naked bone.
Exactly. So this bone just a little, not too much, because you know that then we have the starting point of the, and also this bone. But of course, it takes just a little time because you have to do this thing, this maneuver very, very gentle, and you have to remove the bone in a very precise way. No, but this is the maximum that we can do with the straight. Okay? And so, once at the end of the procedure, once this bone has been completely removed, this bone has been completely drilled out until the level of a posterior roller frontal sinus, and this bone has been completely drilled out, we can resurface the denuded bone with this mucosal flap. You see? This mucosal flap helps to cover the denuded bone in order to reduce the area of the exposed bone. And you can do it bilaterally, both on this side and both on the other side. For reason of time, not harvested on the other side, but you can do the same things also on the other side. And you can cover with the mucosa also here the posterior wall in order to harvest completely the draft type 3, which is almost done, but it's okay, I think. The point has been reached, okay? Thank you.
Thank you, Mario. Well done.
Now, Alkis gonna show you. You have another one? Perfect.
Can turn on, please.
Thank you so much for a wonderful dissection.
Okay. So, good afternoon. For me, it's a great pleasure to be here. I want to thank Professor Renuka Bradu for the kind invitation. I'm very happy, glad, and honored to be in such a beautiful place with such a beautiful audience and people here in India. So we changed to 0 degree, and now we will move a little bit posterior. Okay, suction. So I would try to access the cavernous sinus and pituitary. Here is the drill of Mario that was broken, foreign body. Huh? Okay. So Mario exposed very well all the landmarks on the posterior part in the sphenoid sinus. So our target area will be the pituitary, clivus. If we have time, we can open also the clivus, and cavernous sinus to see the nerves and the carotid inside the cavernous sinus. Yes. Show it? Okay. So first, I would like to show you the transmaxillary approach, the so-called prelacrimal approach, which will give us access to pterygopalatine fossa, and if we need to the infratemporal fossa, and then we will be also have better exposed to the cavernous sinus. So prelacrimal approach is an approach that we use Freer in order to do access to the Freer to do access to the maxillary sinus by preserving the inferior turbinate and the nasolacrimal duct. So the patient will benefit because will not have any epiphora after, and will have less crusting because we will have also the inferior turbinate. So it will be that patient that has not ever been operated will seem. So to do this kind of approach that you can change to middle maxillectomy if you need, the cutting is from above of the head of the inferior turbinate at the line of the maxillary line, and we do a mucosal cutting and we come anterior to the head of the inferior turbinate. So it's good to feel the piriform aperture, the bony structure here, and you stay a couple of millimeters behind of this, and then you do the cutting of the mucosa going down. Do you have a scissor, sorry, a knife, a blade? I try with a sickle knife, but it's better if you have a blade, 15 blade maybe. Or high? Okay. So you can use a cold knife. You will have a little bit more bleeding, but the tissue will not shrink at the end of the surgery, and it will be better to when you suture. Okay. If you can use cautery, but you will have maybe a little bit of shrinking of the mucosa. Another trick is to extend the mucosa cutting in the floor of the nasal fossa, so the tissue will not be blocked, and then it will not be retracted when you do the dissection of this part. Okay, we have the Freer now. Okay, so I elevate a little bit this tissue. I want to expose the bony part of the inferior turbinate, which then will be the landmark for the osteotomy. Okay. So working in these spaces, so anterior, can be a little bit tricky due to blood and getting dirty. So you have to be patient to do this. Okay, so I elevate this mucosa here, the mucosa of the inferior meatus, and now also here. So you see the mucosa is not blocked and will not disrupt. Because one main issue is that you will have the mucosa disrupt, and then you will not have space to do the suture, and you may have a hole on the inferior meatus, so inferior meatotomy, and we don't want this. Nothing happens, but it's better if you don't have this. Can I have the chisel now? So in real life, I like to use the chisel to do this. You can use the drill if you want. So I stay at this point of the insertion of the bony part of the inferior turbinate. Okay, go. Okay, okay. A little more. Okay, go, go, go. Okay, go, go. Okay. Go. 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 So, okay. Like a sleep. Maybe a hard bone here. So it depends from the how chisel? How fat is the bone here? How thick is the bone here? So you may need to remove more bone. Go. 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 Okay. Go. Go. Okay. So, okay. You can check the distance between the this bone and the nasolacrimal duct in the CT scan. Blackesley. And this will give you also the idea of the space you have to enter this, to access this area. So this is the maxillary, okay? So this is the area. I have to remove this bone over here. This will be the nasolacrimal duct. I can remove the bone around the nasolacrimal duct. Non ce la fai, Mario. Blackesley. We remove this bone. Okay. Dammi ancora. Chisel. You see, this is the nasolacrimal duct over here. I can remove all this bone here. Right. 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 Okay. So one important structure that you can find at this level when you remove the bone anteriorly is the anterior superior alveolar nerve. So this nerve, it's a branch from the infraorbital nerve that will run at this level of the bone. So more you come anterior and more you remove bone, you can hit this nerve, and the patient will have dysesthesia of the teeth and the cheek after the surgery. Okay, so it's a classic symptom that patients undergoing medial maxillectomy, radical medial maxillectomy, the Denker approach or the Sturman-Canfield approach, they complain after surgery, right? 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 Okay. Ancora un po'. Right? So it's a thick bone. It's hard bone. Vai qua? Sì, vai. Sì. No, questo non lo voglio. Vai. 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 Okay. So this is the bone behind the nasolacrimal duct. That we remove. Okay. Dammi ancora la tap tap. Right? Okay. I try to do a fracture of the medial wall. Right? But it's very thick and it's not so easy. But it's not a problem. If you need to remove the bone, you can remove the bone as long as you preserve the mucosa and you have the integrity. Yes, of course.
Otherwise, we change.
One, two, one, two. No. So here, 1, 2, 1, 2. No, no working. Is it? One, two, 1, 2. Okay. So now I change to 45-degree ball probe, please. We have ball probe. And you see that with the 45-degree, I can enter the maxillary sinus and have a vision of the infraorbital nerve coming in front to the anterior wall of the maxillary sinus. And also, I can see the zygomatic recess behind the infraorbital recess. And if I turn the scope down, I can see the alveolar recess over here. And I can remove more bone. I can work easily in these all spaces. Remove all the mucosa. For instance, you have inverted papilloma here, you can work. And if it's anteriorly based, you can remove this mucosa, you see. You can drill the pedicle of the tumor. Curved? Dammi una Harrison. Straight. So I can remove this bone here to gain more space over here. Sì, adesso dammi un attimo una suction. Okay. So you see that the piriform aperture is preserved, the ball probe. And now here I can remove also this part if I need, also lower. C'è qualcosa di curvo. You need, of course, curved dissectors, curved instruments to manage these areas. It's not possible with straight instruments. Okay. You have? Give me.
La corda frontale.
Sì. Dammi la Blackesley. Che è rimasto un po' di osso qua. Bastardo. Dammi. Non ci arrivo. Mi dai troppo, no?
Straight one.
Yes. So I extend a little bit the drilling over here. Lower down this part. So I can remove as needed here the bone. Okay. Good. Then we now give me the curette. Yes. Yes. And now I have better access to all this area. Also the orbit, this is the floor of the orbit. Infraorbital nerve, anterior wall of the maxilla, and all the mucosa here. So of course I can spare the mucosa that is not infiltrated by inverted papilloma. So we do the pedicle oriented surgery. I remove only the mucosa where the tumor is attached. And I can spare all the other mucosa. Okay? So this will be the access. I will not lose time to remove this mucosa. I want to show you after the access what happens. We put again the 0 degree prayer. So once you have done your job inside the maxillary sinus, then you can put back again your mucosa. Okay. So you put back your mucosa with the inferior turbinate and you can stitch this. You can just one stitch is sufficient usually between the head of the inferior turbinate and the mucosa of the piriform aperture. And then you see this mucosa will come also to cover here. And you will have all the integrity. And of course, we do middle anthrostomy because we want to check post-operatively if any inverted papilloma will recur. And we do this with flexible endoscope from the anthrostomy. But you see, the patient will seem that has had only an FES approach. Okay? So once we have done with this approach, we can extend the approach and do the classical medial maxillectomy. I need the scissor, please. I widen the space. So this is the cutting of the mucosa. This is the nasolacrimal duct. Give me the frame, please. Oh, I have it here. So when we cut the nasolacrimal duct, we want to get it free from all the bony boundaries around, and we want to cut it and leave some millimeters in order to avoid the stenosis from the scarring that will form at this level. So when we cut, sharp cutting, just one cut, and leave some millimeters below the sac. Okay? So this will prevent stenosis of the nasolacrimal duct. Now, we can complete our medial maxillectomy by doing the inferior cutting of the mucosa. Let me free. And at this point, we reach the area of the sphenopalatine artery, okay? So we will have here above one centimeter from the tail of the middle turbinate, we will have the palatine bone and the ethmoidal crest, which is the landmark to identify sphenopalatine artery. So I do an incision. I have to find the superiosteal plane like this. C'è un altro più sottile. Smaller freer, please. Oh, okay. This one. Okay, now you see this is the landmark. This is the ethmoidal crest, okay? So the palatine bone will have an orbital process going to the orbit and a sphenoidal process going back to the sphenoid. And where you have the ethmoidal crest, you will have the exit of the branches of the sphenopalatine artery. We can see we have this branch here already coming out, and these are branches that go to the inferior turbinate, and then we will have branches going to the middle turbinate. Okay. So now that I know there is my sphenopalatine artery, I can complete the cutting of the tissues of the inferior turbinate and the medial wall of the maxillary sinus. And I stay in front of the eustachian tube, of course, Blakesley. And now I have exposed posterior wall of the maxillary sinus. I have my sphenoid sinus here. So the region I want to reach is this area. So I have to remove the tissues that are in front of me, okay? So I will remove the middle turbinate for this purpose. We don't need it anymore. So we do the cutting in the common lamella and then the posterior part. As you saw, Renuka Bradu, Professor Bradu did this same procedure this morning for the angiofibroma procedure. Of course, you need to coagulate. Dammi ancora la velina. Sì, adesso vi facciamo vedere. Ok. Sorry? So, you see now that we have better access, better view. Of course, it's all on the tailor-based surgery. So I remove what I want to remove based on what I want to reach. So now I will like to expose the pterygoid plates. So I remove the mucosa of the posterior wall of the maxillary sinus. Scissors, please, again. So I can detach all this mucosa. I will drill this ball or remove this bone to have better access. Curved Blakesley. So one thing I try always when I do surgery to preserve this mucosa, because I want to, when I access the infratemporal fossa, I want to put it back. But many times after half an hour, I get very nervous because it comes in front of me, and at the end I remove it. But I always am willing to preserve mucosa. Frontal curette? Frontal curette? Yes, thank you. Okay, let's put it like this. Now you can see nicely the infraorbital nerve coming along the floor of the orbit from the inferior orbital fissure over here. Okay, our sphenopalatine. Okay. Now I need cutting, straight through cutting. So now I remove this part of the maxillary wall, or posterior maxillary wall, retromaxillary part. Blackesley, please. Blackesley. Okay. Harrison, please. Okay. Okay, just a little bit of cleaning. And now we have our nice view. Prayer. So here is our sphenopalatine artery. It's a little bit higher than usual. Usually comes quite behind this ethmoidal crest, but sometimes can be superior to that, okay? And you see these are branches for the inferior turbinate, okay, going down. We will have branches for the middle turbinate, branches for the superior turbinate, and then, as Mario told you, we will have the branches that goes to the septum, which are important for our Haddad flap, okay? So now, if I go just behind this level and try to dissect a little bit, it's we do it better now. I can see the Vidian artery, which will be the projection over here. So to do this, I need to remove the bone over here. Vediamo via tutto. Vai, 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 vai. Okay. So an important thing to remember when we remove the bone of the medial wall of the maxillary sinus in the posterior part, you will encounter the descending palatine artery, okay? And you may have bleeding from this part. So if you don't have a good exposure, coagulation of the descending palatine can be tricky. Okay. Right. Okay. Right. Okay. Gentle. Okay. Go. 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 Go a little bit. Go. 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 Ancora un po'. Okay. Blackesley, you have straight Blackesley, please. chisel. So we have still this part of the palatine bone here. I gently do the fracture over here in the posterior wall, where the junction of the posterior wall of the maxillary sinus goes to the palatine bone. Right? Piano, piano, piano. Right? Right? Okay. One more. Right? Right? Ancora un po'. Of course, in live surgery, you heard before, we do this by drilling, okay? It's not safe to do this by chisel. Right, right, right. In the dissection, you save some time. Okay, by doing this with chisel, and you don't have dust and powder in your surgical field. Let me okay. So you see now I expose the descending palatine artery over here. I will cut this small branch to remove the bone that was passing through. Okay. So I have less bone over here. So inside here, I will have my descending palatine artery. Okay, you can see this? So I will have in front palatine bone, and posteriorly I will have the pterygoids, okay? Medial pterygoid plate, and behind here I will have the lateral pterygoid plate. And this is the descending palatine artery. Posterior to that, I will have the greater and lesser palatine nerves. Okay? Dammi una citelle. I can extend the approach a little bit medially by removing the posterior wall of the maxillary. I put the kerison inside. I push the periosteum to elevate, and then I grasp the bone. It's better not to open the periosteum at this point. So try to preserve the periosteum, the periosteal bag. Inside this part, you will have fat. You will have the distal portion of the internal maxillary artery that will give you all the terminal branches, okay? So the main terminal branch is sphenopalatine artery. Then you will have the descending palatine artery going down, 90-degree down. The branches of the sphenopalatine artery for the turbinates, for the septum. And then we will have Vidian that we will see in a minute, and palatovaginal before, and then Vidian artery. These are the terminal branches of the internal maxillary artery. So this is the approach if you want to also access the infratemporal fossa. More lateral you need to go, more you have to drill the anterior portion of the piriform aperture, okay? So because you see this bone will give me medial, will give me some limitation to move. So if I want to reach this area, you see I have blockage here. So I need to drill this bone to have a control of the lateral part of the infratemporal fossa. So here we will have the periosteal bag, we will have fat inside, and then the maxillary artery. So now you can see here the descending palatine artery. If I go from this side behind, I can find the lateral part of the pterygoids. I can dissect this. So this is the nerve, you see, palatine nerve. Small scissor going top. No, it's okay. Thank you. Of course, it's very difficult to identify some structures when you are doing live surgery. For instance, the palatine nerves, I think it's not so easy to identify. And then behind, we will have the ganglion, sphenopalatine ganglion. So medial pterygoid, lateral pterygoid, over here. You know that in the lateral pterygoid, we will have the attachment of the lateral pterygoid muscle. Medial pterygoid, we will have the attachment of the medial pterygoid muscle coming from below. Between the two, we will have tensor veli palatini muscle, okay? Then the other muscle is the levator palatini muscle that follows the tube and goes up to the skull base, okay? So tensor will be vertical, levator will be oblique, going up. So now, if we want to move in this area, we need to sacrifice the vessels over here. So it means that I need to cut the arteries from the sphenopalatine, the branches of the septum. I need to cut the descending palatine artery so I can expose the base of the pterygoid. I need to cut the Vidian artery over there. So I have my scissors here. See. So it's very difficult to try to preserve the vessels from this side if you want to work in this space. It's very, very difficult. So this is why if you need some kind of flap, you take it from the contralateral side, okay? So I cut over there. Ce l'hai, frère? Piccolino. Okay. Where is Frere? So you can see now what Mario showed you before. This is the palatovaginal artery coming from the pterygopalatine fossa. I want to show you better. This is really nice view. Okay, because you can see when I push the tissues here, it moves also over there. So usually this artery comes with a small common trunk with the Vidian artery. And then they divide. The Vidian will go straight to the carotid. The palatovaginal will divide and go to the nasopharynx. Chisel? Ok. Vai pianissimo qua, Mario. Piano piano. Vai, piano piano. Ok. I try gently to remove these bones. So the importance to remember these vessels is that many times happens that we receive patients from other hospitals that have massive bleeding, and maybe they had already many different procedures for coagulation, sphenopalatine, etc. And sometimes they have coagulate this artery, and they think they have coagulated the Vidian artery. Okay, so it's important to remember. Also, if you do approaches to the this region, it's maybe you want to know that you have these arteries and not to confound them. Okay, so I will. Okay, so here I try to dissect, and you see, this is the Vidian, okay? That is below the crest Mario showed you before. So you see there is a small common trunk. One will divide, go to the nasopharynx, and one will go to the Vidian. Now we can cut this part, small scissors. Thank you. So now we'll get access to the base of the pterygoids like this, okay? This is why we do all this. If we want to access the cavernous, we need to access the base of the pterygoid. Voy a tagliarlo ancora un pochettino. Sì? Vai? Poco? Ok. Vai poco? Ok. Facciamo questo, vai. 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 Ok. Vai ancora un po'? Vai. Ok. Oh, nice. Dissect, freer, small one. Okay, you can see here now the anatomy. Okay, you see the Vidian going there and the palatovaginal going down. Okay? Small scissor. Small scissor. So now I cut the palatovaginal artery. I have my space. Okay. Tap, tap.
Chisel and hammer.
This is palatovaginal. So now I can remove also this bone over here. Go. Okay. Of the basis sphenoid. Right. Okay. Right. 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 Okay. One more. One more. Okay. Black sleep, please. Okay. Really nice. This specimen is fantastic. One of the best specimens I have ever seen. They're really fresh. Okay, so Vidian. And we saw the CT scan. Also, Mario showed you that the pneumatization is not so good of this sphenoid sinus. So the lateral recess is not so big. And when this happens, we will have the condition that the foramen rotundum will be close to the median, okay? So if I go lateral to this and I dissect these tissues, this is greater wing of the sphenoid, okay? And if I dissect these tissues, I will find foramen rotundum, okay? Over here. May I remove this bone a little bit? Dammi. Vai, piano piano. Vai, piano piano. Vai, piano piano. Vai. Piano. Piano. Vai. Ok. Ok. On the other hand, if you have a very big pneumatization of the sphenoid, of the lateral recess, then V2 will be very far away from the median. Okay. So this is V2 over here, I think. Troppo alto lì. This is questo qua. This one. Sì, però non è pneumatizzato. Anche lui è. Non può essere lì. Ok, poi lo vediamo. Guarda che arriva da qua. So the projection of the infraorbital nerve will be here, okay? You see? This is rotundum. Then we will clean this area just in a minute. So I want to cut now the inferior part. No, dopo. Scissors, please. Small, yes. So I cut the descending palatine artery now to expose completely the pterygoids. Do you have a curved scissor, small scissor? Okay. So now I put the tissues over there, but you see that the median keeps me ligated here. So I have to cut the median. Otherwise, I cannot move. So I will cut the median. Small scissors for these areas. Okay. Let me falcato. Sickle knife, please. Okay, so you see this is the Vidian cutted and the Vidian canal. It's a quite wide Vidian canal. Eh? Okay, now I can push the content of the pterygopalatine fossa. This is pterygopalatine fossa. Infratemporal fossa will start lateral to the infraorbital nerve, an imaginary line that divides pterygopalatine fossa to infratemporal fossa is the line passing through the infraorbital nerve. Okay, I will leave the infraorbital nerve. Now you can see the infraorbital nerve coming from out from the rotundum, foramen, V2. You see the relationship between median and V2. So if you have pneumatization, this distance will be very, very higher, because in the between of them, you will have air cavity. So the median will be at the base of the pterygoid as always, but the V2 will be at the level of the floor of the middle cranial fossa. Okay? So between will be a very big space. So now you see I can expose the greater wing of the sphenoid over here. Here I will have the attachment of the middle pterygoid muscle. And if I dissect the muscle, this is the artery probably. Mario now will hold it for me a little bit. I try to dissect, because hopefully this is the vessel. Internal maxillary artery. Big one. Big vessel. You have the small scissors, please? No, non strapparmela. Sì, ma solo il grasso. Aspetta, non strapparmela. Devo disseccarla. So Mario is trying to pull some fat out. And I try to dissect. Okay. To expose it. So now for the purposes I will cut. You know that the maxillary artery comes behind the lateral pterygoid muscle. Terminal branch from the external carotid artery. Okay, no, my dissector over here. So I will cut this part here because I want to show you the V3 if I'm able. I will try to preserve V2, of course. Okay. There's big scissors, please. Ok. Fammi vedere il video, due dietro. Vado di qua. So I see where is the nerve and I stay here below to remove all these tissues. Okay. We have it? Yes, Mario? Yeah. Okay. Bisogna rimuovere un po' di tessuto qua, fare quella roba lì. Scissors? Sorry? Yes? Yeah. You can put, please. Thank you. Okay. Go. Nice. Okay, now. Oh. Sickle knife, please. Okay, here. I cut the periosteum of the floor of the middle cranial fossa. So here we will have an inferior orbital fissure, as Renuka showed you this morning, taking off this big angiofibroma. Really enjoyed this surgery, the FREER. So now you see this is the lateral pterygoid muscle that is attached at the lateral pterygoid plate. So once I dissect it from this part, I hope I will be able to find just posterior of the lateral plate coming out V3 from foramen ovale. And Professor Castelnuovo showed you this afternoon. Very nice lecture with all these landmarks. Okay. Can you give me the curette, the ethmoidal curette, please? Huh? Sì, sì, sì. Okay, you see, this is V3, V3. And you have a bigger dissector, please, the Freer one. Okay, I want the other one. Yeah, maybe this one is better. Spetonata. Okay, so you see V3 and foramen ovale and lateral posterior a little bit to this. We should find foramen spinosum with middle meningeal artery. The problem is I have this bone here. So if I don't remove that bone, it will be very difficult to show you middle meningeal artery. Have something curved.
Scusa, quella creta fa di filosofi.
See, let's move the. Let me tap. I just remove it. Renuka is okay with you to show this? Yes? Okay. Go. Go. Yes, yes.
What time is it?
How much time? Okay, okay, finish this and then, okay. Kerson?
At least some idea of how to do it.
Okay.
So now 10 minutes of this one and 10 minutes of this one and 20 of transorbital.
Okay, so I go.
So I have requested them to show us a little more of this and then to show us, give us a brief idea of transorbital approach to the middle cranial.
The middle chisel. Chisel?
Okay.
A little bit. Okay. Carrison, please. Oh, nice. Outside. And this one. Okay. Dammi una mano qua. Vai. Sì. Vai. 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 Okay. Okay. So now I take again the dissector over here. Now I have more space probably, and maybe I will be able to show you also this. I would like to show you this. Rare? I like very much this anti-fog solution. It really works very good. Dov'è? Eh? It's really fresh. This specimen. Bigger is prayer. Non so se lo riusciamo a trovare. Okay.
That is more, but it is
Okay, you see here behind? Should be over there. Suction. Dimmi un attimo. Okay. So now I think it's over here, posterior to this. Very small, where my tip of the instrument is, like here. Unfortunately, there is some blood.
Okay.
You see? This one. Okay.
Middle meningeal.
Now I just will make 10 minutes of removing this bone to show you the nerves inside the cavernous, and we do the orbital, okay? Chisel. Okay, so V2 is the limit of cavernous sinus. Wait, Mario. Wait. So we have done many dissections with Mario, so we are quite in sympathy to do this thing. Right. Right. Okay. Right. 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 Of course, again, we don't do this with chisel in live surgery. Eh? We use the drill. Right. Piano, eh? Right. 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 Ok. Ma perché qua sei fratturato come sempre qua? Mm. Ma perché quando sei fratturato male qua, vai? Piano? Piano? No. Ma adesso è bloccato lì. Vedi? Si è fratturato male là. Vai? Sì. Vai. Ok, correct. Ce l'hai un ethmoidal. Okay, we expose the cavernous sinus. So cavernous sinus, you know that will be then in communication with the orbit, with the superior orbital fissure, and you know that all the nerves will pass from there. Always happens this to me.
Oh,
Okay.
nice. This is floor of cavernous.
Floor of cavernous, you see? Okay. Wow.
Oh, nice. The Syrian.
Okay. So this is also the front door to Meckel's cave, as has been described from Pittsburgh group, okay? So this is the cavernous, floor of middle cranial fossa, V2. We remove this bone here again. Dummy, tap, tap.
Beautifully seen.
Okay. So we remove this bone to show carotid, right? Right. 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 Vai? Facciamo così, fa niente, vai. Ok. Correct. Dami flare. Small flare, please. Huh? Harrison, please. Okay. That's good. I want to expose as much as possible to show you better the landmarks and the structures. Optic nerve is over there. Non ce la faccio più. Ok, fammi tirar via quell'osso lì. Chisel. Chisel. Gisellino. Yes. Ok. Vidian. Vidian. Vai, vai. Vai, vai. Vai, vai, vai. Okay. Vai. 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 Okay. Vai. Ok. Vai. Attento che c'è la carotide dietro. Vai. Ok. Vai. Vai. Ok. Vai. Piano, eh. Vai. Gently. Gently. Vai. Vai. Go. 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 Okay.
Et mother correct?
Correct. Give me chisel, please, again. Chisel. Vai, seguiamo il video. Vediamo. Vai. Vai, via. Ok. Vai. This is the cancellous bone of the basis sphenoid. Right. I want to show you the Vidian entering the carotid. Right. Okay. Right. Right. Better. Right. Okay. Right. 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 Okay.
Beautiful.
So carotid, paraclival carotid. Rear. Sorry. The Vidian going to the genius, the carotid over there. I will not lose time to show you this, but you can see that the direction is over there. I want to open the cavernous now to see the nerves. Give me sickle knife. Okay. So now you can appreciate V2. Give me. Oh, this is okay. So V2. Okay. If I go over here, we can see V3. Maybe with give me the curette, frontal sinus curette, please. Look. So if I elevate here, I can show you from above V3. Okay.
Yes.
This is V3.
Yes.
And
yes.
we saw V3 from here. Okay. This one.
Yes.
Over here.
Yeah. Well
okay?
seen.
V2. Then we will have V1 above. So I open the cavernous. The safest point to open the cavernous is above V2. If I open it between V2 and V3, I will have entered the temporal lobe, okay? And I will reach the Gasserian ganglion. So I stay above. Do you have another sickle knife? This is not good. I show one before, please. Yes. Okay, this is better one. Okay. Sure. So this is the medial wall of the cavernous. This is the dura of the middle wall of the cavernous. I stay above the V2, you see? You don't have to apply a lot of pressure because sometimes in the cadaver, the structures are very adhesed to the this part, and you may cut the nerve or something else. So you don't want to do this. Okay. I want to open the dura here. Dammi un dissettore magari. Tieni il sickle knife per favore, che non voglio tagliare. Okay. Small scissors, please. Yes, straight. Va bene. È fresco. Okay, carotid. Anterior
Yes,
genius of the
please, sir.
carotid. Ophthalmic artery, but very strange.
Ophthalmic artery.
Very strange. Maybe it's a variant. I don't know. I will see. Like Castelnuovo show you, because we are below the dural ring. So ophthalmic artery should origin above the cavernous sinus. So once the carotid has passed through the distal and proximal dural rings. Small scissors, please, again. So this is the 6 over there, I think. So if I go back here, I will find Dorello's canal. And the 6th nerve, this is the 6th nerve. It's coming from behind. And enters the cavernous sinus from behind of the carotid. Also here I will have the meningoepiphyseal trunk with inferior epiphyseal artery, Bernasconi casinari artery, and dorsal meningeal artery. I want to see if I can show you this. It's nice usually. Not so easy. So let's see the nerve, 6th nerve, 6th cranial nerve. Let me the scissor. Not cutting. Have a different scissor, please. Okay. Sì. So you see, the 6 is the only one that is inside the cavernous.
If you could just point out the paraclival, carotid, and paracellar ones properly.
Sorry, Renuka?
The paraclival, carotid, and the paracellar.
Paraclival carotid and paracellar carotid.
Yes.
This is lateral wall of the cavernous. I want to see if I can find to show you the third and the fourth nerve that are on the wall. Let's see if we are able to identify these nerves. Are you sickle knife, please, again? I want to release this. Okay. Huh?
Exactly at this level of the lateral wall of cavernous sinus, we can approach also with a transorbital approach. We can reach the same area externally with a transorbital approach, because this is also called meningo-orbital bend.
So you see, this is maybe 3. Third cranial nerve. This one. Big one.
Yes.
Okay. Below, you will have fourth cranial nerve, which is smaller. I want to show you if I'm able.
Yes.
It depends from the disease, because, for example, when we have a pathology which involve the medial wall of a cavernous sinus, I mean, for example, a cavernous sinus, a pituitary adenoma with invasion of cavernous sinus that come from medial to lateral, it's better to approach from a transnasal approach. Conversely, in other pathologies such as spinoorbital meningioma, which may invade the cavernous sinus at the level of a lateral wall, we approach on opposite side. We approach using the endoscopic assisted transorbital approach. It gives us a direct view on the lateral wall of the cavernous sinus.
Okay, you see? I think this one is 3. And this one is 4. You see 3, the
Yes,
bigger one?
Yes. Yes.
Okay. 4 is the smaller one. And you see that they cross 4 will cross third nerve. 6th nerve, V2, and most likely this will be V1. Okay. This one.
Yes. If you could just once more point out V1, 2, and 3.
The V1,
V1,
2,
2,
V3?
and 3.
Yes. Okay. So, sickle knife. So, this one, the bigger one, will be the V1. You see these fibers over here?
Yes.
And this will go to the superior orbital fissure. This nerve will go to superior orbital fissure is together with 6, 3, 4. Okay? Then
Yes.
you will have V2. V2 will go to foramen rotundum, will enter the pterygopalatine fossa, and there will go to inferior orbital fissure, and along the floor of the orbit will reach the anterior wall of the maxillary sinus and will exit to the cheek. Then, third branch, V3, will go down and pass through the greater wing of the sphenoid in the foramen ovale, and will enter the infratemporal fossa, and then will divide in anterior and posterior branch, and will give the alveolar nerve and lingual nerve. Okay, so
Just point out the Gasserian ganglion, please.
yes. So Gasserian ganglion will be where all these meet. I can open this dura over here, and if I open the dura between these three branches, we can appreciate this, I think. Yes, to cut. So the problem is I left this bone, and I left this bone to do quickly, so I have some limitation of my movements. So this is why everybody says exposure is the more than half of the joke of the game, sorry. So you may lose time to expose, to do the approach, but then when you are working in that space, you are not suffering like I am doing now, because I have a very small access. Ah. Cycle. I open this dura between V2 and V3. Okay. Ah. Tagliamo qua, riesci? Tagliarlo questa roba qua. Yes? Okay. All right. Okay. Temporal lobe.
Yes.
So this is V1, V2, Gasser here, V3.
Yes. Beautifully seen. Beautifully seen.
Okay.
So we have a choice.
Sorry? Quarter?
To see only the approach, 10, 15
See, 10-15 minutes.
No, not to see everything, only the approach.
The approach and the structures inside. We see optic nerve and anterior, medial, anterior, posterior. Yes, 15 minutes. Okay, okay. Lo fallo tu? Ok.
Immediatamente per spostare.
Eh? No, ce l'abbiamo.
You have the scissors, please, so we open.
We will have a late dinner.
Yeah, let's do left.
You don't mind. Neither do I. And neither do all these people who are waiting till much later than the scheduled time.
Tomorrow in the lecture, I will show you also anatomical video with all the
Okay,
steps of
you have some water, please, to inject with the needle.
very easy. But we show you the initial part of a transorbital approach with the incision at the level of a superior elite, okay? And the identification of the first landmarks. After that, we have to drill out a lot the bone of the greater wing, and there is no time in order to drill out the bone and expose superior interorbital fissure and the dura of anterior and middle cranial fossa. But at least the very initial part can be done. So, knife. This is the eyeball of our patient, and usually we try to keep advantage of a crease of a superior eyelid in order to make hidden the incision, okay? Okay, in order to make hidden the incision, if you can hear me now. You have to hold for the incision.
Yes, can you?
Okay, 1, 2, 3, it's good. And so, in this crease, okay, of the superior lid, that's why in this way, when the patient has the eyeball open, it's not visible. And so it's very cosmetic incision, okay? And then the other things is that we have to identify the lateral bony rim. So in this maneuver, it's important to perform the incision and cut skin, subcutaneous tissues, and preserve the levator palpebrae muscles. It's important because we have to prevent problems in the palpebral apoptosis. We have some pickup. Yeah. You see, I'm cutting the skin, the subcutaneous tissues, and also I'm cutting the orbicularis muscles, but I'm preserving these blue, this different color and different different direction fiber, because the orbicularis muscles have horizontal fiber, orbicularis muscle, and we can cut horizontal fiber of the orbicularis muscle. Okay. Conversely, levator palpebrae muscles has vertical fiber. Okay, so it's quite important to preserve this one, which is levator palpebrae muscles, and we have to slide just over the aponeurosis of the
like this
of the levator palpebrae. Okay, you have to slide on this aponeurosis. Okay, we can cut just a little more laterally the skin. Okay, and so in this way, sliding at the level of the levator palpebrae muscle, which should be preserved, of course, we identify the lateral bony rim. Okay, lateral bony rim that should be identified and preserved. Lateral bony rim have a very important cosmetic aspect. That's why it should be identified. And usually when we start drill out the bone, we keep in place a small part of this bony rim, because it's important for the cosmesis of your patient. Okay? We have to identify the subperiosteal plane here in this region. Okay. Give me a sort of prayer, small. This is the bone. I feel the bone just here. Okay. And now I would like to expose you just a little better the bone. Okay, you can see this is the bone of the, okay, the bone of the rim. And now I cut just a little more. It's time to go inside to this bone, looking for the subperiosteal plane. Okay, this is the lateral aspect, no need to go. We have to go medially here inside and enter this plane. You see?
Yes.
This is the subperiosteal plane, and we have to follow this subperiosteal plane in order to perform the approach. In this part, we have to go on and dissect everything here. This is the bone. Of course, during this maneuver, it's quite important to preserve the integrity of a periorbit. Because if you destroy the periorbit, it's a problem because the fat, the orbital fat, will collapse inside to our surgical field. Okay? And so, in doing this maneuver, it's better to preserve the integrity of the periorbit. That's why usually at this point we insert inside a sort of elastic sheet, a sort of silicone sheet, and with a malleable retractor we compress and retract medially the orbit. But pay attention, it's not a fixed retraction, otherwise you can damage the orbital bulb, but it is a dynamic retraction, so we are moving. So inside here we put a elastic silicone sheet and a retractor, and this is very mobile and it's dynamic retraction. Another important thing, once we are at this level, we have to preserve this bony rim for cosmetic issues, and we have to start to drill the greater wing of the sphenoid more or less at this level. And the working space will be gained not compressing the orbital bulb, but removing the very thick bone of the greater wing of the sphenoid. So the surgical room will be created not compressing the bulb, not compressing the orbit, but removing this bone, which is the bone of the greater wing of the sphenoid. Okay, so we have no malleable retraction, unluckily now. Okay, we can use something like this, which is not so malleable, but it's okay. And it's just a little bulky. But we can try. And so with the silicone and the retractor, we have to go on in dissection. Of course, we have to keep in mind to preserve the periorbit. Okay? We are going on with the dissection. You can see. And probably this structure is the so-called recurrent meningeal branch. The recurrent meningeal branch is a very, very small vessels that may run inside the superior orbital fissure or may have a specific foramen, which is called Hirtle foramen, and may run at this level. Of course, it's mandatory to cauterize and cut recurrent meningeal artery. Give me a sort of, okay, small scissor. Okay. So first cauterization, and after cauterization, we cut the recurrent meningeal branch. And now our task is to identify superior and inferior orbital fissure, okay? The working space of our approach will be gained by drilling out this bone. And we have to drill out all this bone until we reach the temporalis muscle, which is the lateral limit of our dissection, okay?
So it's better if you start drilling anteriorly to identify the temporalis muscle.
Okay, so here we have to drill out all this bone I'm touching, okay? Because if you drill out all this bone, you gain a lot of working space, okay? You gain a lot of working space and you reach the temporalis muscles. Okay, after that, this is the recurrent meningeal branch and this is the superior orbital fissure. Superior orbital fissure, it's quite important. Why? Because we know that if we drill out here, just below the superior orbital fissure, we will get access to the dura of a medial cranial fossa, I mean temporal lobe. Conversely, if I gain to drill out here, just above the superior orbital fissure, I will enter into the anterior cranial fossa dura. Just sliding just a little anterior, okay, with the scope, you can see that here we can identify also the inferior orbital fissure, okay? Which is the other landmark for us, okay? Which is this one, okay? So by drilling out between inferior orbital fissure and superior orbital fissure, we get access to the medial cranial base. By drilling out up of the superior orbital fissure, we enter the anterior cranial fossa. Moreover, this approach is really versatile because it allows us also to enter in the frontal sinus. If we stay very, very, very anteriorly, come anterior with the scope, okay, you see that we are working two nostrils, no, sorry, we are working four hands without two nostrils, we are in transorbital.
One orbit.
One orbit, four hands, because we have to hold the scope, the suction, the washing system, so it's important that the second surgeon hold the scope because first surgeon in such an approach have to work with bimanual, okay? And here, anterior cranial fossa, but just anteriorly, you can enter also in the lateral aspect of a frontal sinus. And so you can use this approach also for this. And if we go on with dissecting here and we turn the scope on the other side, we can also see optic nerve, sorry, optic nerve, smaller but it's bigger. We try this one. Give me light. Just above. Okay. To come here anteriorly, we can enter on the frontal sinus. But if you want, we can turn the scope also medially, and we can identify the optic nerve and the ethmoidal arteries. It's important in doing this to preserve the periorbit, but unluckily we have no the malleable retractor, but next time we will bring our malleable retractor in the luggage, not in my luggage, because my luggage usually stay in the connection flight in the airport, but in the hand luggage. Okay. I'm looking for the optic nerve.
So optic nerve will be medial to superior orbital fissure, okay?
A superior orbital fissure. This is superior orbital fissure, you see? And so we are looking for the, but I have to enter with the, give me light here. So, this one, okay.
So once the levator is down,
no risk.
No risk. You can cut. Important is that the levator is down. I mean, on the orbit, attached to the eyeball. Okay.
I try to go with the scope. So, superior orbital fissure. And so, more or less in this area.
Posterior.
Okay, nice. More or less here.
Okay, optic.
We have optic nerve. Okay, here. And turning the scope medially, we can identify posterior ethmoidal artery and anterior ethmoidal artery. And also we can enter in the nose, of course. So anterior and posterior ethmoidal artery and optic nerve. Okay? And superior orbital fissure like this. And so the transorbital corridor is very versatile because give us some different target areas. Just here in front, frontal sinus, up to the superior orbital fissure, the anterior cranial fossa, optic nerve just behind, you see, superior orbital fissure, optic nerve and posterior ethmoidal artery, and between the superior orbital fissure and inferior orbital fissure, we can, drilling out this bone and exposing laterally the temporalis muscle, we can enter in the middle cranial fossa. Okay.
So Professor Castelnuovo says that one finger is inferior orbital fissure, second finger is superior orbital fissure, like a V. Okay. Then you will have optic nerve, posterior ethmoidal artery, anterior ethmoidal artery. Left hand, left eye, left orbit. Right hand, the same, right orbit. Okay. Just to remember.
Okay.
Thank you very much.
Good. Thank you so much. Very nice.
It was a pleasure.
Thank you.
Thank you for your help.
Thank you very much. Thank you.
Thank you.
That was excellent. We really enjoyed it. Thank you so much.
Thank you.
Great.
So now we can have dinner at St. Regis. So we'll meet you at St. Regis for dinner.
Can you take a picture for us? With you, with both of you, of course. Okay.
Can live here?
Here.
Okay. Okay. Thank you. Dove vuoi? Col cadavere?
Yeah.
Okay.
Okay, but it's okay.
Toglili.
It's okay. Okay.
Thank you.
With our friends.
Yes.
That help us a lot.
Good team. Great team.